So good afternoon, everyone. Hopefully the audio visuals are clear. So first of all, welcome to the Remarkable Rapid Revision 2.0. Hopefully all of you have been attending all the revision sessions until now. Let me introduce myself for those who don't know. Myself, Dr. Omkar Sonone. So we will be revising ENT and surgery for the upcoming FMG Jan 2026 examination. And I hope all of you have been preparing quite well for the upcoming FMG examination, right? Hopefully the preparations are going fine. They are on track. Okay? Don't worry. I'll be sharing the PDF beforehand itself, so it is easier for you. The ENT PDF has been shared already in the groups, in the Telegram group, and the link is in the chat box itself. So make sure you get the PDF from there. Even after the session, I'll share the annotated PDF also. One thing. Second important doubt that a lot of people may have, that will this session be enough? So yes, if you have studied ENT earlier, this session is definitely going to boost up your preparation, one thing. And second important, I'll try to cover and touch all the important high yielding and the previous year topics for FMG examination from ENT, and majority of the questions you'll be able to solve in the FMG or even from the NEET PG examination as well. Okay? So make sure you are dealt there till the end of the session. Okay? Don't skip the session in between. Be there till the end. Any doubts, you can let me know in the chat box. Ask the doubts. Okay? And most importantly, don't worry about the length of the session. It is not going to be too long. We'll be trying to wind up ENT by 5 or 6 hours maximum. Yes, NEET PG questions also I try to touch. Don't worry about that. ठीक है? चलो. Hopefully सब कुछ ठीक चल रहा है. ठीक है? चलो. Don't worry too much about the examination. Now it's the time that you are going to do your revisions. Don't waste a lot of time in procrastination. Don't waste a lot of time thinking about the exam, thinking about the results. This is not the time for that. Now, just make sure whatever subjects you are getting, properly revise them. Take it, whatever you have read until now, just keep on revising it. Solve enough number of questions on a daily basis, 100 questions minimum from the previous year FMG as well as NEET PG examinations. Okay, appear for 2 or 3 grand tests in this last month, and I hope you're good to go for the examination after that, right? Chalo. So let's start with ENT without any further delay, bache. So as I always say, ENT is one of the minor clinical subjects which will definitely give you the best strike rate among all the clinical subjects. And I can assure you this, if you know ENT properly, you may get 90% of the strike rate in the FMG examination also. Okay? Chalo. So in the last examination itself, there was one question completely out of the box, the one related to the uncinate process. Apart from that, all the other questions were pretty much easy and straightforward in the examination beta. Okay? Again, I'm not going to predict. I'm not a person who predicts and who claims things. My work is basically to teach and cover all the important topics. It will cover majority of the questions, okay? But nobody is basically sure. They have said there would be 15 questions of ENT in the examination, but nobody is sure. Sometimes along with integration, the number of questions may increase, sometimes it may decrease, right? So that depends completely on the examiner, how many number of questions he puts from ENT, but majority of the questions from ENT in the examination are doable. Do remember that. Okay? Chalo. So let's start. We know ENT or the otorhinolaryngology, if I talk about, okay, it has 3 parts. First is the ear, second the nose and the paranasal sinuses, and third is the throat. In throat, basically we have the larynx and pharynx beta. So first of all, we'll be starting the revision from the throat, that is the larynx and pharynx part. Then we'll continue further with the nose and paranasal sinuses, and lastly I'll be covering the ear. ठीक है, a lot of people are definitely dreaded or they think too much about the ear part, but make sure the number of questions from ear are going to be there in the examinations, but it is not the entire ENT. Do remember that. There are a lot of other easy topics which you have to focus on also. Clear? So chalo, let's start basically from the throat part. And throat mein we know basically beta there are going to be 2 cylinders. Okay? There are 2 cylinders inside the throat. The posterior longer cylinder which is there beta it is going to be called as your pharynx. The posterior longer cylinder is known as your pharynx, and the anterior shorter cylinder is known as your larynx beta. Okay, so posterior longer cylinder is your pharynx, anterior shorter cylinder is your larynx. Basically, we know that this posterior cylinder called as pharynx, it is continuous with your esophagus or it is continuous with your GI tract beta. But this anterior shorter cylinder called as larynx, this larynx is continuous with your trachea, or this larynx is continuous with your airway or the respiratory tract. समझ गए? So larynx is continuous with the respiratory tract, whereas pharynx is continuous with the GI tract. That is the basic idea. Now if I talk about definitely the first one, that is larynx beta, which is also known as the sound box, right? I want each one of you to be active. Whenever I'm asking questions, please make sure all of you are answering in the chat box. Nobody is going to judge you whether right or wrong. Please make sure you're answering the questions. Okay? Chalo. Now if I talk about basically beta, first of all, larynx, we know what is the extension of larynx. So if they ask you the vertebral extension of larynx, it is usually going to start beta from the C3 and it is going to extend up to the C6 beta. So do remember, if they ask you the extension of larynx, so we know it is going to be from C3 to C6. It starts from the third cervical vertebra and ends on the sixth cervical vertebra beta. Samjhe? Now important is definitely if I talk about the pediatric larynx. Let me know the extension of pediatric larynx beta in your chat box. Let me know what is the extension of your pediatric larynx. The extension of your pediatric larynx is going to be from which vertebral level till which vertebral level? Very good. So we know beta that the pediatric larynx is high in position, and that pediatric larynx is going to be from C2 to C3 beta. Yaad rakhna, the pediatric larynx is higher in position and it is going to be from C2 to C3. That is what is important. Another previous year question from the FMG examination, and that was, what is the narrowest part of the pediatric larynx? Let me know in the chat box. Again, basically beta. Beta, whatever I use basically, that is going to be my slang. Okay? You may have to definitely bear with it. Okay? So that is what is important. So do remember, if they ask you what is the narrowest part of the pediatric larynx, all of us are quite aware that in the larynx definitely we have three parts. The first one is known as supraglottis, second is known as the glottis, and third one is known as the subglottis beta. Now we know glottis literally means our true vocal cords. Barabar? Glottis literally means our true vocal cords. All the area above that is known as supraglottis. All the area below that is known as subglottis beta. Okay? So supraglottis, glottis and subglottis are the three parts. Out of them, very good. If they ask you what is the narrowest part in the pediatric larynx, if they ask you what is the narrowest part in the pediatric larynx, answer is definitely subglottis beta. Okay? Answer is definitely subglottis. Hopefully clear to all of you now. So these are the points that you need to remember. Clear? Sure. Next important, if I talk about now, larynx, we all know that larynx is made up of two things beta. One is the cartilages and second are the muscles beta. One is going to be the cartilages and second is going to be the muscles that you have to remember. If I talk about the cartilages first, so we know the laryngeal cartilages are going to be of two types beta. One is the unpaired cartilages of larynx and second is the paired cartilages of larynx. Clear? One is the unpaired cartilages, second are the paired cartilages. Unpaired cartilages of larynx are going to be three of them. First one is the thyroid cartilage, second is the cricoid cartilage, and third is the epiglottis. Okay? Unpaired cartilages are going to be three of them. First one is the thyroid cartilage, which is considered as the largest cartilage of larynx. Below that, cricoid cartilage, which is a ring-like cartilage beta. Below thyroid, we have another ring-like cartilage called as cricoid cartilage. And third is epiglottis. Epiglottis cartilage is present inside the larynx, and this epiglottis controls the opening and closing of laryngeal inlet. Okay? The opening and closing of larynx is basically controlled by this epiglottis cartilage beta. So these are the three unpaired cartilages of larynx. If I talk about the three paired cartilages, The first one is known as arytenoid cartilages. Second ones are called as corniculate cartilages. And third one is known as cuneiform cartilages. The first one is arytenoid. This arytenoid cartilages are pyramidal cartilages or triangular cartilages, you can say, and they make the posterior 1/3 of the vocal cord, right? Anterior 2/3 of the vocal cord is membranous in nature, but posterior 1/3 of vocal cord, which is cartilaginous in nature, is made by these arytenoid cartilages. Second important, the corniculate and cuneiform cartilages. Both of these are rudimentary. They do not have any functional value. बेटा किसी काम के नहीं होते. Clear? Corniculate and cuneiform cartilages, they are rudimentary in nature. They are having no functional value. Clear? So that is what is important to be remembered. The first thing now, if I ask you, this was a previous year question from FMGE exam. Which cartilage does not ossify with age, beta? Which is that cartilage which does not ossify with age? Elastic or hyaline in nature? Let me know one thing, that which cartilage does not ossify with age? The elastic cartilages or the hyaline cartilages? Very good. So we know, beta, that elastic cartilages are the ones which do not ossify with age. The elastic cartilages do not ossify with age. Hyaline cartilages, on the other hand, they ossify with age, beta. Those hyaline cartilages, they ossify with age, they become harder with age, beta. But elastic cartilage never ossifies with age. It always remains soft throughout life. In any age group, you will find elastic cartilage have never been ossified, beta. Clear? And we know the main cartilages which are elastic in nature, very good, it is going to be your epiglottis. And this was the previous year question in the FMJ examination. Which among the following is an elastic cartilage, they asked you, and the answer to that question was epiglottis. Why? Because epiglottis is an elastic cartilage in nature. As epiglottis is elastic basically, beta, therefore it never ossifies with age. Clear about? Do remember. Apart from that, even corniculate and cuneiform cartilages, they are also elastic in nature, beta, but as they are rudimentary, they are not considered very important. So do remember, the cartilage which never ossifies with age is elastic, and that is mainly epiglottis inside the larynx. Another question, which cartilage makes posterior 1/3 of the vocal cord? This I have already told you. We know that the anterior 2/3 of the vocal cord which is there, beta, it is going to be membranous in nature, whereas the posterior 1/3 of the vocal cord is cartilaginous. The anterior 2/3 is membranous, but the posterior 1/3 is cartilaginous, and that is made by these pyramidal cartilages called as arytenoid. Shabash. These posterior 1/3 of the vocal cord, it is made by this triangular or the pyramidal cartilages, and that is nothing else but called as your arytenoid cartilages. Understood? So that is what is important. Next, we know that each and every organ is going to have an epithelial lining. हर एक organ के अंदर एक epithelial lining होती है बेटा. तो please tell me the epithelial lining of larynx is going to be. Okay, this is related somewhat to the previous year anatomy question. In previous year examination once, they asked about what is the epithelial lining of the respiratory tract or the airway. And we know, as larynx is part of the airway or it is the part of the respiratory tract, it has the same lining, beta. Very good, shabash. So the epithelium of larynx which is there, it is nothing else but ciliated, pseudo-stratified columnar epithelium, shabash. So it is going to be ciliated, pseudo-stratified columnar epithelium. Ciliated because definitely it is going to have, okay, it is considered ciliated because it has those hair-like projections known as cilia. Pseudo-stratified means it is going to have only one layer, but that one layer appears as multiple layers, beta. Therefore we call it as pseudo-stratified. एक ही layer होती है, but nucleus के arrangement की वजह से ऐसा लगता है कि बहुत सारी layers है. Therefore we call it as pseudo-stratified. तो ciliated, pseudo-stratified columnar epithelium is the epithelium found in the larynx or in the respiratory tract. We know the whole larynx is lined by the columnar epithelium except one part. Very good, all of you. And the only part which is not lined by the columnar epithelium is your true vocal cords, also known as glottis. Clear? So the true vocal cords, also known as glottis, beta, they are lined by, shabash, they are going to be lined by the stratified squamous epithelium. They are lined by the stratified squamous epithelium. Now, a recent NEET PG examination, my question, and that was the virus basically There is a virus which has a very strong affinity with stratified squamous epithelium, or in general with squamous epithelium beta, and therefore it commonly infects the vocal cords or the glottis. Which is that virus? Let me know in the chat box. Which viral infection has a very strong affinity towards the squamous epithelium, and therefore it mainly infects those areas or those organs which are lined by squamous epithelium. ऐसा कौन सा viral infection है जो squamous epithelium को infect करता है very commonly? Shabash. Yes, and this was the recent question in the NEET PG examination, and that is nothing else but HPV, that is your human papilloma virus. So do remember, human papilloma virus has a very strong affinity towards squamous epithelium. That's the reason if they ask you that HPV or the human papilloma virus in the whole respiratory tract, it mainly infects which of the following structure? Answer is going to be vocal cords. Q, because the true vocal cords or the glottis, as they are lined by the stratified squamous epithelium, that's the reason they are very commonly infected with HPV or the human papilloma virus infection beta. Hopefully clear hai? Chalo. So these are the important points that you need to remember. Now we know that the larynx is mainly lined by the ciliated pseudo-stratified columnar epithelium, right? And the vocal cords by the stratified squamous epithelium. What happens is, if a person is a chronic smoker beta, this stratified squamous epithelium in the vocal cords, it starts shedding at a faster rate. जो squamous epithelium होता है vocal cords के ऊपर, वो जल्दी जल्दी shed off होना शुरू हो जाता है. And due to that, a lot of debris or a lot of keratin usually keeps on collecting over the vocal cords beta. Excess keratin, excess dead cells, they collect on the vocal cords. Okay, and that condition will damage the vocal cords, which leads to hoarseness of voice. And this condition is classically known as nothing else but keratosis larynx beta. Barabar hai? So here you are able to see a condition which says a male smoker presents to you with complaints of hoarseness of voice, and the patient has been diagnosed with keratosis larynx. So I have told you what is keratosis larynx. When there is faster shedding of the stratified squamous epithelium, a lot of dead squamous epithelial cells or a lot of keratin usually collects over the vocal cord, and they damage the vocal cord, leading to hoarseness of voice or dysphonia beta. What should be the treatment? Very good, all of you. Shabash. So do remember that if the vocal cord mucosa or if the vocal cord epithelium is damaged beta, तो हमें क्या करना चाहिए? हमें वो खराब mucosa या खराब epithelium को हटाना है, right? We are just going to strip off the vocal cord mucosa or the vocal cord epithelium, and stripping off the damaged vocal cord mucosa or the vocal cord epithelium is classically known as decortication. Stripping off the damaged vocal cord mucosa or the vocal cord epithelium is classically known as decortication. Shabash. That is what is important to be remembered. Along with that, you will also advise the patient to quit smoking beta. Reason, if your patient will not quit smoking, what will happen? Obviously, again, the new epithelium which will regenerate or the new epithelium which will regrow, that will also get damaged. Okay? So along with decortication beta, do remember, you will advise the patient to quit smoking. Okay? So that is what is important to be remembered. As such, keratosis larynx is not considered pre-malignant, but yes, due to chronic smoking, the patient will surely develop a cancer larynx or a glottic cancer beta. Do remember that. Hopefully clear to all of you now. So that is what is important. Samjhay baat? So do remember, we have to remove the damaged vocal cord mucosa or the damaged vocal cord epithelium known as decortication and advise the patient to quit smoking. This is what is the treatment for keratosis larynx. Understood? Chalo. Next, let's talk about vocal disorders beta. Now, when I talk about vocal disorders, before that, you need to know beta, what is the normal voice in an adult male and an adult female. I hope all of you are quite aware that adult male, if I talk about beta, normally an adult male is going to have a low pitch voice or a dull voice beta. Reason, we know that the vocal cords in an adult male are loose. As the vocal cords in the adult male are somewhat loose beta, therefore they produce a low pitch voice or a dull voice. But if I talk about an adult female, do remember, normally an adult female is going to have a high pitch voice or a sharp voice beta. Normally an adult female has a high pitch voice or a sharp voice. Reason, we know adult females will have tight vocal cords And as the vocal cords in an adult female will be tighter, they are going to produce a high pitch voice or a sharp voice. Hopefully you understood this. So normally adult male should have a low pitch voice and adult female should have a high pitch voice beta. But in case if this gets reversed, then that is going to lead to a vocal disorder. बराबर अगर ये उल्टा हो जाता है तो vocal disorder कहलाएगा. So definitely, if I talk about the first case, that is known as puberphonia. Puberphonia is nothing else but when adult male is having a high pitch voice or a feminine voice beta. So whenever an adult male has a high pitch voice or a feminine voice, that condition is known as puberphonia. You might have seen in Bollywood films beta. Okay, बड़ा सा गुंडा आता है but पतली सी आवाज होती है एकदम, right? So definitely remember that adult male having a high pitch or a feminine voice is considered as puberphonia. And the treatment for this condition, now we know, as the vocal cords in this male are tight, that's the reason it is producing the high pitch voice or the feminine voice. So you will advise the patient a speech therapy. What is the name of the speech therapy that we will advise to the patient? क्या बोलते हैं? We advise the patient, whenever you speak, press the thyroid cartilage backwards and downwards. You can see the change in my voice. As I press the thyroid cartilage backwards and downwards, beta, you see that the voice will become more low pitch or the voice will become more dull, right? So that is what is the difference will happen. And this manure, very good. This speech therapy is classically known as Gutsman's manure beta, right? Very good. Shabash. So do remember that puberphonia mein, if the patient comes to you, the first line of management is always a speech therapy called as the Gutsman's manure. So whenever a man is having a female like voice beta, always tell him, hey man, have guts and speak like a man. So this is how you can remember the name. So yaad rakhna that the initial treatment for puberphonia condition is Gutsman's manure when we press the thyroid cartilage backwards and downwards and then we ask our patient to speak. Let's say for 6 months you have tried the Gutsman's manure beta. 6 months tak you have tried Gutsman's manure, but if it fails, that is the patient is not responding to the Gutsman's manure. In those conditions, we have to go for a surgical treatment beta. And that surgery which we do in puberphonia is known as a type 3 thyroplasty. Do remember, thyroplasty is any surgery that we do for the repair of the vocal cords beta. Thyroplasty is any surgery that we do for the repair of vocal cords. There are total 4 types of thyroplasty. In puberphonia, we perform the type 3 thyroplasty where we will do the surgical loosening and shortening of the vocal cord beta. We know now this man is having tight vocal cords. So therefore we have to do surgical loosening and shortening of the vocal cord. You will be like, sir, shorten karne pe how they will become loose? Shortening, that doesn't mean cutting it short. Shortening means decreasing the distance or bringing them closer. So you just have to do a shortening and loosening of the vocal cord, because we know once the vocal cords become loose, we will produce a low pitch or a dull voice beta. Understood? Chala. Next important, if I talk about a condition known as androphonia. Now androphonia, if I talk about, it is when an adult female is having a low pitch or a masculine voice. So when an adult female starts having a low pitch or a masculine voice, that condition is known as androphonia. Now in puberphonia, so you told the male to press the thyroid cartilage backwards and downwards and then perform Gutsman's manure. But in females who are suffering from androphonia, can you ask the female to pull the thyroid cartilage forward and speak? Obviously that's not possible. So there is no speech therapy or no manure that is practically possible for a patient suffering from androphonia. For them, definitely we have to directly go for a surgery. And the surgery that we perform for a case of androphonia is known as type 4 thyroplasty. Do remember, type 4 thyroplasty may we do completely opposite. That is, we do a surgical lengthening and tightening of the vocal cord, right? So again, how lengthening will lead to tightening? Lengthening means increasing the distance. So definitely beta, as you do a lengthening, that will tighten the vocal cords. And these tight vocal cords now will produce a high pitch or a feminine voice beta. Understood? So that is what is important. So do remember vocal disorders mein, if I ask you to remember easily. So do remember, if papa starts having if papa starts having amma like voice beta, that condition is known as puberphonia. If amma starts having papa like voice, that condition is known as androphonia beta. The easiest way to remember. Okay? Hopefully clear to all of you. These are the vocal disorders, easy to remember. Next condition is this. So this was the previous year image based question in FMG examination, which they have shown. So here you can see the patient comes to the ENT OPD beta with complaints of hoarseness of voice or dysphonia beta. Do remember, any condition which will damage the vocal cords, the main complaint or the chief complaint is always hoarseness of voice or dysphonia basically. Okay? A lot of people are confused. What is dysphonia? But dysphonia is same as hoarseness of voice. Okay? Chalo. So that is what is important. So here you are able to see. These are your vocal cords. Can you see? But here the vocal cords appear to be swollen beta. ऐसा लग रहा है ना कि vocal cords सूज गए. So definitely the vocal cords appear to be swollen. That's because of collection of fluid or that's because of the edema. So we know definitely that if this is my vocal ligament beta, if this is my vocal ligament, this is my vocal cord mucosa. Can you see between the vocal ligament and the vocal cord mucosa beta, we are having some space. So this submucosal space or this subepithelial space is known as my Rinne space beta. And in this Rinne space, if there is collection of fluid, that condition is known as my Rinne's edema beta. And due to this Rinne's edema, the vocal cords are swollen over here. You can see there is collection of fluid in this subepithelial Rinne space that leads to swelling of the vocal cord. And obviously, if the vocal cords are swollen, patient will produce a hoarse voice or there will be dysphonia in the patient. Clear about? So Rinne's edema. Please tell me, beta, Rinne's edema is a condition which will always be unilateral or always be bilateral. Let me know. Yes. Rinne's space is the subepithelial space which contains the loose connective tissue, the loose areolar tissue. So therefore, there is more tendency of fluid collection in the Rinne's space beta. Very good. So ये याद रखना बात that Rinne's edema is a condition which is always and always going to be bilateral. Rinne's edema is a condition which is always and always going to be bilateral beta. Rinne's edema is never a unilateral condition. Hopefully clear to all of you. Can anybody tell me another condition in vocal cords which is always and always bilateral? Let me know in the chat box another condition of vocal cord which is always bilateral. Okay? We know that Rinne's edema mein the most common cause is going to be smoking beta. Obviously, smoking is going to damage the vocal cord or smoking will definitely lead to this inflammation or the edema in the vocal cords beta called as Rinne's edema. Okay? Apart from smoking, there are two other factors also. One important factor is LPR or laryngopharyngeal reflex. When a patient is having a prolonged GERD or a long-standing GERD, that is gastroesophageal reflux disease beta, the acid from the stomach comes into the esophagus. But if it is a prolonged GERD, the acid may come up to the larynx and pharynx called as LPR or laryngopharyngeal reflux, which will eventually damage the vocal cords leading to Rinne's edema. And another cause can be vocal abuse as well. Yes, if a person speaks too much beta, barabar, if a patient is abusing his voice, if the person is speaking too much, that is also considered as one of the causes for Rinne's edema. That is what is important. But yes, the leading cause will always be smoking. Okay? Chalo, shabash. Vocal nodules is that another condition beta which is always bilateral. Very good too. Now treatment if they ask you. So we know here there is collection of fluid in the submucosal or the subepithelial Rinne's space beta. तो क्या करना पड़ेगा? हमें इस fluid को drain करना है. And if I want to drain this fluid, yes, I have to strip off the vocal cord mucosa or I have to strip off the vocal cord epithelium. Reason? As we remove the vocal cord mucosa beta, all the fluid from the Rinne's space will be able to drain. And we have just now seen in cases of keratosis larynx also we perform the same procedure. And this procedure where we strip off the vocal cord mucosa is classically known as decortication. तो क्या याद रखना है? There are two conditions in vocal cords where the treatment is decortication. One is nothing else but keratosis larynx and second is Rinne's edema. And obviously along with this, another advice that you should always give to the patient is quit smoking beta. Another advice that you will always give to the patient is quit smoking. Reason, until and unless the patient will not stop smoking, basically the patient's condition will again recur beta. Always remember, वापस हो जाएगी same problem. Clear hai? That is important. Anybody, if the cause of Ranke's edema is LPR or a laryngopharyngeal reflux, which drugs are you going to prescribe to the patient? Let me know in the chat box. अगर ये चीज GERD की वजह से या फिर sorry, laryngopharyngeal reflux की वजह से होती है, then which drug you are going to prescribe the patient? Very good, all of you. Shabash. Yes, we have to prescribe PPI, that is nothing else but proton pump inhibitors. Very good. So if the problem is due to GERD or LPR beta, always prescribe PPI or the proton pump inhibitors, drugs like omeprazole or lansoprazole alongside. Hopefully clear? Shabash. Very good. Next important, if I talk about, here the question states beta, a patient complains of a weak breathy voice beta. Laryngoscopic examination is given below. What is the likely diagnosis? So when the patient speaks beta, a lot of air or breath comes in his voice. Matlab, listen to this now. The patient will have this kind of voice. Can you see? A lot of air or the breath is basically coming in the patient's voice, and due to that the patient's voice is going to be breathy or weak beta. The reason behind this is, we know whenever phonation happens or whenever voice production happens beta, the vocal cords should be in a closed position or the vocal cords should be in an adducted position beta. Barabar? But what is the problem? As in this condition there is weakness of the adductor muscles. As there is weakness of adductor muscles, kya ho jata hai? The vocal cords are not able to close properly or the vocal cords are not able to adduct properly beta. And as the vocal cords cannot close or as the vocal cords cannot adduct properly, there is some gap left between the vocal cords, and this gap which is left between the vocal cords during the speech beta, it is the reason why a lot of air comes in the patient's voice or a lot of breath comes in the patient's voice beta, leading to weakness. And this condition is very good, classically known as phonesthenia. Phono matlab voice, asthenia literally means weakness. ठीक है, तो weak voice, this condition is classically called as phonesthenia beta. Do you remember? This condition is classically called as phonesthenia. That is known as weak voice. And why does it happen? So I have already told you that phonesthenia or weak voice happens whenever there is weakness of the adductor muscles. Okay, yes, adductor muscles like especially the thyroarytenoid muscle and the interarytenoid muscle. When these thyroarytenoid and interarytenoid adductor muscles are weak, vocal cords cannot adduct properly or vocal cords cannot close properly, leading to this weak or breathy voice called as phonesthenia. Anybody let me know, in cases of phonesthenia beta, when you do a laryngoscopic examination, if there is weakness of thyroarytenoid muscle, then I am able to see such kind of an elliptical gap. But if there is weakness of the interarytenoid muscle, then posteriorly we can see a triangular gap beta. But if both the muscles are weak, matlab let's say if the thyroarytenoid muscle is weak leading to an elliptical gap and the interarytenoid muscle is weak leading to a triangular gap, this leads to which kind of glottis very classically? Shabash. All of you are right? Yes. If both the thyroarytenoid and the interarytenoid muscles will be weak beta, the patient will classically have the keyhole glottis. Yes. The patient classically has this keyhole glottis, that has to be remembered. No issues with this. Now, let me know. From surgery, keyhole appearance on ultrasound KUB or on the MCU is a classical feature seen in which condition? Let me know in the chat box. We will try to integrate all the subjects that come across. ठीक है? तो keyhole appearance on ultrasound KUB or the MCU is a classical feature seen in Shabash. Yes, it is a feature seen in PUV, that is posterior urethral valve beta. Posterior urethral valve also gives us the classical keyhole appearance. Shabash. Great, great, great. Now, so do remember phonesthenia mein, there is weakness of the adductor muscles leading to a keyhole glottis and a breathy voice. Therefore, the treatment is nothing else but speech therapy beta. To increase the strength of these adductor muscles or to increase the strength of this thyroarytenoid and interarytenoid muscle beta, you have to prescribe the patient a speech therapy. That speech therapy will help in strengthening the adductor muscles beta. That is what is important. Clear? Chalo. Next, another Sarkari question of the FMG exam, as I always say, okay, and that is this one. So, a trumpet player presents to the ENT OPD with complaints of neck swelling. as you are able to see in the picture, the patient complains of a lateral neck swelling beta. Now they say whenever we press the neck swelling, on pressing the neck swelling beta, a hissing sound is heard. Why? Reason, obviously that swelling may contain some air inside it. So when you press the swelling, the air goes out of the swelling beta, making a hissing sound like, and this is classically known as Brice sign. All of us are quite aware, right? So this is a classical feature of Brice sign. Please tell me what is going to be the likely diagnosis. What is going to be the likely diagnosis? Shabash. Very good, all of you. So we know beta that in the larynx we have two types of vocal cord. One are the false vocal cord, which are nothing else but the mucosal folds, and second are the true vocal cords, which is known as glottis. So let's say these are my false vocal cords, these are my true vocal cords. In between the false and true vocal cord, ये जो space है, this space is known as my ventricle. And from the ventricle itself beta, we have a mucosal outpouching, and that mucosal outpouching is known as saccule. बराबर, the mucosal outpouching is known as saccule. And if there is a increased transglottic air pressure, मतलब the pressure in the larynx is too high for a very long duration of time, तो क्या होगा? Obviously due to that constantly high pressure, the saccule which is there gets abnormally dilated. And when this saccule gets abnormally dilated beta, the patient presents to you with a lateral neck swelling, and that condition is classically known as laryngocele. Very good, all of you. Yes, this condition is classically called as a laryngocele. Do remember, laryngocele happens in all those people who have an increased transglottic air pressure. Whichever patient will have an increased transglottic air pressure or increased laryngeal pressure will always develop a laryngocele. Usually the people who play wind instruments beta. Wind instruments like trumpets, saxophone, shehnai, or even glass blowers, weightlifters, these are the people. But yes, your examiner's classic favorite is trumpet player. Barabar? So that is what is important to be remembered. Clear? Chalo. Now treatment, if they ask you now. If they ask you what should be the treatment in this condition, we know. In this condition, once we have done the X-ray and the CT scan. So you can see on the X-ray, you are able to see this air-filled cystic neck swelling beta. And this air-filled cystic neck swelling, once you confirm on the X-ray and CT that it is a case of laryngocele itself, then you will go for a surgical excision beta. The treatment in cases of laryngocele is nothing else but the surgical excision. That is what is important. Okay? So that is what is important. Yes, beta, you can watch them. No, not an issue. Okay? Hopefully clear to all of you now. Now, yes, somebody has answered it, but still I would like to ask you an integration with surgery again. If a patient comes to you with lateral neck swelling, and when I press the swelling, which makes a hissing sound, we know it is known as Brice sign seen in laryngocele that we have studied. But if the patient comes to you with a complaint of lateral neck swelling, and when you press the swelling, and that makes a gurgling sound, why? Because the swelling contains fluid. So as the fluid escapes out of the swelling, it makes a gurgling sound like this one. This kind of sound is heard beta. This is classically known as which sign and seen in which condition? Let me know in the chat box. We know when I press the swelling, making a gurgling sound basically, it is classically known as Boyce sign beta. Shabash. Yes, it is classically known as Boyce sign. And it is a classical feature seen in Zenker's diverticulum, also known as pharyngeal pouch. Shabash, very good. So when you press a swelling and that makes gurgling sound, known as Boyce sign, seen in Zenker's diverticulum. Shabash. Chalo. Next important is this question. Another Sarkari question. So here the question is, a neonate was brought to you with complaints of an inspiratory stridor. First of all, what is a stridor? So all of us are quite aware. Stridor means a noisy breathing. And stridor always happens due to obstruction of the upper airway beta. So whenever there is an obstruction in the upper airway or narrowing of the upper airway, that leads to this noisy breathing called a stridor. I hope all of you are quite aware. Yaad rakhna. There is an inspiratory stridor when the noise is heard only during the inspiration beta. And that happens whenever there is obstruction at the level of pharynx or at the level of supraglottis beta. So yaad rakhna. Whenever there is obstruction at the level of pharynx and supraglottis, that leads to an inspiratory stridor. Second is a biphasic stridor. Biphasic stridor happens whenever there is obstruction at the level of glottis, that is your true vocal cords, at the level of subglottis, and at the level of cervical trachea. Cervical trachea matlab the part of trachea which is found in the neck. Okay? So if there is obstruction at the level of glottis, subglottis and cervical trachea, that leads to an biphasic stridor. And third is an expiratory stridor when the noise is heard only during expiration beta. And I hope all of you are quite aware, expiratory stridor happens whenever there is some obstruction at the level of thoracic trachea. Whenever there is obstruction at the level of thoracic trachea, that is the part of trachea in the chest or the thorax, and at the level of bronchi, the primary and secondary bronchi beta. Okay? Now you will be like, so ye kyun likhwaya? PDF I have shared in the groups. Please don't bombard the chat box with PDF. You will get my sessions PDF always. Don't worry. Okay? Please find it in the groups. The link is in the chat box also. Okay? Chalo. I don't have any issues with sharing the PDF. Okay? Sabse pehli baat. So inspiratory, which is there basically, inspiratory stridor, it is due to blockage or obstruction at the level of pharynx or supraglottis. Biphasic due to obstruction at the level of glottis, subglottis and cervical trachea. And expiratory due to obstruction at the level of thoracic trachea and bronchi. Okay? The reason I have told you this, because in a previous year examination, they asked a question about the same condition. And they asked you which type of stridor is going to be seen. The answer was an inspiratory stridor. Why? Because this condition is usually going to cause an obstruction or a narrowing at the level of supraglottis beta. Clear है? तो अब क्या है? A neonate was brought to you with complaints of an inspiratory stridor, and this stridor increases whenever the child cries or whenever the child lies supine, and the stridor decreases whenever the child lies in prone position. तो जब बच्चा सीधा लेटता है या रोता है तब स्ट्राइडर बढ़ जाता है, जब बच्चा उल्टा लेटता है पेट के बल तो स्ट्राइडर कम हो जाता है. राइट? What is this classical condition? So we know on examination, if you do a laryngoscopy, on laryngoscopic examination, you will find this leaf-like cartilage called as epiglottis beta. It has become loose or it is floppy. And as it is loose or floppy or it is weak beta, it falls down and makes a classical shape called as omega beta. Very good. Shabash. So we know definitely laryngoscopic examination shows me a classical omega shaped epiglottis, also called as a floppy epiglottis. Do remember, in the examination, if the examiner uses the term floppy epiglottis, they are talking about the same condition. Samjhe? Okay? So, whenever the neonate has been brought to you with complaints of an inspiratory stridor, along with the omega shaped epiglottis or a floppy epiglottis on laryngoscopy, we know classically it is a case of the most common congenital anomaly of larynx. Barabar, the most common congenital anomaly of larynx called as nothing else but laryngomalacia, also known as laryngomalacia. We know that laryngomalacia, Malaysia literally means weakness beta. So laryngomalacia is a condition where there is weakness in the larynx or there is weakness especially at the level of supraglottis. And as there is weakness at the supraglottis or as there is weakness of the epiglottis, this epiglottis falls down, making an omega shape. Second, as the epiglottis falls down, you can see it obstructs or it narrows the larynx, causing an inspiratory stridor. Which is clear about it? That is what is important. We know that laryngomalacia is the most common congenital anomaly of larynx beta. What is the treatment? If a neonate has been brought to you with the complaints of laryngomalacia or an inspiratory stridor, what should be the treatment? Great. Shabash. So if the child is brought to us with complaints of laryngomalacia, the treatment is nothing beta. Yes, we will just reassure the parents. So reassurance to the parents has to be done. You can say no treatment, you can say conservative management, whatever it is, one and the same thing. Clear about wait and watch, reassurance, no treatment, observation, everything is same. Okay? So definitely reason this is a self-limiting condition beta, and as it is a self-limiting condition, the patient does not need any treatment. It will resolve by a span of 2 years beta. Within a span of 2 years, this condition is going to resolve. Now please tell me in the chat box, if this condition does not resolve even after 2 years of age, then what is the treatment that we do? Even after 2 years of age beta, if the child's condition does not resolve or if the inspiratory stridor continues, so batao, what is the treatment that we should do? Very good. The treatment or the surgery that we do beta, if this condition is not resolved even after 2 years of age, has to be repair of the supraglottis beta, and that repair of supraglottis has to be considered as nothing else but supraglottoplasty. Okay, and what we do in the supraglottoplasty, we do fixation of the epiglottis, also called as epiglottopexy. Okay, so do remember the treatment for laryngomalacia after 2 years of age is either supraglottoplasty, also known as epiglottopexy beta. Yes, clear hai? So that is what is important. Next, here you are having a question which states that we are having a school age child who presents to you with complaints of hoarseness of voice along with stridor. On laryngoscopy, viral warts are seen beta. As you are able to see in the picture, can you see these benign overgrowths? These benign overgrowths over the true vocal cords or the glottis. These are your viral warts. So what is the likely diagnosis of this case? I hope all of you are quite aware. When a school age child is presenting to you with hoarseness of voice and these viral warts are seen, it has to be only one condition, and that condition is classically referred to as shabash. It is known as the juvenile papilloma of larynx, or you can call it as the laryngeal papillomatosis. It is one and the same thing. Okay? Either you can call it as the juvenile papilloma of larynx, or you can definitely call it as laryngeal papillomatosis. Papillomas are benign overgrowths arising from squamous epithelium. और हमें पता है in the whole larynx, squamous epithelium is only and only found in the true vocal cords or the glottis beta. So this juvenile papilloma of larynx or these viral warts, they mainly arise from the true vocal cords or the glottis. That has to be remembered. Juvenile means what? So it is common in children who are less than 18 years of age beta. That is the juvenile age group. Most commonly the school age children. Okay, so that is important. So we know that viral warts or these papillomas, they are basically due to which viral infection? All of us are quite aware. They are mainly due to the viral infection known as HPV, that is human papilloma virus beta. They are mainly due to a viral infection called as HPV or human papilloma virus. The low risk serotypes, हमें पता है that the low risk serotypes of HPV are known to cause warts or they are known to cause papillomas beta. But the high risk serotypes, they are known to cause cancers. Barabar? So the low risk serotypes of HPV or the human papilloma virus like 6 and 11. Shabash. Yes, the low risk serotypes of the human papilloma virus like 6 and 11. These are associated with the laryngeal papillomatosis or these are associated with the juvenile papilloma of larynx. Hopefully clear to all of you now. So that is what is important. Now, we know how does this virus entered into the child's larynx or entered into the child's throat. So the history will be what? The mother was having active genital warts during a normal vaginal delivery. Okay? So we know whenever there are active genital warts or whenever there is an active condyloma acuminata, never deliver a child vaginally. Always prefer a cesarean section. Another question of gynae. Barabar? But in case if the child was delivered via vaginal delivery, even though in presence of active genital warts, that leads to this condition later on in life beta, classically known as juvenile papilloma of larynx or the laryngeal warts. Hopefully clear about that is what is important. Now, we know when these warts start growing, the child is brought to us with complaints of hoarseness of voice along with stridor at times. Very rarely, if the warts will grow very rapidly, they may cause a blockage or an obstruction in the airway, which leads to a respiratory distress. Let's say a child suffering from juvenile papilloma of larynx has been brought to us in the emergency or has been brought to us in the casualty with complaints of respiratory distress. What are you going to avoid in this child? We have to manage the child's airway beta, but during the airway management, what should be absolutely avoided or absolutely contraindicated? Very good. Yes. So if the child is suffering from juvenile papilloma of larynx, always avoid an endotracheal intubation beta. Reason is whenever you try to perform an endotracheal intubation, what is going to happen? The ET tube will come in contact with these warts or papillomas and then it will carry the virus further down into the respiratory tract or up to the trachea beta. ठीक है, तो वो जो वायरस है वो ET ट्यूब के साथ साथ नीचे चला जाएगा और do you want that to happen? No. So to prevent the spread of infection beta with the help of ET tube, you are going to avoid an ET intubation or an endotracheal intubation beta. Yes, in a case of laryngeal papillomas or the laryngeal warts. Understood? Treatment. So do remember, in case if the child of juvenile papilloma of larynx is having a respiratory distress, the airway management is done by tracheostomy beta. The airway management should be done by tracheostomy. Hopefully clear. Now if they ask you what is the treatment, so we know these warts are there. We have to remove these warts beta. And to remove these warts, nowadays we use laser. Majority of the vocal cord surgeries are done with the help of the CO2 laser or the carbon dioxide laser beta. So treatment is nothing else but a carbon dioxide laser excision or a CO2 laser excision. And we know the CO2 laser excision that we do in a laryngeal papillomatosis is a type of MLS, that is a microlaryngeal surgery. Okay? What is a microlaryngeal surgery? Microlaryngeal surgery is any surgery done on the vocal cords under the microscope beta. Okay? So definitely this CO2 laser excision, it is a type of microlaryngeal surgery which we do for the treatment of juvenile papilloma of larynx or laryngeal warts. Hopefully clear. So that is important. We know HPV 6 and 11, that is the low risk serotypes, they are associated with warts or they are associated with papillomas beta like the laryngeal warts or the anogenital warts. But the high risk serotypes, that is 16 and 18, they are associated with cancers beta. 16 and 18 are associated with cancers, especially the oral cancer, the laryngeal cancer, the anogenital cancer and the cervical cancer. Okay, oral cancer, laryngeal cancer, anogenital cancer and cervical cancer. The reason being, all these sites are lined by stratified squamous epithelium and all these sites will have a squamous cell carcinoma. Hopefully clear about. So that is what is important. Chalo. Next important, let's talk about another laryngeal infections beta which are more commonly seen in the pediatric population or in children bache. Very common question of pediatrics as well. The first condition we have to talk about is nothing else but called as acute epiglottitis. We know itis literally means infection or inflammation beta. Barabar hai? So acute epiglottitis is a bacterial infection beta which is going to infect the supraglottis or which is going to infect the epiglottis beta. Clear about? So that is what is important. So do remember that acute epiglottitis is a bacterial infection of the supraglottis or especially the epiglottis. We know this condition is very severe beta. Why? Reason? Because any pediatric laryngeal infection will cause inflammation of the airway. And we know if there is inflammation of the airway, there is also going to be edema in the airway beta. Okay? So whenever a child is going to have infection of the larynx, there will be inflammation of the airway or edema in the airway. And if there is edema in the airway beta, that causes narrowing of the airway leading to a respiratory distress. And that is the reason why all the pediatric laryngeal infections are considered as airway emergency. तो याद रखना, बच्चों में अगर कोई laryngeal infection होगा तो उसको definitely बेटा एक pediatric emergency या airway emergency माना जाएगा, because due to the edema of the airway the child experiences respiratory distress. Clear है? Got it? चलो. So now if they ask you which is the most common cause or which is the most common bacteria causing acute epiglottitis, the answer to this question will be very good. A lot of you have answered it already. The most common cause for acute epiglottitis is nothing else but a bacteria classically known as Streptococcus pneumoniae, also known as pneumococcus beta. Yes, the strep pneumoniae, also known as pneumococcus, is definitely the leading cause of acute epiglottitis that has to be kept in mind. Clear? So that is important. Secondly, if they ask you that the child is unimmunized, matlab the child is not immunized or the child is not vaccinated beta, okay, agar tika nahi lega bacche ko, then what is the leading cause of acute epiglottitis? Let me know in the chat box. If the child is unimmunized, then the leading cause of acute epiglottitis will be shabash. Then the leading cause of acute epiglottitis will be HIB, also known as Haemophilus influenzae type B beta. Okay? So don't again get involved in these kind of controversies again. Okay? So just remember, most common cause overall is Streptococcus pneumonia or pneumococcus, whereas in unimmunized or unvaccinated children it has to be HIB or Haemophilus influenza type B. Hopefully clear to all of you now. Now we know whenever there will be acute epiglottitis, the child will be brought to us with complaints like respiratory distress. I've told you, reason, there will be laryngeal edema causing a laryngeal narrowing that leads to respiratory distress. Second, the child will have a high grade fever. Third, the child may present to you with a muffled voice that is also known as hot potato voice. Again, whenever there is obstruction at the level of larynx, the child may have a muffled voice or a hot potato voice. Like the child will speak like this. Can you see? The voice of the child is very muffled. Clear? So this is the kind of voice beta that is known as muffled voice or the hot potato voice, which can be seen in multiple other conditions. One of them is acute epiglottitis. Apart from that, we know acute epiglottitis mein there will be edema in the supraglottic region, and edema or narrowing of supraglottic region will lead to which kind of a stridor? An inspiratory stridor beta, that has to be kept in mind. Apart from that, whenever the child tries to swallow due to inflammation beta, there is excessive pain, and we know pain while swallowing is known as odynophagia beta. ठीक है, निगलते वक्त अगर दर्द हो रहा है, that is classically known as odynophagia. And due to this severe pain or due to the severe odynophagia beta, the child will not even dare to swallow the saliva, and therefore the saliva will keep on drooling out from the baby's mouth. Okay, so there will be a continuous drooling of saliva from the baby's mouth, and you will see that the child will always sit in this position. Let me know the name of this position in the chat box. The child will sit in this position, bending forwards, supporting his body with his upper limbs, and that gives him symptomatic relief beta. What is this position classically called as? Very good. So the child sits in tripod position, which gives symptomatic relief to the child beta. Shabash. Very good, all of you. Now, whenever the child is brought to us in emergency and we suspect a case of acute epiglottitis, always remember, we will go for an X-ray soft tissue neck lateral view. And whenever I take this X-ray soft tissue neck lateral view beta, on this X-ray soft tissue neck lateral view, we are able to see a very classical picture. Can you see? This classical picture is of nothing else but the swollen epiglottis. Can you see? The swollen epiglottis or the edematous epiglottis appears so prominent. And this classically looks like the, yes, Sarkari X-ray in the FMG examinations. This swollen epiglottis classically looks like the thumb sign beta. The swollen epiglottis classically looks like thumb sign. Okay, so that is what is important. This will confirm your suspicion of acute epiglottitis in the child. Apart from that, you can also do a laryngoscopy. And when I do a laryngoscopy beta, on laryngoscopy, I am able to classically see the cherry red epiglottis. Yes, due to inflammation, the epiglottis becomes extremely red, and that is classically known as cherry red epiglottis. So thumb sign on X-ray soft tissue neck lateral view and cherry red epiglottis on the laryngoscopy. These are the classical features seen in a patient suffering from acute epiglottitis beta. Clear yahan tak? Chalo. Now treatment. So we know, as the child has been brought to us in the emergency or the casualty with a complaint of dyspnea or respiratory distress, the first line management or the priority in management should always be the airway beta. Barabar? The first line treatment is always the airway management. Please tell me beta, airway management in cases of acute epiglottitis is done by which method? The airway management in a case of acute epiglottitis should be done by which method beta? This airway will be secured by, very good. We have to secure the airway in a case of acute epiglottitis by an early elective intubation beta. As early as possible, please intubate the child. Reason is, if you delay the intubation, the laryngeal edema is going to increase, and if the edema becomes very severe, then you will not be even able to see the vocal cords beta, and then the endotracheal intubation becomes extremely difficult. ठीक है, तो जितना जल्द हो सके we have to plan out the intubation beta. So an early elective intubation has to be done for airway management in a child suffering from acute epiglottitis. If you delay, intubation becomes extremely difficult. Now treatment. As we all know, acute epiglottitis is a bacterial infection. So the mainstay of management has to be antibiotics beta. Barabar? And as it is a severe infection, always go for nothing else but IV antibiotics in the patient. Along with IV antibiotics, do remember the mainstay of management is always the IV antibiotics basically. Okay? Along with IV antibiotics, you can give steroids. Reason, The steroids like dexamethasone will help in reducing the inflammation or will help in reducing the edema beta. Okay. Next important is you can give bronchodilators, and those bronchodilators are going to be nebulization of racemic epinephrine or nebulization of racemic adrenaline can be given. We know epinephrine is a sympathetic drug, so it is going to cause bronchodilation beta. Hopefully clear. So this is the management of a case of acute epiglottitis. Understood? Chalo. Next important, if I talk about now, is nothing else but another pediatric laryngeal infection called as acute LTB, that is acute laryngotracheobronchitis, also known as croup beta. याद रखना, acute laryngotracheobronchitis means this is the infection of the complete airway beta. The larynx, the trachea, the bronchi, everything is going to be infected. But the commonest site infected is known as subglottis beta, right? The commonest site infected in cases of acute LTB is known as subglottis. Clear about? Acute LTB or croup is a viral infection of the complete airway beta. Okay, acute LTB or croup is the viral infection of complete airway. Please let me know what is the most common cause or which is the most common virus leading to acute LTB or croup. The most common cause or the most common virus leading to acute LTB or croup, very good all of you, has to be the para-influenza virus beta. It has to be the para-influenza virus. Para-influenza virus type 1 and type 2. This is going to be the leading cause beta for a case of acute LTB or croup. Hopefully clear hai tak. Now if they ask you, as it is also a pediatric laryngeal infection, here a 6-month to 3-year-old child will be brought to us beta. Okay. A 6 months to 3-year-old child will be brought to us. And this child will be brought to us with complaints like, first one, respiratory distress. Again, as there will be a laryngeal edema or a laryngeal narrowing, the child will have dyspnea or respiratory distress. Second, the child will have low-grade fever. As it is a viral infection, child experiences a low-grade fever. And lastly, a very classical finding known as the barking cough or the brassy cough beta. So barking or brassy cough is a very classical feature seen in patients of croup or acute LTB. Yes. Along with that, the child may have a biphasic stridor. Do remember, in cases of acute LTB or croup, there will be inspiratory stridor also, there can be biphasic stridor also, and there can be expiratory stridor also. Okay. Commonly, it can be a biphasic stridor because the narrowing mainly happens at the level of subglottis beta. Understood about? Chalo. Now, when a child of acute LTB or croup is brought to you and you suspect a case of croup, always go for an X-ray soft tissue neck. And again, when I go for an X-ray soft tissue neck AP view this time, on that X-ray soft tissue neck AP view, we are able to see a very classical picture beta. On the X-ray soft tissue neck AP view, I am able to see a very classical picture, and that is the narrowing of subglottis. And this narrow subglottis which is there, it looks like the top of a church, classically known as nothing else but the steeple sign. Very good all of you, shabash. Yes, the top of the church is narrow, classically known as steeple sign. So another Sarkari X-ray question in the FMG examination, X-ray soft tissue neck AP view showing you the steeple sign due to the narrowing of subglottis is a classical feature of acute LTB or croup in the patient beta. Clear hai yahan tak? If they ask you what is the treatment, again we know acute LTB or croup is also known to cause a laryngeal edema which can lead to respiratory distress. Therefore, the first line management or the priority in management should always be given for the airway management beta. And for airway management, you can perform an endotracheal intubation if possible. Second, do remember it is not a bacterial infection. As it is not a bacterial infection, antibiotics are not the mainstay of treatment, or antibiotics are not the primary treatment. The mainstay or primary treatment is always steroids beta. Yes. So steroids like dexamethasone are the mainstay or the primary treatment that has to be done, along which will help in reducing the inflammation and reducing the edema beta. Along with that, you can give bronchodilators like nebulization of racemic epinephrine or adrenaline, which will help in bronchodilation and improving the respiratory distress in the patient beta. Samjhe baat? Do remember, IV antibiotics can be given in the management of croup, but not for treating croup, just to prevent secondary bacterial infection. So IV antibiotics if they are given in croup, they are not for the treatment of croup, they are for prevention of secondary bacterial infection, because bachcha immunocompromised hai, so you should not develop any secondary bacterial infection. For that purpose we will give prophylactic IV antibiotics. Hopefully clear hai yahan tak baat. Chalo, so that is important. Now this question which is there beta, related to the nerve supply and the condition, I hope all of you are quite aware that the nerves which are going to supply the larynx, one is the SLN, that is superior laryngeal nerve. Second is the RLN, that is recurrent laryngeal nerve. So superior and the recurrent laryngeal nerves are the two nerves supplying the larynx. Both of them are branches of which cranial nerve? Let me know in the chat box. The SLN and RLN, both of them are branches of which cranial nerve? Let me know in the chat box. Very good. So both SLN and RLN, they are the branches of nothing else but the vagus nerve. Shabash. Both of them are branches of the vagus nerve or your 10th cranial nerve. That has to be remembered. Now do remember beta, we know that here the question is nothing else but a patient complains of hoarseness of voice, and it was found that there is a left atriomegaly or the left atrial enlargement which is causing compression of the left-sided recurrent laryngeal nerve. We know whenever there will be a unilateral vocal cord palsy, it is always the left-sided vocal cord which is commonly paralyzed, and the reason behind that is because the left-sided RLN or the left-sided recurrent laryngeal nerve is longer, and as the left RLN is more longer, it is more prone or it is more at a risk of injury beta. So here they are saying that the left atriomegaly or the left atrial enlargement causes compression of the left recurrent laryngeal nerve, and we know whenever there is a unilateral recurrent laryngeal nerve injury or whenever there is a unilateral recurrent laryngeal nerve palsy, that causes hoarseness of voice. And yes, classically it is known as the Otner syndrome. Yes, also called as the cardiovocal syndrome, but commonly we call it as Otner syndrome, and this was the previous year question in the FMG exam. A very old question but has been asked. Okay, so do remember left atriomegaly causing hoarseness of voice is classically known as the Otner syndrome beta. Hopefully clear. Chalo. Next, another condition is this. Here we are going to talk about the intrinsic muscles of larynx. What is the difference? Understand, all the muscles which are present inside the larynx and are responsible for internal movement of larynx beta are called as intrinsic muscles, whereas all the muscles which are present outside the larynx and are responsible for external movement of larynx are known as extrinsic muscles. Do remember, all these intrinsic laryngeal muscles which are there, basically they are responsible for the internal movement or they are responsible for the movement of vocal cords beta. Okay, now the intrinsic muscles of larynx are more important. They are classified into three groups. The first group of intrinsic muscles is the abductor muscle. Abductor matlab the muscle which will cause abduction or opening of the vocal cord. Okay, the muscles which will open the vocal cord is known as abductor muscle. Second, adductor muscles beta. Adductors matlab the muscles which will cause closure or adduction of the vocal cord. So the muscles which will close the vocal cords are known as adductors. And third, tensor muscles beta. Tensors matlab the muscles which will tense or the muscles which will stretch the vocal cord. Why? Reason, if the vocal cords are tensed or if the vocal cords are stretched, they will produce better quality of voice. So tensor muscles are responsible for better quality of voice. A PYQ, straightforward PYQ in the FMG exam was the only abductor muscle of larynx. Yes, some of you have answered. The only abductor muscle of larynx, if they ask you, answer is PCA. And what is PCA? The posterior cricoarytenoid muscle which is. Clear hai baat? So do remember that the posterior cricoarytenoid muscle which is there, basically, or the PCA muscle which is there, it is going to be the abductor muscle of vocal cord. The PCA or the posterior cricoarytenoid muscle is the only abductor muscle of vocal cord that has to be kept in mind. Clear? Next, there are four adductor muscles that we have, and the four adductor muscles are: one is thyroarytenoid, second is interarytenoid, third is lateral cricoarytenoid or the LCA, and fourth is cricothyroid. Okay? So the four adductor muscles are thyroarytenoid, interarytenoid, lateral cricoarytenoid, and the cricothyroid. These are the four adductor muscles which will close the vocal cord. Now important is, do remember beta, if I talk about the adductor muscles, so three adductor muscles, that is thyroarytenoid, interarytenoid and lateral cricoarytenoid. They are supplied by the RLN or the recurrent laryngeal nerve. But we know cricothyroid which is there, though cricothyroid is an intrinsic muscle of larynx, it still lies outside the larynx beta. ठीक है, भले वो इंट्रिंसिक में गिनी जाती है, but it is an extrinsic muscle that has to be, it is lying outside the larynx. That is what is important. Next important, cricothyroid is the only muscle which is not supplied by RLN or the recurrent laryngeal nerve. Cricothyroid is the muscle which is supplied by ELN, that is external laryngeal nerve, which is nothing else but the external branch of superior laryngeal nerve beta. Hopefully clear to all of you. That is important. Next important, tensor muscles. So we know tensor muscles, the ones which are responsible for quality of voice. The main tensor muscle of vocal cord, let me know in the chat box. The main tensor muscle of vocal cord, which is the muscle that is present outside the larynx, which will stretch the vocal cord and give a better quality of voice. The main tensor muscle of vocal cord, if they ask you the answer to that question, very good all of you. Yes, the main tensor muscle of vocal cord agar pucha jaye, answer has to be cricothyroid. So cricothyroid muscle is considered as the main tensor muscle of vocal cord. Has to be remembered. Clear? Apart from that, the another muscle which is also a tensor is known as vocalis. If cricothyroid muscle is not an option, another tensor muscle or an accessory tensor muscle which helps is known as vocalis muscle. And do remember, vocalis is not a separate muscle. Vocalis is just the internal part of thyroarytenoid muscle. ठीक है, vocalis is just the internal part of the thyroarytenoid muscle beta. Clear है यहाँ तक बात? Very good. Now let me know which is the only unpaired muscle of larynx. We know each and every intrinsic muscle of larynx is a paired muscle. The only unpaired muscle of larynx, if they ask you, what is going to be your answer? The only unpaired muscle of larynx beta. The only unpaired muscle of larynx. Bolo. Let me know in the chat box. The only unpaired muscle of larynx. We know all the muscles are usually present on either sides. There is only one muscle which is exactly present in the center. The muscle which is exactly present in the center between the two arytenoid cartilages. Very good. Yes, it is nothing else but your interarytenoid muscle, which is shabash. So your interarytenoid muscle is the only unpaired muscle of larynx. The interarytenoid muscle is the only unpaired muscle of larynx. That has to be remembered. So this interarytenoid, also called as transverse arytenoid, is the only unpaired muscle of larynx. No, PCA is also a paired muscle beta. Do remember this. Okay, the only unpaired one is interarytenoid or the transverse arytenoid muscle. Clear hai baat yahan tak? Now this to all of us are quite aware, we have discussed it, that all the intrinsic laryngeal muscles beta, they are derived from the sixth pharyngeal arc, except cricothyroid muscle, which is a derivative of fourth pharyngeal arc. So all the intrinsic laryngeal muscles are derived from sixth pharyngeal arc, except cricothyroid, which is a derivative of fourth pharyngeal arc. Isiliye, do remember, all the intrinsic laryngeal muscles are innervated by or are supplied by the RLN or the recurrent laryngeal nerve. All the intrinsic laryngeal muscles, they are usually innervated by or supplied by the recurrent laryngeal nerve, except cricothyroid muscle. We know that cricothyroid muscle, as it is a derivative of fourth arc beta, it is supplied by the ELN or the external laryngeal nerve. And we know ELN or external laryngeal nerve is nothing else but the branch of SLN or the superior laryngeal nerve. Barabar, SLN has two branches. One is going to be the ELN, called as external laryngeal nerve, and second is ILN, known as internal laryngeal nerve. So as cricothyroid muscle is present outside the larynx, it is supplied by the external laryngeal nerve or the ELN beta. Has to be remembered. Hopefully clear hai yahan tak. Now if I talk about the sensory innervation. Sensory innervation means the nerve supply to the mucosa, which will carry sensations beta. We have discussed there are three parts to the larynx, or the three divisions to the larynx. First one is supraglottis, second is the glottis or the true vocal cords, and third is the subglottis beta. Barabar? So sensory innervation to glottis. We know glottis or the true vocal cords lie exactly in the center. Therefore, they are supplied by both the nerves beta. Yes, so glottis gets its sensory innervation from both the nerves. That is, the superior surface is supplied by ILN or the internal laryngeal nerve, whereas the inferior surface is supplied by RLN or the recurrent laryngeal nerve. So glottis is the one which gets the nerve supply from both the nerves, that is the ILN, which is a branch of SLN, and second RLN beta. Supraglottis, we know. Supraglottis, or the area above the vocal cord. PYQ in the FMG examination, they asked you, a patient is experiencing recurrent aspirations and loss of sensations in the area above the vocal cord, which is the likely nerve injured. So we know the sensory innervation to the supraglottis or above the true vocal cords is usually given by the ILN or the internal laryngeal nerve. As I've told you, it is a branch of SLN itself. Hopefully clear. So this has been a PYQ. Next important, if I talk about subglottis. So we know subglottis below the true vocal cords, it is going to get the sensory nerve supply or the sensory innervation from RLN or the recurrent laryngeal nerve beta. Hopefully clear है यहाँ तक. So the glottis by the supraglottis by the ILN, the subglottis by the RLN, and glottis by both the nerves. Chalo, yes, known as the gallon anastomosis. Shabash. Now if I talk about beta, the question over here which states a patient underwent a thyroid surgery, and after the thyroid surgery the patient starts complaining of poor quality of voice beta along with recurrent aspirations. What is the likely cause? We know after thyroid surgery, if the patient starts experiencing these symptoms, it is going to be most likely a case of nerve injury. Okay, important is, please tell me, after a thyroid surgery or during a thyroid surgery, there will be more commonly a unilateral or bilateral nerve injury beta. Thyroid surgery is a common cause of unilateral or bilateral nerve injuries. Thyroid surgery or thyroidectomy is a common cause of unilateral or bilateral nerve injuries. It is a more common cause of bilateral nerve injury. Reason beta, unilateral nerve injuries which are there, their most common cause is idiopathic. Unilateral nerve injuries का most common cause is idiopathic usually, ठीक है, followed by carcinoma bronchus. But bilateral nerve injuries का most common cause is a thyroid surgery or a thyroidectomy. Reason, thyroid is a common relation for both the right sided and the left sided nerves beta. So therefore, if they ask you thyroid surgery के बाद, so patient may have a bilateral nerve injury after a thyroid surgery beta. That is what is seen commonly. Now important is, after this thyroid surgery, patient is having poor quality of voice. Now I hope all of you are quite aware that quality of voice is the function of the tensor muscles or the cricothyroid muscle. If the patient is having poor quality of voice, that means the tensor muscles or the cricothyroid muscle is paralyzed. And if cricothyroid muscle is paralyzed beta, that means there is injury to the ELN or the external laryngeal nerve. Barabar? Due to which the vocal cords become loose and they cause a poor quality of voice. Second important, patient is also having recurrent aspiration beta. Recurrent aspirations happen when there is loss of sensations from the larynx or loss of sensations from the supraglottis mainly. And if there is loss of sensation from supraglottis, that means the ILN or the internal laryngeal nerve has been injured beta. Okay, so what is going to be answer? What is your likely cause? Bolo. What is going to be your answer? The likely nerve injury in this condition will be the ILN, ELN, SLN or RLN. What should be your answer? The likely nerve injury in this condition has to be the ILN, the ELN, the SLN or the RLN. RLN का तो संबंध ही नहीं है. It is not a case of RLN palsy at all. It is a case of nothing else but a bilateral SLN or a bilateral superior laryngeal nerve palsy beta. Why? I told you that superior laryngeal nerve or SLN has two branches, the internal laryngeal nerve and the external laryngeal nerve, right? So it is a case of bilateral superior laryngeal nerve palsy. Why? Reason, as the ELN or the external laryngeal nerve is damaged, therefore the patient has palsy of the cricothyroid muscle leading to the poor quality of voice. Second, as the ILN or the internal laryngeal nerve has been injured, therefore there is loss of sensations from supraglottis causing recurrent aspirations beta. As there are symptoms of both the ELN palsy as well as the ILN palsy, That's the reason we call it as a case of bilateral SLN palsy or a bilateral superior laryngeal nerve palsy. समझे यहाँ तक बात अभी? Hopefully clear to all of you now. Clear है? So don't get confused. If they would have only said there is poor quality of voice and no aspirations, then definitely my answer would have been ELN, that is external laryngeal nerve injury. If they would have said patient is having recurrent aspirations with a normal voice, then my answer would have been only ILN or the internal laryngeal nerve palsy beta. But as they have said both the symptoms, therefore my answer has to be bilateral SLN palsy or a bilateral superior laryngeal nerve palsy. Clear यहाँ तक बात अभी? कोई दिक्कत? चलो. And treatment, we know whenever there is a bilateral superior laryngeal nerve palsy, the treatment is usually a speech therapy beta. The treatment has to be speech therapy. Understood? Next question that I will ask you, and that is this over here. If they ask you now, which is the most common nerve injured during a thyroid surgery beta? Let me know in the chat box. Which is the most common nerve injured? From surgery also it is very, very important. The commonest nerve injured during a thyroid surgery. Answer will be the commonest nerve injured during a thyroid surgery. Options are again ELN, ILN, SLN, RLN. ELN, ILN, SLN, RLN. These are the options basically. The most common nerve injured during a thyroid surgery. Answer has to be nothing else but the ELN, that is external laryngeal nerve. If not an option, you can mark the parent branch, that is SLN or the superior laryngeal nerve, followed by RLN or the recurrent laryngeal nerve. But please remember, I have told you a lot of times that this has got updated days or years ago now. Okay? The most common nerve injured during a thyroid surgery or during a thyroidectomy has to be the ELN or the external laryngeal nerve, followed by RLN or the recurrent laryngeal nerve. Clear? According to both ENT as well as surgery, it is ELN followed by RLN now. Understood? So that is important. Now there is a question which states beta, a patient underwent a thyroid surgery and now post surgery or post operatively the patient complains of respiratory distress or dyspnea along with noisy breathing, that is stridor. So after a thyroid surgery, if the patient starts complaining of respiratory distress or stridor, what is going to be the likely cause? Which nerve would have been injured over here? It is a case of, chalo, I'll make it simple, only two options. One case is basically of a अरे polyp, image देख के मत आंसर करो, वो image नीचे वाला है, ठीक है? So the question is definitely that which nerve has been injured beta. So do remember, it is a case of nothing else but a bilateral RLN injury or a bilateral recurrent laryngeal nerve injury. Clear है बात? तो इसीलिए मैं बोलता हूँ कि इमेज देख के आंसर मत मारा करो, ठीक है? ऑप्शंस पढ़ के बस इमेज देख के आंसर मारने की आदत खराब है. Clear? So that is important. So do remember that. So please remember, now what has happened during the thyroid surgery beta, there is a bilateral RLN injury or a bilateral recurrent laryngeal nerve injury. Now we know the RLN or the recurrent laryngeal nerve is known to supply all the intrinsic laryngeal muscles except cricothyroid, right? So when there will be a bilateral RLN injury or when there will be a bilateral recurrent laryngeal nerve injury, do remember all the intrinsic laryngeal muscles will be paralyzed. All the intrinsic laryngeal muscles will be paralyzed except cricothyroid. Reason? Cricothyroid is not supplied by RLN. So whenever there is a bilateral RLN injury, all the intrinsic muscles are paralyzed except cricothyroid. We know cricothyroid is mainly a tensor muscle, but apart from being a tensor muscle, it is also an adductor muscle which is known to close the vocal cord. So as there is a bilateral RLN injury, what will happen? All the muscles are paralyzed except cricothyroid. And cricothyroid being an adductor muscle, it closes the vocal cords or it adducts the vocal cord. And if the cricothyroid muscle will cause adduction or closure of vocal cord, the patient complains of respiratory distress along with stridor beta. Samjhe baat? That is important. No, the vocal cords will not be in cadaveric position. The vocal cords will be in the median or the paramedian position, that is in the adducted or the closed position beta. Clear? And this is a classical case of, very good Manvi, yes, it is a case of bilateral abductor palsy. Reason? Abduction नहीं हो पा रहा ना भाई, बराबर? As all the intrinsic laryngeal muscles have been paralyzed, abduction is not happening. Adduction is happening, and that's the reason why the vocal cords are closed. Shabash, very good. So the diagnosis of this case is nothing else but it is going to be a case of a bilateral abductor palsy. Okay, it is a case of bilateral abductor palsy. So do remember, if they give you a history of thyroid surgery and post-operatively if they say patient experiences a respiratory distress along with stridor, it has to be a case of bilateral abductor palsy, and the cause for that is nothing else but a bilateral RLN injury or a bilateral recurrent laryngeal nerve injury, due to which only cricothyroid muscle is working, and cricothyroid muscle being an adductor muscle, it is going to close or adduct the vocal cords, and as the vocal cords are closed, that's the reason why there will be respiratory distress along with stridor. Samjhe baat abhi? That is important. Treatment: as the patient is complaining of respiratory distress, the priority or the first line management has to be airway beta, and the airway management is usually done by intubation or tracheostomy. Let me know in the chat box. The airway management in a patient of bilateral RLN palsy or a bilateral abductor palsy is done by intubation or tracheostomy. Let me know in the chat box. Very good. It has to be done by tracheostomy. Reason: as both the vocal cords are closed, endotracheal intubation will fail or endotracheal intubation will not be possible. So the first line treatment has to be nothing else but tracheostomy, that is what is important. The first line treatment has to be nothing else but tracheostomy. Shabash. And we know the definitive treatment or the definitive management is going to be a type 2 thyroplasty. Okay, what we do in type 2 thyroplasty, we have to repair the vocal cord. And for that, we know the vocal cords are now in a closed position or in a median position. So we will try to lateralize the vocal cord. And this lateralization of vocal cord is basically known as your type 2 thyroplasty beta. This lateralization of vocal cord which we do is classically referred to as the type 2 thyroplasty. Hopefully clear about. And completely opposite to this will be a type 1 thyroplasty, which is medialization of vocal cord. So याद रखना, MLS is the mnemonic you might have heard. ठीक है, तो thyroplasties के लिए we know beta that the mnemonic to be remembered is definitely MLS. And when I say MLS, M means medialization of vocal cord, that is type 1 thyroplasty. L means lateralization of vocal cord, that is type 2 thyroplasty. S means shortening and loosening of vocal cord, that is type 3 thyroplasty. And completely opposite to this will be the lengthening and tightening of vocal cord, that is a type 4 thyroplasty. Clear hai? Chalo. So this is what is important to be remembered. Now let's talk about a condition beta. My patient comes to me with a complaint of, now let's see how many of you are going to diagnose. A teacher comes to me with the complaints of hoarseness of voice or dysphonia beta. Okay, a teacher comes to me with complaints of hoarseness of voice or dysphonia. Okay, laryngoscopic examination reveals a unilateral growth at the junction of anterior 1/3 and posterior 2/3 of vocal cord. What is the likely diagnosis? Laryngoscopic examination reveals a unilateral growth at the junction of anterior 1/3 and posterior 2/3 of the vocal cord. What is the likely diagnosis? Shabash. Very good, all of you. Yes, the answer to this condition has to be a vocal polyp and not vocal nodules. Very good, all of you. I'm glad that you know this difference. Reason, as I said, unilateral overgrowth beta, it had to be a polyp. Reason, nodules are always and always going to be bilateral, as we have discussed earlier also, right? Very good, Shabash. So this was a PYQ. Don't make a mistake if it repeats again. So if I talk about vocal nodules, which are also known as the teacher's nodules, singer's nodules, or the screamer's nodules, the reason being most common cause is vocal abuse beta. Whereas another condition is known as vocal polyp. Both these conditions beta, the cause is same. In both the conditions, the most common cause is vocal abuse itself. ठीक है, extreme use or excessive use of voice, which is done by teachers, singers, vendors, all of them. Apart from this, the other two causes, as usual, smoking and LPR, that is laryngopharyngeal reflux. Yes, do remember, smoking and LPR can also be the cause of these two conditions beta, but leading cause is always vocal abuse. Now if you see that these growths which are there, they are seen exactly at which point on the vocal cord. So they are seen at the junction of anterior 1/3 and the posterior 2/3 of vocal cord. Whether it is a case of vocal nodules, in vocal nodules you can see these bilateral growths, they are present at the junction of the anterior 1/3 and the posterior 2/3 of vocal cord. Or in vocal polyp, this unilateral overgrowth, if you see, it is again present at the junction of anterior 1/3 and the posterior 2/3 of the vocal cord. Reason, This junction is the most vibrating part of the vocal cord. As it is the most vibrating part of the vocal cord, therefore, this is the commonest site beta for a vocal nodule or a vocal polyp to develop. Clear? We know as the vocal cords are damaged or as there are growths over the vocal cord, we know the commonest symptom has to be nothing else but hoarseness of voice or dysphonia beta. ठीक है? तो vocal nodules में there will be hoarseness of voice or dysphonia. But in vocal polyp, along with hoarseness of voice or dysphonia, there is one more feature called as diplophonia. Diplophonia means whenever the patient speaks, you will hear sounds of two different frequencies. Yes, two different frequency sounds are produced at the same point of time, called as diplophonia बच्चे. ठीक है? डबल फ्रीक्वेंसी की आवाज सुनाई देगी. ठीक है? तो vocal nodules only hoarseness of voice, vocal polyp hoarseness of voice along with diplophonia at times beta. We know to differentiate, we do a laryngoscopy. In laryngoscopy, you will find vocal nodules are always and always bilateral beta. Vocal nodules are always and always bilateral, and they're very small in size. They are usually less than 3 mm or less than 3 millimeters in size beta. Clear about? So that is what is the important point to be remembered. Whereas if I talk about vocal polyp, we know vocal polyp is usually a unilateral condition. Vocal polyp is usually a unilateral condition beta. Apart from this, it is usually bigger in size. It is more than 3 millimeters or 3 mm in size beta. Okay, vocal polyp is usually unilateral. It is more than 3 mm or 3 millimeters in size. Hopefully clear to all of you now. So these are the points that you need to remember about both these conditions. Now coming down to the treatment. Do remember vocal nodules mein, the treatment is nothing else but vocal rest or voice rest beta. Yes, you will just ask the patient to shut up. Okay, so just ask the patient beta to take vocal rest for few days. Okay, that will definitely help in the treatment. Second thing can be speech therapy, so that the patient will learn the skill to speak with less strain or less stress on the vocal cords beta. Okay, so that is important. Whereas if I talk about vocal polyp, do remember bache, for polyp you have to remove this overgrowth or you have to remove this polyp, and that is again done with the help of CO2 laser. Shabash. So you have to go for a CO2 laser excision or a CO2 laser ablation beta. Okay? So CO2 laser excision is the mainstay of management in a vocal polyp. Along with that, here also you will advise vocal rest or voice rest to the patient. Along with that, speech therapy as well. Okay? So that is what is important to be remembered. But this is the mainstay of management. Vocal nodules mein main treatment is vocal rest. Vocal polyp mein main treatment is CO2 laser excision. And if the cause was identified as LPR or the laryngopharyngeal reflux, so we know we have to always add PPIs or the proton pump inhibitors in the treatment protocol. Hopefully done with all of you. Chalo. Now let's talk about the next one, and that is nothing else but called as tracheostomy. Bache. Okay, the next one is nothing else but tracheostomy. We know ostomy means what? Making an incision or making an opening and not closing it back beta. So wherever you make an opening and do not close it, that is known as an ostomy. So when you make an incision over the trachea and create an opening over the trachea, it is classically known as tracheostomy. Tracheostomy beta. We know tracheostomy is done for the purpose of ventilation. Okay, it is usually an emergency condition, but sometimes it can be elective as well. Okay, it is usually an emergency condition, but sometimes it can be elective. Now please tell me beta, that what is the best site to perform a tracheostomy? Let me know in the chat box what is considered as the best site to perform a tracheostomy. What is going to be your answer? And those who are in my class, if you say C2 and C3, I'll tell you then what happens. Okay? Yes. Shabash. The answer should be second and the third tracheal ring and not C2, C3. C2, C3 is over here. Are you going to perform tracheostomy at this level or what, bache? No. To remember, it is basically at the level of the second and the third tracheal ring beta. Clear about? That is important. So the best site is definitely between the second and third tracheal ring. Why I'm telling you this? Because the examiner is going to confuse you. And I've seen people getting confused with the same point again and again. So it is between the second and the third tracheal rings, which is considered as the best site. We know if I perform the tracheostomy between the first and second tracheal ring, that is known as high tracheostomy. Let me know in the chat box. The high tracheostomy that we do between the first and second tracheal ring, it is only and only advised in which condition? The high tracheostomy that we do between the first and the second tracheal ring, beta, that is usually avoided, but it is only advised in which condition? Very good, shabash. So high tracheostomy done between the first and the tracheal ring is only advisable in a patient suffering from cancer larynx. Reason? In a case of cancer larynx, the larynx is already damaged, beta. And if the larynx is already damaged, we don't care about damaging the larynx further, and therefore high tracheostomy is the high tracheostomy is only indicated if a patient is suffering from cancer larynx, beta. Hopefully clear to all of you now. So that is important. Now we know tracheostomy is usually done in which condition? So do remember, tracheostomy can be done in a prolonged mechanical ventilation. Matlab, if a patient has to be kept on a ventilator for a very long duration of time. So we know for a prolonged duration, you don't prefer an endotracheal intubation, beta. For a long duration, you prefer tracheostomy for ventilation, beta. So whenever a patient needs a prolonged mechanical ventilation, you have to go for a tracheostomy. That is what is important. Clear? Eh? Second important, if I talk about, it is always advised in all those conditions wherever endotracheal intubation is not possible or endotracheal intubation fails. So in all those conditions, wherever the endotracheal intubation is not possible or endotracheal intubation fails, we prefer doing a tracheostomy. And what are those conditions? Those conditions are usually written as KICO, beta. And what I've told you about KICO का मतलब होता है can't intubate, can't oxygenate. Okay, in these conditions, the intubation is extremely difficult or it is not possible, beta, and therefore you are not able to intubate or oxygenate the patient. So can't intubate, can't oxygenate the patient will be the conditions like maxillofacial injuries. Wherever if the patient is suffering from maxillofacial injuries, beta, that will be one condition. Second, if the patient is going to have laryngospasm, obviously due to laryngospasm, the larynx itself is closed. So again, intubation will not be possible. Third, a bilateral abductor palsy. Just now we have seen that bilateral abductor palsy mein, the vocal cords are in a median or a closed position. So intubation is not possible again. Or if a patient is having short neck because a proper positioning cannot be done. Multiple conditions. So all these conditions where intubation is not possible, we call them as KICO. And in all these conditions, tracheostomy has to be done, beta. Now, a previous year NEET PG question, let me know in the chat box. Listen to the question carefully. They gave a picture of tracheostomy tube, beta, and they asked you, all the below given are the indications of this tracheostomy tube except option 1, maxillofacial injuries. Option 2, prolonged mechanical ventilation. Option 3, assessment of upper airway. And option 4, pulmonary toileting. Toileting means cleaning. Okay? So again, I'm repeating, maxillofacial injuries, prolonged mechanical ventilation, next assessment of upper airway, and 4, definitely pulmonary toileting. What is going to be answer? 1, 2, 3, 4. Bolo. Yes, cervical spine injury may be, the patient may have KICO or a problem of can't intubate, can't oxygenate. So you can prefer doing a tracheostomy in those conditions as well. No, the answer to this question will be option C or option 3, beta. That is nothing else but assessment of upper airway. Do we perform a tracheostomy to examine the upper airway or what? Assessment का मतलब examination होता है. No, obviously. So assessment of upper airway is not an indication of tracheostomy. Pulmonary toileting. Why are the tracheostomy opening? Can you pass a suction catheter and clean the bronchi? Obviously yes, right? So examination के लिए कौन tracheostomy करता है? Nobody. Right, so that is what is important, bachche. Clear? This was a recent NEET PG PYQ from 2024, I feel 3 or 4. Okay, so that is important. Understood? The tracheostomy is done for all these conditions. You can see once we have done a tracheostomy, we have to definitely insert this tracheostomy tube, and to this tracheostomy tube we have connected the ventilator tubings, beta. Chalo. Now, if I talk about basically the next one, we know nowadays the tracheostomy tubes that we prefer using, beta, they are nothing else but the PVC tubes. Yes, the polyvinyl chloride tubes or the plastic tubes, beta. So the PVC tubes are used nowadays. Metallic tubes are not preferred. nowadays. So in case anywhere if the answer is metallic, no beta. Nowadays metallic tubes are not used due to the risk of corrosion. As the metal gets corroded, therefore metallic tubes are not preferred. Okay, we tend to use PVC tubes. PVC tubes are of two types. If this balloon is present, we call it as the cuffed tracheostomy tube. If it is absent, we call it as an uncuffed tracheostomy tube beta. Now important is, if I talk about a PYQ from ENT in the FMG examination, and the question was, if a patient is admitted in the ICU, or if the patient is unconscious, if the patient is in a comatose state, or if the patient has suffered from a severe head injury with a GCS of less than equal to 8, in all these conditions, you will prefer using a cuffed tube or an uncuffed tube beta. In all these conditions, you will prefer using a cuffed or an uncuffed tube. Shabash. Yes, so this was a PYQ beta. In all these conditions, we prefer using a cuff tube basically. And the reason is all of you are right. The cuff tubes are preferred in these kind of patients to prevent aspiration beta. हमें पता है in all these patients who are in a comatose state, who are unconscious, they have a very high risk of aspiration beta. And if you want to prevent aspiration, you tend to use a cuff tube. Reason, that cuff which is there beta, it is known to block the airway. Okay, and as it blocks the airway beta, it is not going to allow aspiration to happen. Barabar hai? Shabash. All of you are right. Yes. Now another complication of the tracheostomy tube. Chalo, cuff tube to we can use. That's not an issue. But the problem is, if the cuff is causing constant pressure on the trachea beta, if the cuff is causing constant pressure on the trachea, that leads to weakness in the trachea called as tracheomalacia beta. Okay, that leads to weakness in the trachea called as tracheomalacia. So to prevent this tracheomalacia bache, there are two options. One is I can deflate the cuff for 5 minutes after every 2 hours. हर 2 घंटे बाद जाओ, कफ की हवा निकालो 5 मिनट के लिए, फिर वापस उसको इन्फ्लेट कर दो. Right? So deflate the cuff for 5 minutes after every 2 hours beta. That can be done. But another way is, because this one is a hectic thing to do now, after every 2 hours you have to go. So the better option is what? Use which kind of a cuff? A cuff which is going to have a high volume. Very good. A cuff which will have a high volume, so it causes a proper blockage beta, but which has a low pressure. Because if the pressure is going to be less beta, it will not cause any tracheomalacia. Clear? So to prevent the tracheomalacia from happening, use a high volume but a low pressure cuff beta. Shabash. Use a high volume but a low pressure cuff. Hopefully clear है यहाँ तक बात. Use a high volume but a low pressure cuff. That is what is the advice that you will give if there is a risk of tracheomalacia. Understood? Next important, if I talk about now, we know what is the most dangerous or the most deadly complication of tracheostomy or intubation. We know whenever you intubate a patient or whenever you perform tracheostomy, after every 2 hours you have to go and clean the tube by suctioning beta, because there will be a lot of secretions which are going to be present inside the tube. Okay? So if there was an inadequate suctioning done, if you did not clean the tube properly, if you did not suction the tube properly, the tube will get blocked due to the secretions beta. Yes, so the most deadly or the most dangerous complication beta of tracheostomy is going to be tube blockage. Okay? So if inadequate suctioning of secretions is done, that leads to a dangerous complication known as tube blockage. You should immediately go and clean the tube beta. If not, you have to replace the tube. Clear? So that is what is important. Now, another complication which may happen after tracheostomy is what? After tracheostomy, you will find around the tracheostomy opening beta, there is some swelling. And when you press the swelling now, you will feel some crackling sensation of crepitus. This is why. Reason is, as there is a lot of air collected below the skin, therefore you are able to feel this crepitus beta, and that condition is classically known as subcutaneous emphysema. This condition is classically called as subcutaneous emphysema. Now, what is the leading cause for subcutaneous emphysema? There are two causes. One, when I apply tight sutures around the tracheostomy opening so that the air is not able to escape out. One, tight sutures around tracheostomy opening. And second is rupture or tear in the posterior wall of trachea. Second is rupture or tear in the posterior wall of trachea. What is the leading cause? This was a PYQ again. The leading cause or the most common cause of this subcutaneous emphysema, very good all of you, it has to be tight sutures around the opening beta. So when you have applied tight sutures around the tracheostomy opening, that will not allow the air to escape out beta, and that causes this subcutaneous emphysema, or which will lead to the crepitus around the tracheostomy opening. Hopefully clear to all of you now. So tight sutures around the opening is going to be the cause. Sure. Done with this. Next important, if I talk about the last point from larynx, and that is nothing else but CA larynx or cancer larynx beta. Now when I talk about the CA larynx or the cancer larynx, let me know, more commonly cancer larynx is going to be an adenocarcinoma or a squamous cell carcinoma. Let me know, more commonly CA larynx or cancer larynx is an adenocarcinoma or a squamous cell carcinoma. Let me know in the chat box. Batao. What do you think? Very good. We know that though the whole larynx is lined by the ciliated pseudostratified columnar epithelium, but more common type of a CA larynx or cancer larynx is squamous cell carcinoma. Two reasons for it. One, most common site of cancer larynx is the true vocal cords or the glottis beta. And as glottis is the most common site, we know glottis is lined by stratified squamous epithelium. Yes. Another important cause, very good, smoking. That smoking is basically known to cause a squamous metaplasia, which can further lead to a squamous cell carcinoma. Clear about? So do remember beta, cancer larynx which is there, it is more commonly going to be a squamous cell carcinoma. We know squamous cell carcinoma of larynx mainly occurs by two main reasons. One obviously has to be smoking beta, and second, a viral infection. We have already discussed. The viral infection which has a very strong affinity towards the squamous epithelium or squamous cell carcinoma is HPV, that is human papilloma virus. But this time, as we are talking about cancers beta, cancer larynx, so it has to be the high risk serotypes, and the high risk serotypes of HPV or human papilloma virus is known as 16 and 18. More common being 16, more dangerous being 18, which are actually known to cause various cancers like the cancer larynx, anogenital cancer, cervical cancer, and the oral cancer beta. Hopefully clear to all of you now. Great. Now we know there are three types of CA larynx beta. One is the glottic cancer arising from true vocal cords. Second is the supraglottic cancer, and third is the subglottic cancer. But out of all of them, the most common type which is there beta has to be the glottic cancer itself. Okay, the most common type of CA larynx is the glottic cancer. Okay, and that's the reason why squamous cell carcinoma is more common. Another thing that I would like to ask you, and that is, please tell me, glottic cancer we all know has the best prognosis beta. But why do glottic cancer has the best prognosis? That is a matter to discuss. Bolo. We know most common type is glottic cancer, and by good fortune, glottic cancer is the one having the best prognosis. Why do glottic cancer has the best prognosis? The main reason behind that is, very good, shabash. It has best prognosis because of no lymphatic metastasis. Do remember beta that the glottis or the true vocal cords do not drain into any lymphatic. And as it does not drain into any lymphatics, it does not lead to any lymphatic metastasis beta. And that's the reason it will have the best prognosis. Clear about samjhe? Two reasons. One, there is no lymphatic metastasis. And second reason, glottic cancer immediately causes hoarseness of voice. So the patient seeks medical attention or the patient seeks medical help early on. So the cancer is diagnosed very early beta. That's the reason definitely glottic cancer will have the best prognosis. We know whenever a patient will come to us with complaints of CA larynx or cancer larynx beta, investigation of choice is nothing else but a direct laryngoscopy with biopsy. And as it is a case of squamous cell carcinoma, biopsy or the histopathological examination shows you which classical feature. Let me know in the chat box. We know as CA larynx is more commonly a squamous cell carcinoma, the biopsy or the histopath will classically show you which kind of feature beta. Let me know in the chat box. These kind of features will be seen on histopath. Yesterday itself you have done your path, right? So let me know. It commonly shows the classical keratin pulse beta. Barabar, it can show us the classical keratin pulse. Has to be remembered. Now, if I talk about the staging, always remember, or always say, only remember three main cancer stagings for FMG examination at least. One, CA breast from surgery, extremely important. CA cervix from gynae, and third, CA larynx from ENT beta. Okay, so CA breast, CA cervix, and CA larynx. Now, CA larynx mein staging is very easy. T1 is nothing else but involvement of one structure beta. T2 is involvement of more than one structure. Okay, so if only glottis is involved, that is T1. If glottis plus supraglottis is involved, that is T2. Okay, T3, that means whenever the vocal cords are fixed or immobile. Do you remember, if only vocal cords are involved and if they are mobile beta, then it is T1. But if vocal cords are involved and they become fixed or they become immobile due to the cancer, then it is considered as T3 beta. And lastly, when the cancer spreads outside the larynx, that is known as T4. So T4 matlab extra laryngeal extension when the cancer goes outside the larynx. In a previous year examination, they asked you beta a stage. Let me know, if both the vocal cords are involved and both the vocal cords are mobile, what is the exact stage you are going to answer? Let me know in the chat box. If both the vocal cords are involved and both the vocal cords are mobile, basically, what is going to be your exact stage? Exact, huh? Anybody? Yes, the answer to this has to be nothing else but T1B beta. Reason, T1 which is there, it can be of two types. One is going to be the T1A bache, that is involvement of only one vocal cord. T1B beta is nothing else but involvement of both the vocal cords. So if there is involvement of only one vocal cord, that is known as T1A. If there is involvement of both the vocal cord, that is known as T1B. And in both these conditions, the vocal cords are going to be mobile. Because if the vocal cords become fixed or immobile, that is T3 then directly. Clear about? So that is what is important. So this was the previous year question in the FMG exam. So if both the vocal cords are involved and their mobility is intact, consider it to be T1B beta. That has to be remembered. Clear? Do remember, vocal cords or glottis as a whole, it is considered as only one structure. Okay, glottis together is one structure, that has to be remembered. Samjhe baat? So that is important. Now, if I talk about treatment, we know if the patient is diagnosed with cancer larynx and the patient is in the stage T1 or T2 beta, then as the cancer is in the early stages, we can treat it only with the radiotherapy. Okay, we can treat it only with radiotherapy beta. Nothing else is needed. You may go for a partial laryngectomy, but partial laryngectomy does not have a very good outcome. That's the reason beta we prefer doing a radiotherapy. So stage T1 or stage T2 mein the treatment is radiotherapy beta. Whereas if the patient is in the stage T3 or the stage T4, in those conditions we have to go for surgery. And the surgery that we do in a case of CA larynx stage T3 and T4 is nothing else but complete removal or total removal of larynx, that is called as total laryngectomy beta. Along with total laryngectomy, as the cancer is in the advanced stages, even the lymph nodes may be involved. And for that, I have to go for plus minus MRND beta. What is MRND? Modified radical neck dissection. So along with total laryngectomy, you may have to go for a MRND, that is a modified radical neck dissection. Followed by this, we know after surgery we don't want any recurrence beta. Okay, as you don't want any recurrence after surgery, you have to give radiotherapy in the patient beta. Hopefully clear hai baat yahan tak. So the treatment for stage T3 and T4 of CA larynx is total laryngectomy followed by a radiotherapy, or total laryngectomy plus minus modified radical neck dissection followed by radiotherapy. Hopefully clear to all of you now. Chalo. Now after laryngectomy beta, we know we will do a permanent tracheostomy, right? After laryngectomy, we do a permanent tracheostomy for the airway. But apart from that, we also need vocal rehabilitation. Reason, as you have removed the larynx or as you have removed the vocal cords, the patient has lost the voice. So therefore, if they ask you, what is the best method for vocal rehabilitation? There are three techniques beta. One is the esophageal voice. Second is artificial larynx, also called as an electrolarynx, which is a mechanical vibrator usually. And third one is nothing else but the TEP device or the tracheoesophageal puncture device. Let me know, out of these three beta, the best method for vocal rehabilitation will be considered as. Shabash. The best method beta for the vocal rehabilitation is nothing else but called as the TEP TEP device बच्चे, that is called as the tracheoesophageal puncture device, which is a one-way valve like device beta, which is surgically placed between the trachea and esophagus, and that is responsible for producing vibrations. ठीक है? So याद रखना, the best method for the tracheoesophageal puncture device is nothing, best method for vocal rehabilitation is the tracheoesophageal puncture device or the TEP device. ठीक है? Let me know in the chat box the best TEP device. Shabash, very good. The best TEP device that we use for the vocal rehabilitation is nothing else but, very good, the best TEP device that we use for vocal rehabilitation is nothing else but known as the Blom Singer prosthesis bache. The best TEP device that you use for vocal rehabilitation is considered as the Blom Singer prosthesis. Very good, shabash. So that was all about your CA larynx or cancer larynx, and that was all about basically your larynx as well, beta. Now let's talk about the second part, and the second part in the throat is nothing else but your pharynx. The second part in the throat is nothing else but pharynx. Now I have discussed already, pharynx is the posterior longer cylinder which is going to start from the skull base and it will end along with larynx at the level of C6 or the 6th cervical vertebra. तो end साथ में ही होता है दोनों. Pharynx is continuous with your GI tract or your esophagus, that we know. बराबर है बात? तो do remember beta, if I talk about pharynx, the extension of pharynx which is there, it usually starts from the level of the skull base and goes down till the level of C6 beta. It starts from the level of skull base and it goes down till the level of C6. That has to be remembered. Clear? Now we know pharynx is basically divided into three parts. What are the three parts to the pharynx? The first part, the part of the pharynx behind the nose or behind the nasal cavity, should be called as the nasopharynx, also known as the epipharynx beta. Epi मतलब ऊपर, ठीक है? So the part behind nasal cavity is known as nasopharynx. Second, the part of the pharynx behind the oral cavity is known as oropharynx. The part behind the oral cavity is known as oropharynx. And third, the part of the pharynx behind the larynx. So you can see this is the larynx, this is your epiglottis. Okay? So the part of the pharynx behind the larynx beta is known as your laryngopharynx, also known as retropharynx, also known as hypopharynx. Hypo मतलब नीचे. ठीक है? तो laryngopharynx, retropharynx और hypopharynx. Hopefully clear to all of you now. So that is important. Now, if I talk about basically, this is the first picture that you are able to see beta. And this is the classical picture of a nasopharyngeal endoscopy beta. This is the classical picture of a nasopharyngeal endoscopy जो दिख रहा है तुम्हें. Now, in this nasopharyngeal endoscopy, they mark some structure and ask you, what is the mark structure? So you can see where your endoscope is placed. So यहाँ पे your endoscope is present at the posterior nasal opening. I hope all of you are quite aware beta that your posterior nasal opening is known as choana. So till the level of choana beta, your endoscope is gone. And now you are able to see the picture of nasopharynx. This is your nasopharynx. बराबर क्या देख रहा है? First of all, please tell me the highlighted opening is of which structure beta? The opening that I have highlighted on the lateral wall of nasopharynx. On the lateral wall of nasopharynx, the opening that I have highlighted is basically which opening? Let me know in the chat box. The opening that I have highlighted on the lateral wall of nasopharynx, it is which opening? Very good, shabash. So we know on the lateral wall of the nasopharynx, the opening that you have highlighted beta, it is nothing else but the ET opening or an Eustachian tube opening beta. So we know Eustachian tube or an auditory tube is basically a connection between the nasopharynx and the middle ear. हमें पता that middle ear is a closed cavity only having one exit point, and that exit point is known as your Eustachian tube beta. So this Eustachian tube is basically a connection between the middle ear and the nasopharynx, and Eustachian tube always opens on the lateral wall of the nasopharynx. So if they mark this opening, you have to remember it is the Eustachian tube opening. Second, this one that you are able to see, we know where the Eustachian tube opens, the cartilage of the Eustachian tube forms a protrusion. ये उभरा हुआ जो हिस्सा दिख रहा है, that protrusion on the lateral wall of nasopharynx due to the Eustachian tube cartilage is classically known as, anybody? The protrusion on the lateral wall of nasopharynx due to the cartilage of Eustachian tube is classically referred to as the torus tuberous beta. This is classically referred to as the torus tuberous. And behind that, basically, if there is a protrusion, there will be a depression also. And we know this depression that we are able to see beta, over here. This depression that you can see over here beta behind the torus tuberous, that is classically known as nothing else but your classical fossa of Rosenmuller beta. बराबर है? So definitely this depression which you are able to see behind the torus tuberous, it is classically known as nothing else but fossa of Rosenmuller beta. Has to be remembered. Now, why this fossa of Rosenmuller? They might have marked twice in the FMG examination and asked you in the exam. This nasopharyngeal endoscopy was given in a PYQ beta, and they marked this fossa of Rosenmuller and asked you the name of the structure. Why it is clinically so important? Fossa of Rosenmuller is the commonest site for which condition? Let me know in the chat box. Which is the condition which commonly arises from the fossa of Rosenmuller? Let me know in the chat box. Which is? Shabash. Very good. We know that fossa of Rosenmuller is the most common site for a nasopharyngeal cancer or a nasopharyngeal carcinoma. Shabash. That's the reason why it is clinically so important. Understood? Great. Next, there's a question which states we are having a 7-year-old child beta, and this 7-year-old child was brought to you with complaints of what? The child is having complaints of a bilateral CHL or a bilateral conductive hearing loss. Along with that, the child is also having poor school performance. Obviously, due to the hearing loss, the child may have a poor school performance. The child is having a dull voice or a hyponasal voice. Matlab, this school going child will speak in which kind of voice? Like this. The child will have this kind of a voice, but you can see there is a very dull voice or a low pitch voice. Understood? So this is a dull or a hyponasal voice. And there is a below given classical or the characteristic faces. Very good, all of you. Yes. ये जो classical faces है, we know beta, we call it as the adenoid faces. बराबर? This classical faces that you are able to see, it is classically referred to as the adenoid faces beta. And adenoid faces में क्या क्या होता है? First, the child will have the pinched up nose beta. The nose is going to be pinched up. Second, there is high arched palate. If you see the palate of the child, it is not going to be flat, it is high arched palate. Third, due to the high arched palate, there is crowding of teeth or malocclusion of teeth. The teeth will come closer. There is crowding of teeth. And fourth, yes, the mouth is always open. Okay? This classically is known as the adenoid faces. We know if a child complains of bilateral conductive hearing loss, dull voice and adenoid faces, has to be a case of nothing else but, all of you are right, has to be a diagnosis of adenoid hypertrophy beta. हमें पता hypertrophy means increase in the size of cells beta. Okay, and when there is hypertrophy of adenoids, these kind of symptoms are going to be seen. First of all, what are adenoids? For those who don't know, do remember बच्चे, adenoids are nothing else but nasopharyngeal tonsils. Yes, the nasopharyngeal tonsils or the nasopharyngeal lymphoid tissue is known as adenoids. They are located exactly in the center of the nasopharynx, and therefore whenever these adenoids will undergo hypertrophy, क्या हो जाएगा? As these adenoids which will be there beta, as these adenoids will undergo hypertrophy, they are going to block both the eustachian tube openings. We know if both the eustachian tube openings are blocked beta, the middle ear is not able to drain the secretion. हमें पता है ना, eustachian tube helps in drainage of middle ear secretions. But if both the eustachian tube openings are blocked, middle ear cannot drain the secretion, and a lot of glue-like fluid collects in the middle ear. And this lot of glue-like fluid beta, okay, so please remember, a lot of glue-like fluid basically which is there inside the middle ear beta, that condition is known as glue ear. And due to the glue ear basically, or due to the serous otitis media, the child is suffering from conductive hearing loss. Due to the fluid, there is difficulty in conduction of sound na? So the child will have a CHL or a conductive hearing loss due to this reason. Samjhe baat? That is important. Yes, mouth breathing is there beta. The reason is basically हमें पता है, in the posterior wall of the nasopharynx we have adenoids. So whenever these adenoids will undergo hypertrophy, they block the posterior nasal opening of the choana. As they block the posterior nasal opening or choana, the child is not able to breathe via nose. That's the reason why the child keeps the mouth open and keeps on breathing beta, because the air enters via the mouth into the airway. समझे बात? That is what is important. Hopefully clear है बात. पानी के नीचे definitely open the mouth, or whenever you have distress you open the mouth ना भाई. So that is what is important. Understood? चलो. Understood? So this is a classical case of adenoid hypertrophy. Why adenoid hypertrophy happens? We know the school age child who is going to have a recurrent URTI or a recurrent upper respiratory tract infection, that is the leading cause of adenoid hypertrophy बेटा. Clear? क्योंकि अगर बार बार upper respiratory tract infection हो रहा है, due to that the adenoids or these nasopharyngeal tonsils are working over time, and that's the reason they ultimately undergo hypertrophy beta. Hopefully clear. Chalo. So do remember this. Treatment, if they ask you, we know if the patient is suffering from adenoid hypertrophy, first always see, okay, what is the real cause. Reason is, let's say a school age child has been brought to you with complaints of adenoid facies along with a bilateral conductive hearing loss along with dull voice or hyponasal voice. The first step is always do a nasopharyngeal endoscopy and find out what is the cause for the eustachian tube blockage. Okay, whether it is a tumor, it is a polyp, it is adenoids, whatever is the cause. So always first of all diagnose what is the reason why the eustachian tube openings are blocked, and then you are going to proceed to the treatment. When we proceed to treatment, we know the main problem is adenoid hypertrophy, so we have to remove these adenoids. Reason, all of us usually after 20 the adenoids are going to disappear in us beta. ठीक है, तो ऐसे भी 20 साल के बाद adenoids गायब ही हो जाना है. So definitely if adenoid hypertrophy is the problem, treatment has to be removal known as adenoidectomy beta. So the mainstay of management in a patient of adenoid hypertrophy has to be adenoidectomy. But along with adenoidectomy, we have to also treat the bilateral conductive hearing loss or the bilateral glue ear beta. Okay, and therefore to treat the glue ear or to treat the conductive hearing loss, हम क्या करते हैं? We make an incision over the tympanic membrane. As you make an incision over the tympanic membrane, you drain the fluid from the middle ear, and after that you are going to insert a middle ear ventilation tube. And the middle ear ventilation tube that we insert, which all of us are quite aware, is known as grommet beta. ठीक है, तो if hearing loss is present, if glue ear is present, then and then only we go for a myringotomy with grommet insertion. ठीक है, so do remember, I have seen a common problem happening with students over here, and that is they give a case of adenoid hypertrophy beta. ठीक है, and as they give a case of adenoid hypertrophy, they have not mentioned anything about hearing loss. Still you people mark myringotomy with grommet insertion in the treatment. Why? Please remember beta, myringotomy with grommet insertion should always be marked in the treatment only if they have mentioned about hearing loss or glue ear. If they have not mentioned anything about the hearing loss which happens due to the glue ear beta, don't mark myringotomy with grommet insertion. It is not done by default. ठीक है, adenoid hypertrophy में the mainstay of treatment is adenoidectomy. Only if hearing loss is there, then you also do a myringotomy with grommet insertion. समझे बात? That is the basic difference you have to keep in mind. Understood? Next important, if I talk about a sarkari, जैसे biochem से you might have heard about vitamin B3 or niacin, वैसे ही ENT से the sarkari question has to be this. What is the case? A 14-year-old boy beta comes to us with complaints of recurrent profuse epistaxis, that is nosebleed, along with a nasal mass and a frog face deformity beta. What is the likely diagnosis they are asking you? Tell me. Okay, a teenager or a juvenile age group patient, especially boys, 12 to 14-year-old boy, coming to you with complaints like recurrent profuse epistaxis along with a nasal mass and this kind of frog face deformity where there is a broadening of nose and there is proptosis or protrusion of eyeball. This is classically known as the frog face deformity beta. This has to be a classical case of, very good all of you, has to be a classical case of nothing else but JNA, called as juvenile nasopharyngeal angiofibroma beta. This condition is classically known as nothing else but JNA, called as the juvenile nasopharyngeal angiofibroma. Hopefully clear. As you can see the name itself beta, juvenile means it is more common in the children less than 18 years of age, especially 12 to 14 years. And nasopharyngeal angiofibroma means it is basically a tumor arising from the blood vessel. Yes, it is a highly vascular tumor. And as it is a highly vascular tumor, which procedure is contraindicated in this patient of angiofibroma? Let me know in the chat box. As it is a highly vascular tumor beta, which procedure is contraindicated in a case of angiofibroma? Let me know in the chat box. We know that this juvenile nasopharyngeal angiofibroma mein, the classification which is there beta, it is going to be known as the FISH classification, or the staging is known as the Radkowski staging. So the classification or the staging is known as FESS classification or Radkowski staging respectively. This was the previous year FMG question. Do remember. Very good. We know as nasopharyngeal angiofibroma beta is a vascular tumor. Biopsy will be absolutely contraindicated. Reason, if you try to go for biopsy, the patient will bleed to death on the OT table itself beta. That is what is important. So biopsy is absolutely contraindicated if a patient is suffering from angiofibroma. ठीक है, याद रखना. In any vascular tumor, biopsy should be contraindicated. So what is the investigation of choice was a PYQ? We know the investigation of choice in a patient of angiofibroma has to be the CECT or a contrast enhanced CT scan. And when I do a CECT or a contrast enhanced CT scan in angiofibroma, you can see from the spinopalatine foramen. This is the spinopalatine foramen. So from the spinopalatine foramen, a tumor is growing beta laterally or in the pterygopalatine fossa beta. A tumor is growing laterally in the pterygomaxillary or the pterygopalatine fossa. And this tumor, you can see it is pushing the posterior wall of the maxillary sinus. If you compare the posterior wall of maxillary sinus on both the sides, तो मैं दिखेगा that on the side where the tumor grows in the pterygomaxillary fossa, the posterior wall of maxillary sinus is pushed forward, and that is classically known as which sign? PYQ in the FMG exam. Very good, all of you. Yes, this classical sign on CECT is known as the Hallman-Miller sign, which is also called as the antral sign. Yes, this classical sign which is there on the CECT is classically called as the Hallman-Miller sign or the antral sign, known as the Hallman-Miller or the antral sign. Hopefully clear to all of you now. So these are the points that you need to remember. Clear yahan tak? Now if they ask you basically what is going to be the treatment. So a previous year question was what should be the treatment if a patient is suffering from JNA or an angiofibroma. Options are radiotherapy, chemotherapy, chemoradiation or surgery. What should be your answer? What is the treatment for a case of an angiofibroma? Let me know in the chat box. Very good. The treatment in a case of a angiofibroma is nothing else but a surgery or a surgical excision beta. Now we said that biopsy is also contraindicated beta. Then how a surgical excision will be possible? So to make sure that there is no bleeding during the surgical excision, we have to go for a preoperative embolization. Yes, you have to embolize the main blood vessel or the main artery supplying the tumor beta. So do remember that treatment is going to be a surgical excision, but preoperatively we have to embolize the tumor so that the bleeding can be minimized beta. Very good, shabash. Yes, so that is what is important. Yes, very good, all of you. Chalo. So that was all about your classical nasopharyngeal angiofibroma. Now another common question which comes basically in the examination is about the NPC or the nasopharyngeal carcinoma beta. If I talk about the NPC or the nasopharyngeal carcinoma, we know angiofibroma was a benign tumor of nasopharynx, but nasopharyngeal carcinoma, by the name it is evident, it is a cancer or malignancy of the nasopharynx. If I talk about this nasopharyngeal carcinoma, it is more common in young or old patients. Let me know in the chat box. So we know, yes, maxillary artery is the main artery supplying angiofibroma. Shabash. So do remember beta, NPC or the nasopharyngeal carcinoma which is there, do remember more commonly it happens in the older patients or the elderly patients, especially the people more than 50 years of age beta. Okay, especially the people who are more than 50 years of age, and more commonly the Chinese race beta. More commonly the Chinese race. Now it happens mainly due to which viral infection? This is a question, another important from microbiology as well. The nasopharyngeal carcinoma or NPC is commonly associated with which viral infection beta? Very good, all of you. Yes, shabash. Yes. So do remember NPC or nasopharyngeal carcinoma is commonly associated with the EBV of the Epstein-Barr virus infection. We know it is commonly associated with EBV or the Epstein-Barr virus infection beta. Yaad rakhna, I am just telling you other ones. Epstein-Barr virus is commonly associated with multiple malignancies in the body. One being NPC or the nasopharyngeal carcinoma. Second is Hodgkin's lymphoma. Third is non-Hodgkin's lymphoma. Fourth is Burkitt's lymphoma. And fifth is post transplantation lymphoma. After transplant, post transplantation lymphoma. Again, I'm repeating: nasopharyngeal carcinoma, Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt's lymphoma, which is a subtype of non-Hodgkin's itself, and post-transplantation lymphoma. 5 malignancies commonly associated with EBV or Epstein-Barr virus infection. Chalo. We all know, beta, that nasopharyngeal carcinoma is considered as a hidden malignancy or an occult malignancy, beta. Why? Because in early stages, the patient does not develop any symptoms. Q? Reason is, this cancer commonly arises from this fossa of Rosenmuller, as we all have discussed, beta. And as it arises from the fossa of Rosenmuller, early stages mein it does not show any symptoms. The most common site for a nasopharyngeal carcinoma to develop is classically known as the fossa of Rosenmuller, beta. Hopefully clear about that is what is important. Now, another PYQ once they have asked in the FMG examination, and that is, as nasopharyngeal carcinoma is a hidden cancer in the early stages, so what is the commonest site of presentation? What is the commonest type of presentation in NPC? How the patient commonly presents to us, beta, in a case of NPC or a nasopharyngeal carcinoma? Yaad rakhna, the most common type of presentation in NPC is this. This Chinese patient, you can see, comes to us with a complaint of a lateral neck swelling. When you palpate this lateral neck swelling, beta, yes, these are nothing else but the enlarged cervical lymph nodes, beta. मतलब क्या हो चुका है? The cancer has metastasized or the cancer has spread to this cervical group of lymph nodes, and that's the reason the patient presents to you. Clear? So the most common type of presentation in nasopharyngeal carcinoma is a painless metastatic cervical lymphadenopathy. It is a painless metastatic cervical lymphadenopathy. This is the reason why the patient commonly presents to you. Now, apart from this painless metastatic cervical lymphadenopathy, the patient will come to you with the complaints of a classical triad, beta. And all of us are quite aware that triad seen in patients of nasopharyngeal carcinoma is known as the Trotter's triad, beta. It is classically called as Trotter's triad. Yaad rakhna, Trotter's triad can be remembered by the same mnemonic, NPC, that is nasopharyngeal carcinoma. What is NPC? N stands for neuralgia, beta. Neuralgia is a severe pain due to involvement of the nerve, beta. And which nerve? It is the trigeminal nerve or the fifth cranial nerve. So as the malignancy involves the trigeminal nerve or fifth cranial nerve, patient has severe pain in the face region, beta. Second, P for palatal palsy, that is paralysis of the palatal muscles, which happens due to involvement of the 10th cranial nerve or the vagus nerve. So due to involvement of the 10th cranial nerve, vagus nerve, patient has palatal palsy or paralysis of palatal muscles. And C stands for CHL, that is conductive hearing loss. But do remember, adenoid hypertrophy in a school going child mainly causes a bilateral eustachian tube blockage. So it causes a bilateral glue ear and a bilateral conductive hearing loss. But a nasopharyngeal carcinoma is a malignancy which will only block the same-sided eustachian tube, beta. So it will only cause a unilateral glue ear leading to a unilateral conductive hearing loss. Another PYQ in the FMG examination was, let's say a 58-year-old patient comes to you with complaints, beta. Okay, a 58-year-old patient comes to you with complaints of heaviness in the ear along with a unilateral conductive hearing loss. 58-year-old patient comes to you with a complaint of heaviness in the ear along with unilateral conductive hearing loss. Okay, and on examination there is fluid behind an intact tympanic membrane. Now what should be the next step? Okay, what should be the next step in management of the patient? Options are, first is adenoidectomy with myringotomy and grommet insertion. Okay, option 1, adenoidectomy with myringotomy and grommet insertion. Option 2, myringotomy and grommet insertion. Option 3, nasopharyngeal endoscopy. Option 4, chemoradiation. What should be your answer? Okay, first is adenoidectomy with myringotomy and grommet insertion. Second is myringotomy with grommet insertion. Third is nasopharyngeal endoscopy. And fourth is chemoradiation, beta. Very good, Bipin. The answer has to be a nasopharyngeal endoscopy, beta. This is a question where a lot of people were trapped earlier. Reason is, bache, elderly patient coming to you with unilateral conductive hearing loss or unilateral glue ear, we have to treat the glue ear, but you will find the cause first ना भाई. Next step पूछा ना उन्होंने, you will find the cause first. What is the reason the patient is having a unilateral glue ear, or what is the reason the patient is having a unilateral conductive hearing loss? For that you need a nasopharyngeal endoscopy to find out the cause behind the eustachian tube blockage beta. It could be a cancer also. हमें पता है that NPC or a nasopharyngeal carcinoma is asymptomatic in the early stages as it is a hidden cancer. That's the reason always do a nasopharyngeal endoscopy first. Followed by that you can decide the treatment option. If it is adenoid hypertrophy, go for adenoidectomy. If it is nasopharyngeal carcinoma, go for chemoradiation. समझे बात? So that is important. Do remember, treatment in patients of nasopharyngeal carcinoma is nothing else but chemoradiation. That has to be remembered beta. Okay, that is a simultaneous chemotherapy along with radiotherapy that has to be done. ठीक है? Do remember, if they only ask treatment of nasopharyngeal carcinoma, my answer is straightforward chemoradiation. But if they are stage 1 and stage 2, you can prefer radiotherapy. If they are stage 3 and stage 4, you can go for chemoradiation. तो स्टेज 1 and 2 बोलेंगे तो आंसर इज रेडियोथेरेपी ओनली. इफ स्टेज 3 and 4 दे से द आंसर इज कीमोरेडिएशन. Overall you can mark chemoradiation as the answer. Clear? Another question which is easy. An adult patient beta presents to you with complaints of fever along with dysphagia, that is difficulty swallowing, hot potato voice or the muffled voice, as I told you, this kind of voice, and a trismus. What is trismus? Difficulty in opening the jaw or difficulty in opening the mouth beta, and that happens due to spasm of which muscle? Let me know. In this condition which we are talking about beta, the trismus or the locked jaw happens due to spasm of which muscle? Was a PYQ. Bolo. The trismus in this condition that we are talking about happens due to spasm of which muscle? Which mastication muscle? The trismus of the lockjaw in this condition happens due to the spasm of the medial pterygoid muscle beta. It mainly happens due to the spasm of the medial pterygoid muscle. We know more commonly it happens due to spasm of lateral pterygoid muscle beta, but in this condition it commonly happens due to the spasm of medial pterygoid. समझे बात? That is what is important. Or more commonly it happens due to lateral pterygoid, but in this condition specifically it is medial pterygoid. इसीलिए पूछा था. समझे? Now we know if an adult patient complains of fever, dysphagia, hot potato voice, trismus, and if you see the examination finding, क्या दिख रहा है examination पे? The tonsils have been pushed medially and the uvula is pushed towards the opposite side. बराबर? Tonsils are pushed medially and the uvula is pushed towards the opposite side beta. Reason is there is collection of pus or there is an abscess beta behind the tonsil, and collection of pus or abscess behind the tonsil means there is abscess in the peritonsillar space. Yes, it is nothing else but a classical case of peritonsillar abscess, also known as quinsy. All of you are right. So if this kind of features are seen beta, the diagnosis is a classical case of quinsy, which is also known as peritonsillar abscess. When there is collection of pus in the peritonsillar space, or whenever there is collection of pus behind the tonsils beta, we call that condition classically as quinsy or the peritonsillar abscess. Treatment क्या करेंगे? As there is pus collection, we have to drain the pus, and if you have to drain the pus beta, you should go for a peroral incision and drainage. If you have to drain the pus, you should go for a peroral incision and drainage. That has to be kept in mind. And along with that, as it is a bacterial infection caused by organisms like Streptococcus pneumoniae or Streptococcus pyogenes, therefore you also have to give antibiotics. Yes, quinsy or peritonsillar abscess mainly happens due to bacterial infections with Streptococcus pneumoniae or Streptococcus pyogenes beta. समझे बात? That's the reason you will also need to give antibiotics in the patient. Which समझे बात? चलो. And yes, very good. After a span of 6 weeks, you go for an interval tonsillectomy. Very good. But कब करते tonsillectomy? If an adult patient had 2 episodes of quinsy or a child had 1 episode of quinsy. Adult में after 2 episodes, child में after 1 episode, we can go for an interval tonsillectomy after a span of 6 weeks beta. ठीक है? So you can write down if you want. So definitely after 6 weeks. ठीक है? So call the patient back after 6 weeks, and after 6 weeks go for an interval surgery called as an interval tonsillectomy. Clear? Reason I always say, If you remove the tonsils itself, will the infection spread to the peritonsillar space? No. Na rahega baas, na bajegi basuri. That I always say, right? So that is what is important. Chalo. Next is, if they say a small child or a pediatric patient comes to you with same clinical picture, beta. If there is a same clinical picture in a small child or a pediatric patient, beta, like quinsy, matlab the child is having fever, dysphagia, odynophagia, hot potato voice at times. Hot potato voice is not common, but yes, fever, dysphagia, odynophagia, trismus. Same picture. Tonsils pushed medially, uvula pushed towards the opposite side, along with neck swelling. Then the diagnosis has to be very good. Yes. Then the diagnosis has to be nothing else but parapharyngeal abscess, beta. Then the diagnosis in this condition has to be a case of parapharyngeal abscess. Yaad rakhna, if they say there is neck swelling in a case, then it has to be a case of parapharyngeal abscess. It can never be quinsy. Reason is bache, quinsy mein neck swelling will never be present. Quinsy mein neck swelling is never present. This is the main difference, right? If neck swelling is present, it has to be a case of parapharyngeal abscess. If neck swelling is absent, you can think about quinsy as the diagnosis. Samjhe baat? Because quinsy or peritonsillar abscess is collection of pus in the inner space or the medial space. Therefore, there is no external neck swelling visible. But parapharyngeal abscess is collection of pus in the outer space or the external space, more lateral space. Therefore, the neck swelling is visible from outside. So, quinsy-like picture with the neck swelling has to be a diagnosis of parapharyngeal abscess. Treatment is external incision and drainage along with antibiotics. Beta. Samjhe baat? Chalo. Answer this question now. A 4-year-old child comes to you with complaints of respiratory distress along with an inspiratory stridor along with fever. The child is also having a hot potato voice or a muffled voice, and the X-ray soft tissue neck lateral view has been given below. Okay? If you zoom in, the X-ray soft tissue neck lateral view seems something like this. What is the classical diagnosis? We know this is a very similar case to that of nothing else but acute epiglottitis. बराबर acute epiglottitis में ऐसा केस देखा हमने, right? A 2 to 8-year-old child coming to you with complaints like respiratory distress, inspiratory stridor, high grade fever, hot potato voice, okay, and X-ray soft tissue neck given. So it is very similar to acute epiglottitis, but it is not acute epiglottitis. The reason it is not acute epiglottitis, bache, because you are not able to see any swollen epiglottis over here. You are not able to see any thumb sign over here. क्या दिख रहा है उसके बजाय? We are able to see, beta, a widening of prevertebral shadow. Can you see in front of the cervical vertebra? There is a wide shadow which is seen, right? So there is a widening of the prevertebral shadow. Why? Because there is collection of pus in front of the cervical vertebra. Okay, there is collection of pus in front of the cervical vertebra that leads to this widening of prevertebral shadow. But along with that, you can see the cervical spine or the cervical vertebra appears absolutely normal. Barabar, the cervical spine or cervical vertebra appears absolutely normal. So there is a normal cervical spine. So we know this is actually a collection of pus, not in the prevertebral space, but in the retropharyngeal space, beta. Very good. And if there is collection of pus in the retropharyngeal space or in the spaces of Gillette, as we call it as, we know classically the diagnosis has to be an acute retropharyngeal abscess. And I hope all of you quite remember that acute retropharyngeal abscess has a very similar presentation to that of acute epiglottitis. Yaad rakhna, acute epiglottitis and acute retropharyngeal abscess, both these conditions are very, very similar to each other. Okay? So the diagnosis is classically acute retropharyngeal abscess, has to be remembered. Samjhe baat? Similar presentation to acute epiglottitis, but X-ray soft tissue neck lateral view showing you widening of prevertebral shadow with a normal cervical spine has to be a diagnosis of acute retropharyngeal abscess, beta. That has to be remembered. Now, as this child is having respiratory distress or dyspnea, the emergency management or the first line management will always be the airway. And if I want to manage the child's airway, beta, obviously the emergency treatment should be intubation or tracheostomy. Let me know in the chat box. The emergency treatment or the airway management will be done by intubation or tracheostomy. Let me know in the chat box. Bolo. It should be done by intubation or tracheostomy, which is very good. That has to be done by tracheostomy, beta. The reason being, in cases of retropharyngeal abscess, beta, if you ask the patient to open the mouth on the posterior pharyngeal wall, you will be able to see the swelling. Why? Because behind the posterior pharyngeal wall or behind the pharyngeal wall, beta, in the retropharyngeal space, there is collection of pus. Easily on the posterior pharyngeal wall, there is a swelling, due to which the ET intubation or an endotracheal intubation, basically, beta, okay, it is going to become extremely difficult. Okay, so do remember, in this condition, the treatment is nothing else but tracheostomy for airway management, because intubation is extremely difficult. Condition being, beta, do remember, X-ray is always needed to differentiate between acute epiglottitis and retropharyngeal abscess. But in case if X-ray is not given, you have to see for swelling. If they say swelling is present on posterior pharyngeal wall, unilateral swelling on posterior pharyngeal wall, that has to be a diagnosis of retropharyngeal abscess. If there is no unilateral swelling on posterior pharyngeal wall, it is more likely to be a case of acute epiglottitis, beta. Samjhe baat? That is what is important. Tripod position which is there, it is more classical of acute epiglottitis. It is not seen usually in a case of retropharyngeal abscess. That is what is important. Tripod position is more classical of epiglottitis. Hopefully clear hai baat yahan tak? So that is what is important. Now here we know, as it is collection of pus or an abscess, beta, treatment is nothing else but peroral incision and drainage along with antibiotics. As it is an abscess or pus collection, again, treatment has to be a peroral incision and drainage. Jo swelling dikh rahi hai on the posterior pharyngeal wall, you have to make an incision over there and drain all the pus from the retropharyngeal space. So peroral incision and drainage along with antibiotics has to be done. Samjhe bache? Chalo, great. Now we'll do oral cavity and then we'll take a break before nose and ear, beta. Oral cavity mein nothing else but we will cover it in surgery also. Oral cavity mein we have to talk about the pre-malignant lesions. Pre-malignant lesions ka matlab kya? The conditions which will increase the risk of malignancy or the oral cancer, beta. Okay, if I talk about the pre-malignant lesions or the pre-malignant conditions in the oral cavity, the first one that you are able to see, you can see here there is a white patch in the oral cavity, and I hope all of you are quite aware, if there is a white patch in the oral cavity, it is classically known as nothing else but leukoplakia, beta. Leuko means white and plakia means patch. Barabar? So do remember, the white patch in the oral cavity is classically known as leukoplakia. And do remember, leukoplakia is the most common pre-malignant lesion of oral cavity, beta. Leukoplakia is the most common pre-malignant lesion in the oral cavity. That has to be remembered. Samjhe baat? Next important is this. Over here, you are able to see a red patch in the oral cavity, bache. And red patch in oral cavity is nothing else but called as erythroplakia. Erythro means red and plakia means patch. Barabar? So erythroplakia is the red patch in the oral cavity. And do remember, erythroplakia is more dangerous. Why? Leukoplakia increases the risk of malignancy or increases the risk of oral cancer by around 3 to 5 times. But erythroplakia increases the risk of malignancy by almost by 6 to 9 times, beta. So it increases the risk of malignancy, beta. It increases the risk of malignancy by almost 6 to 9 times. Okay, so therefore it is considered as more dangerous as compared to leukoplakia. So leukoplakia being more common and erythroplakia being more dangerous, beta. हमें पता है whether it is a pre-malignant lesion in the oral cavity or it is the oral cancer, beta. These conditions commonly happen due to what reason? These conditions, beta, commonly happen due to the risk factors like smoking, tobacco, and tobacco, when I say, everything comes in that tobacco. Gutkha, khani, pan, tambaku, everything. Okay? So it happens mainly due to smoking, tobacco, betel nut, betel leaf, areca nut, okay? Pan, supari, everything like that. Hopefully clear. Zuba, kesri, everything comes in that itself. Clear hai? Samjhe baat? So due to smoking, tobacco, betel nut, betel leaf, all of these are considered as risk factors for the pre-malignant lesions or for the oral cancer, beta, has to be remembered. Samjhe baat? Treatment, if they ask you now, what should be the treatment? हमें पता है, if it is only a pre-malignant lesion, beta, first is avoid all the risk factors. Ask the patient to quit smoking, ask the patient to quit tobacco, ask the patient to quit every risk factor beta. So avoid risk factors. Second, give antioxidant. Reason, it is the oxygen free radicals beta which are causing this damage. Okay, so as the oxygen free radicals are causing the damage, you can prescribe antioxidants. And third, better is to go for a surgical excision beta. The best treatment will be surgical excision. Reason, we know it is a pre-malignant condition beta, so it can progress into a malignancy or a cancer at any given point of time. So better is to go for a surgical excision of this cancer. Surgical excision of this precancerous condition. Commandos is done for cancer, not for pre-malignancy. I am talking about the treatment of these pre-malignant lesions beta over here. समझे बात? Like erythroplakia or leukoplakia. Understood? Now, if I talk about oral cancer, yes. Okay, if I talk about the oral cancer or the oral cavity cancer, I hope all of you are quite aware beta. Oral cancer will be a squamous cell carcinoma or adenocarcinoma. Let me know in the chat box. Oral cancer will be squamous cell carcinoma or an adenocarcinoma. Let me know in the chat box. Bolo. Very good. We know the normal lining of the oral cavity is a stratified squamous epithelium. That's the reason. The more common type of oral cancer has to be a squamous cell carcinoma, and that is the reason some cases may be associated with HPV or human papilloma virus. Shabash. So it is commonly a squamous cell carcinoma. Yaad rakhna, only 3 sites in GIT where squamous cell carcinoma is common. 1, oral cavity. 2nd, esophagus. And 3rd, anal canal. Oral cavity, esophagus, anal canal mein squamous cell carcinoma is common. Otherwise, everywhere in GIT, it is an adenocarcinoma itself. समझे बात यहाँ तक? Great. Now, if they ask you what is the most common site, we know the most common site of oral cavity cancer worldwide. If they ask you, beta, the most common site of oral cavity cancer worldwide, answer is this. Can you see this ulceroproliferative region on the lateral border of tongue? Yes. So yaad rakhna, the most common site for oral cavity cancer worldwide is going to be your lateral border of tongue beta. The most common site worldwide is lateral border of tongue. But in case if they ask you what is the most common site in India, okay, if they ask you what is the most common site for oral cavity cancer in India, answer will be what? Let me know in the chat box now. Iska answer batao. The most common site for oral cavity cancer in India beta. ठीक है, the most common site for oral cavity cancer in India if they ask you. Very good. So we know beta India mein what is the cause for oral cavity cancer? It is nothing else but your gutka, pan, tobacco, all of that. Where they put it usually? They put it in between the gums and the buccal mucosa. उस जगह में रखते हैं ना वो, that is known as gingivobuccal sulcus, the space over here, right? So most common site of oral cancer in India basically beta is known as your gingivobuccal sulcus. If you have to choose one among them, then my answer will be buccal mucosa. Otherwise, the answer has to be a gingivobuccal sulcus. So gingivobuccal sulcus is the commonest site for oral cavity cancer in India. That has to be kept in mind. Now, if they ask you what is investigation of choice, we know that as it is a case of cancer, the best investigation for cancer is always a biopsy or a histopathological examination, except in 2 conditions. कौन से दो? First, if it is a highly vascular tumor, biopsy is contraindicated due to the risk of bleeding. Second, while taking the biopsy, if there is a risk of spread beta, only in these 2 conditions we don't go for a biopsy. Otherwise, the best investigation for cancers is always a biopsy. So investigation of choice will be biopsy, which shows you the classical keratin pulse. Reason, as it is a squamous cell carcinoma, biopsy will show us the classical keratin pulse beta. That has to be remembered. ठीक है, तो biopsy या histopath करोगे, you are able to see the classical keratin pulse. Understood? If they ask you treatment, तो हमें पता है बेटा that in cases of oral cancer, the treatment is nothing else but an oromandibular dissection. Okay, in a case of cancer beta, the treatment is nothing else but a oromandibular dissection. And this oromandibular dissection which is there basically is known as nothing else but commandos operation, as somebody rightly said, right? This oromandibular dissection is classically known as the commandos operation. क्या क्या करता है? We have to remove the cancer beta, and for the removal of cancer basically we do a wide local excision. Okay, that is we remove the cancer along with some normal margins, that is wide local excision. If mandible is involved, we also go for a mandibulectomy, and we have to place a flap. The best flap that we place after oromandibular dissection or after commando's operation will be, let me know in the chat box which है. Please tell me that after the oromandibular dissection or commando's operation, the best flap that we will use, important from surgery beta. कौन सा flap use किया जाता है commonly? The best flap or the most common flap that we use beta after the oromandibular dissection or commando's operation. The most common or the best flap that is used. Forehead is not very common. The most common flap that we use is basically the PMMC flap beta. And when I talk about the PMMC flap, iska matlab kya? It is a flap taken from the chest wall of the patient. And when I say chest wall, that means pectoralis major myocutaneous flap. It is the pectoralis major myocutaneous flap. This flap is commonly taken beta to cover this exposed area after oromandibular dissection or commando's operation. Hopefully clear to all of you now. So these are the points. Take your break basically for 15 minutes, 1-5, and after that we'll start the session again. Okay? And we'll discuss about nose, paranasal sinuses, and the ear. चलो बच्चों, let's start. Hopefully all of you are back. 15 minutes का break था. Shall we start? Great. Chalo. So let's talk about the next topic, and after throat we have to talk about the nose and the paranasal sinuses beta. Clear? Now the first condition we will talk about is about the external nose. Before that, if they ask you basically how much part of the external nose is bony and how much part is cartilaginous, that was a previous year question beta. ठीक है? तो इन PYQ they asked about the external nose कि कितना हिस्सा bony होता है और कितना हिस्सा cartilaginous होता है. तो I hope चलो. So please remember beta that external nose may definitely the upper one third which is there beta. You can see if you feel the upper one third of the nose, it is going to be hard because it is made up of pair of a nasal bones beta. So upper one third in the nose is going to be bony in nature, whereas the lower two third if you feel the lower two third of the nose beta, you will feel the lower two third of the nose is extremely softer. Reason? This is made by three pairs of cartilages beta. This is made by three pairs of cartilages. It is going to be cartilaginous in nature. Okay? So this was the PYQ which has been asked. So be aware that the upper one third of the nose is going to be bony in nature, made by a pair of nasal bones, and lower two third of the external nose is going to be cartilaginous, made by three pairs of cartilages beta. That has to be remembered. No issues with this, anybody? Clear yahan tak baat? Now if they ask you about the first condition, that is nothing else but this one you are able to see in the picture beta. Here you can see the appearance of the nose appears extremely rough beta, usually like the surface of a potato, and this condition is classically known as rhinophyma, which literally means potato nose beta. Rhinophyma ka literal meaning is nothing else but potato nose. Let me know in the chat box that rhinophyma or potato nose happens due to the hypertrophy of which glands beta? Sweat glands or sebaceous glands? Thank you so much beta. Please tell me, rhinophyma or potato nose happens due to the hypertrophy of which glands? Sweat glands or sebaceous glands? Very good. It usually happens due to the hypertrophy of sebaceous glands. That is what is important. It happens due to the hypertrophy of sebaceous glands in the skin of external nose. That is what is important to be remembered beta. And we know, if I talk about rhinophyma which is there or potato nose which is there, basically it is a type of which condition? Let me know in the chat box. From dermatology, if I ask you that this rhinophyma or this potato nose which you might have seen in Om Puri, right? So this condition is basically a type of which dermatological condition? Very good. This is actually a case of nothing else but rosacea, also called as acne rosacea beta. Yes, very good. Okay, it is a type of rosacea which is also known as acne rosacea. There are three types of rosacea you might have heard about: the erythemo-telangiectatic type, papillopustular type, and the phymatous type. So phymatous type of rosacea is nothing else but called as rhinophyma beta. तो कभी कभी क्या कर सकते हैं वो, they may not give you rhinophyma in the option. So do remember, find acne rosacea in the options. Clear? Treatment, we know we have to excise this skin which is affected, and after you have excised this skin with laser, you have to cover this exposed area with some skin graft beta. So the treatment of rhinophyma or potato nose is nothing else but laser excision of the affected skin followed by skin grafting over it. Hopefully clear? Chalo. Now another very common and sarkari question of the FMG examination is this: we are having an ulcerated lesion beta with a necrotic base along with rolled out edges or the rolled out margins on the lateral wall of nose, as you are able to see in the picture also. So in this picture, if you see, this is an ulcerated lesion with a necrotic base and rolled out edges or rolled out margins basically. This is classically known as nothing else but, very good, it is classically known as a BCC, that is basal cell carcinoma or a rodent ulcer beta. Shabash. So the diagnosis of this condition is nothing else but a basal cell carcinoma, also called as rodent ulcer. याद रखना, the most common skin cancer is going to be squamous cell carcinoma. The most common skin cancer is squamous cell carcinoma, but the most common skin cancer in face is a BCC or a basal cell carcinoma. Most common skin cancer in face is a BCC or a basal cell carcinoma beta, has to be remembered. The keyword of the whole question can be this: rolled out edges. Yes, a ulcerated lesion with rolled out edges is a classical feature of nothing else but basal cell carcinoma itself. ठीक है. The most common site if they ask you for the basal cell carcinoma is going to be the medial canthus of eye beta. ठीक है, ये जो inner canthus है या medial canthus है, so this medial canthus of eye is actually going to be the most common site for the basal cell carcinoma, followed by lateral wall of nose. So most commonly it is found in this medial canthus of eye, followed by the lateral wall of nose. That is what is important to be remembered. If they ask you what is the investigation of choice, just now before break I have told you beta, the best investigation for any cancer is a biopsy or a histopathological examination. So the investigation of choice in basal cell carcinoma is also a biopsy or histopath itself beta, has to be remembered. Now there are two types of biopsy. Let me know if the basal cell carcinoma or the rodent ulcer is small in size, you will prefer going for an incisional biopsy or an excisional biopsy beta. If it is small in size, you prefer going for an incisional or an excisional biopsy. Let me know in the chat box. Anybody? If the BCC is small in size, you prefer going for incisional or excisional biopsy? Very good. If it is small in size beta, we better go for an excisional biopsy. Reason is, if it is small, then better is to remove the whole ulcer or excise the whole ulcer and send it for histopath. Barabar? Because that will not only help us in diagnosis but even the treatment. Barabar? If the ulcer is big in size, then we go for an incisional biopsy when we only take a small tissue or a small sample beta. Understood? So that is what is important to be remembered. Okay? Thank you so much. So investigation of choice is biopsy. For smaller ones, excisional biopsy. For larger ones, incisional biopsy. And the treatment is nothing else but a wide local excision. What is wide local excision? Removal of the cancer or removal of the malignancy along with some normal margins beta. That is known as the wide local excision beta, has to be remembered. Clear? Chalo. So that is what is important. Now, here is the question from trauma beta, and that question states, we are having a young male patient who presents to us with complaints after a facial trauma beta. Okay, a young male patient presents to us after a facial trauma with complaints like pain and swelling over the nose or around the nose beta. The patient is having pain and swelling around the nose. X-ray has been given below. If you see the X-ray, this is the classical picture. What is seen on the X-ray beta? If you see the X-ray carefully, this is your nose. This is the upper 1/3 of the nose, which is bony, which is made by a pair of nasal bones. And in this beta, you can see there is a fracture line which is traveling. Can you see this? Yes. So this is a classical picture of nothing else but which case? A nasal bone fracture. Shabash. So diagnosis in this case is nothing else but of a nasal bone fracture beta. That has to be remembered. Now, if they ask you in the examination that which is the most common facial bone fractured or which is the most common bone fractured in a facial trauma, my answer will be a nasal bone fracture beta. But I am asking you the other question, and that question is, which is the second most common facial bone fractured? After nasal, which is the second most common facial bone fractured? Let me know in the chat box beta. So we know that nasal bone fracture is the most common facial bone fracture that is seen beta. Reason, it is the most prominent bone of the face, and as it is being the most prominent bone of the face, it is the commonest one to be fractured during a facial trauma beta. Very good, shabash. After nasal bone fracture, The second most common bone that is fractured beta in the face is the zygoma or the zygomatic bone. Yes, the second most prominent bone of the face, zygoma or the zygomatic bone, is the second most common facial bone to be fractured. Shabash, very very good. Now treatment agar पूछा जाए, do remember beta in this condition, let me know. I am giving you two options. One option is sorry, immediate close reduction using Walsham forceps. Another option is wait for 5 to 7 days and then go for a close reduction. What you are going to choose, immediate close reduction or a delayed close reduction? What you will choose in this condition? In this question, if they ask you what should be the treatment, your treatment should be preferably, anybody? In this condition, my treatment has to be nothing else but, very good, I have to wait for a span of 5 to 7 days beta and let the swelling or let the edema resolve beta. Once the edema or the swelling has been resolved properly, then I will go for a close reduction. Reason, as they have said, there is swelling over the nose beta. If I attempt or if I try to go for an immediate close reduction, the reduction will not be proper. Okay, the reduction will not be done properly and that can lead to a malunion which can later on lead to a deformity. बराबर, अगर मैं swelling के time पे reduce करने की कोशिश करूंगा तो malunion के chances ज़्यादा होंगे. Clear? So as they have mentioned swelling, that one word can change your answer. So if swelling is present, then wait for 5 to 7 days beta and let the edema subside or let the edema resolve. Once the edema has been resolved beta, then definitely go for a close reduction. Okay, wait for 5 to 7 days, then go for close reduction beta. And we know close reduction in cases of nasal bone fracture should be done with the Walsham forceps or Ash forceps. Let me know in the chat box. Close reduction in a patient of nasal bone fracture should be done with the help of Walsham forceps or the Ash forceps. Anybody? Let me know in the chat box. The nasal bone fracture mein close reduction is done with the help of, shabash, very good all of you. Yes, it is commonly done with the help of Walsham forceps beta. Ash forceps are basically used for close reduction of the nasal septum fracture. So if there is a nasal septum ka fracture beta, then we have to do a close reduction using the Ash forceps. That is what is important. Clear hai baat? That is what is important to be remembered. So yaad rakhna, if there would be a nasal septum fracture, you might have heard about nasal septum fractures like the Jarjave fracture or the Chevalier fracture beta. So nasal septum fracture like the Jarjave or Chevalier fracture, in that the treatment is close reduction and that close reduction is usually done using the Ash forceps beta. Okay, that close reduction which we do in nasal septum fracture, it is usually done using the Ash forceps. Hopefully clear to all of you now. So this is what is important to be remembered for the examination. Okay. Next important, if I talk about now, we all know that this is the medial wall of the nose called as the nasal septum. Barabar, this wall which divides the nasal cavity or which divides the nostrils into two halves is known as my medial wall of the nose or the nasal septum. But this one which forms the external nose are my lateral walls of the nose beta. Now on the lateral wall of the nose, from inside if you see, अंदर से अगर देखोगे तो on this lateral wall of nose there are three bony projections and these three bony projections are known as concha, right? We have the inferior concha, middle concha and the superior concha beta. Now when these three bony projections or concha, they are covered by a mucosal layer, जब उनके ऊपर एक mucosa की परत चढ़ा दोगे, these are classically known as turbinates beta. That is your inferior turbinate, middle turbinate and superior turbinate. Now let's say this is your lateral wall of nose and this is the turbinate. In between the lateral wall and turbinate we have some space and that space is known as your meatus beta. Barabar, below inferior turbinate we have the inferior meatus, below middle turbinate we have the middle meatus, below superior turbinate we have superior meatus. But above superior turbinate the space which is present is either called as the supreme meatus or we call it as the sphenoethmoidal recess. Okay, above superior turbinate the space is known as supreme meatus or the sphenoethmoidal recess. Clear? Now why these meatuses are important? Because a lot of structures drain into the nose at the level of these meatuses itself. Okay, so that is important. First of all, if I talk about the longest meatus known as inferior meatus, in the inferior meatus beta, the NLD
or the nasolacrimal duct is going to open up. Okay, the inferior meatus is the site for drainage of NLD or nasolacrimal duct. We know the nasolacrimal duct will drain the tears in the inferior meatus beta. Now let me know, if I say if the nasolacrimal duct is blocked, so the patient develops a condition called as dacrocystitis beta. Barabar? If the nasolacrimal duct is blocked, patient develops a problem known as dacrocystitis, for which we perform a surgery known as DCR or a dacrocystorhinostomy. In this procedure, we create a new opening for the nasolacrimal duct. In which meatus? Let me know in the chat box. So, if a patient is suffering from dacrocystitis, which we usually go for a treatment that is nothing else but called as DCR. So if a patient is having dacrocystitis or infection of the lacrimal sac, okay, due to blockage of NLD, we go for a surgery called as DCR or a dacrocystorhinostomy. After a dacrocystorhinostomy, a new opening for the nasolacrimal duct, very good, has to be made in the middle meatus. This is a PYQ in the FMG exam from Ophtha or ENT. Do remember this, okay? So after a DCR or a dacrocystorhinostomy surgery, the new opening of NLD is usually made in the middle meatus. Reason being, middle meatus is much wider as compared to the inferior meatus, so it does not commonly get blocked beta. That's the reason after DCR, create a new opening in the middle meatus of the nose. Hopefully clear hai yahan tak. Next important, we know middle meatus beta is the site of drainage for 3 paranasal sinuses. I hope all of you are quite aware. Around the nose, we have 4 paranasal sinuses beta. What are paranasal sinuses? These are hollow cavities or the empty spaces inside the bone beta. And these hollow cavities or empty spaces are lined by mucosa and they secrete mucus. Now this mucus which is secreted, that has to drain somewhere, na? So the mucus which is secreted by these paranasal sinuses will drain in the nose or will drain inside these meatuses beta. Samjhe baat? 4 paranasal sinuses will be, first is the frontal sinus, second is the maxillary sinus, third is the ethmoid sinus, and behind the orbit we have the sphenoid sinus. Out of these 4 beta, do remember middle meatus is the site of drainage for the largest sinus called as maxillary sinus, the most irregular sinus known as frontal sinus, and the third one, the anterior ethmoidal air cells or the anterior ethmoidal sinus beta. Clear? These 3 sinuses, maxillary, frontal and anterior ethmoidal, drain into middle meatus. Next is the superior meatus. Do remember, superior meatus is the site of drainage for posterior ethmoidal air cells or the posterior ethmoidal sinus. So anterior ethmoidal air cells drain into middle meatus, but posterior ethmoidal air cells drain into superior meatus beta. And last is your sphenoethmoidal recess, also known as your supreme meatus. So your sphenoethmoidal recess or the supreme meatus is the site of drainage for your sphenoid sinus. It is the site of drainage for your sphenoid sinus. Hopefully clear hai yahan tak? Chal. So this is what is important to be remembered. Now, here there's a question which states, I hope all of you are quite aware beta, this condition you might have heard about. First is, a neonate was born preterm beta. Preterm matlab before 37 weeks period of gestation. So a neonate was born preterm, okay, and he appears cyanotic at birth. Cyanotic matlab he appears blue at birth beta. Reason is hypoxia or hypoxemia beta. As the child may not be able to breathe, there is cyanosis which is seen beta due to hypoxemia. The child appears cyanotic at birth and this cyanosis worsens as the child feeds beta. So as the child feeds, the cyanosis worsens and the cyanosis improves, or you can say the child turns pink as soon as he starts crying. Matlab, as soon as he starts crying or as soon as he opens the mouth for crying beta, immediately the child turns pink. What is the classical diagnosis? Very good. Yes, it is a classical case of nothing else but a bilateral choanal atresia. This has been a previous year FMG question beta. Do remember that. It is a classical case of nothing else but bilateral choanal atresia beta. What is choana? So we have discussed already. Choana is nothing else but the posterior nasal opening. Do remember beta, in the fetal life, between the nasal cavity and the oral cavity, we have a septum. And this septum which is there is called as bucco-nasal septum. Now, this bucco-nasal septum should disappear and a posterior nasal opening called as choana should form beta. The bucco-nasal septum should disappear at birth and a choana or a posterior nasal opening should form. But in some children, what happens? The choana is not formed or the bucco-nasal septum does not disappear. So condition where choana is not formed, bache, due to the persistence of bucco-nasal septum, very good, is classically called as choanal atresia. Atresia means no development. So in this condition, the choana or the posterior nasal opening does not develop. And as the choana does not develop, beta, the child cannot breathe by nose. And the problem is what we know, that neonates are obligatory nasal breathers. This has been a PYQ again. You have to remember from pediatrics also. Yaad rakhna, neonates are considered to be obligatory nasal breathers. And as neonates are obligatory nasal breathers, beta, that's the reason now. As neonates are obligatory nasal breathers, that's the reason what is going to happen. As the child is having a choanal atresia, the child is not able to breathe, causing asphyxia or hypoxia, and that leads to cyanosis. Now, why the cyanosis is basically going to worsen, beta, when the child feeds? Reason, for feeding the child will close the mouth, and if the child closes the mouth, no air is entering into the airway, therefore the hypoxia or the cyanosis worsens. But whenever the child opens the mouth for crying, accidentally he opens the mouth for crying, some air enters inside the airway, and that is the reason why the cyanosis decreases or the hypoxia decreases. Beta, samjhe baat yahan tak? So that is what is important. So this is a case of bilateral choanal atresia. You can see the bucco-nasal septum is still persistent. It has not disappeared, and therefore this posterior nasal opening known as choana is not formed. We know bilateral choanal atresia is commonly associated with a syndrome called a charge syndrome. Beta, yaad rakhna, charge syndrome is a combination of multiple congenital anomalies, beta, which will happen. So yaad rakhna, bilateral choanal atresia is very commonly associated with the charge syndrome. Has to be remembered. Clear? Treatment, if they ask you now, do remember the first line management in a case of choanal atresia is what? You are going to do this, beta. Yes, if you try to pass the nasogastric tube or the rise tube, you will not be able to pass because the posterior nasal opening of the choana is not formed. Very good. So for treatment, what we have to do? We have to keep the baby's mouth open, beta. Reason, to keep the baby's mouth open, we can insert a wide bore nipple, beta. Reason, as we insert the wide bore nipple and keep the baby's mouth open, the air will keep on entering in the airway and the child will not develop cyanosis or the child will not have respiratory distress, beta. And this technique is classically called as, very good, this technique is classically referred to as nothing else but the McGovern's technique, beta. This technique which is there of wide bore nipple insertion in the mouth is classically known as McGovern's technique. Now August 2020 FMGE examination, beta, McGovern's technique or insertion of wide bore nipple was not an option. So if McGovern's technique or wide bore nipple insertion is not an option, the other option that was given was insertion of oropharyngeal airway or the Goodell's airway. We know we have to keep the baby's mouth open now. So if you don't have the wide bore nipple, insert Goodell's airway, right? So if the wide bore nipple is not available, you can even use the Goodell's or the oropharyngeal airway as well to keep the baby's mouth open, which is hopefully clear to all of you now. So that is what is important. No issues with this. Understood? Clear yahan tak? Now we know that this will only help in the temporary management. This will only help in curbing down the respiratory distress in the child, beta. But what is the definitive management? Definitive management is nothing else but you have to remove the bucco-nasal septum. We have to do a surgical resection of the bucco-nasal septum, which is called as recanalization surgery, beta. And this recanalization surgery should be done not immediately at birth, but it should be done at 1 year of age. And this was a PYQ again, beta, in examination. They asked you to choose the wrong statement or an incorrect statement about choanal atresia. One of the statement was recanalization surgery should be done immediately at birth. No, recanalization surgery is usually done at 1 year of age. So it was a wrong statement. Clear? Charge syndrome is a combination of multiple congenital anomalies together, like the congenital heart defects, anorectal malformations, renal anomalies, all of them. Okay? समझे बात यहाँ तक? So that is what is important. Next is this question that you are able to see over here, beta. What is the question? A patient comes to you with complaints of nasal congestion along with rhinorrhea, that is runny nose, post-nasal drip or a post-nasal discharge, and headache. What is the likely diagnosis you should think about? Let me know in the chat box. Bolo. Great. So please remember, beta, here definitely the patient is having a post-nasal drip. Post-nasal drip matlab you might have experienced after a runny nose or after a common cold, beta. When you develop sinusitis, you are having a constant discharge going in on your throat, beta. There is a constant discharge going in your throat basically. That is what is known as a post-nasal drip or a post-nasal discharge, beta. And that is a very classical case of sinus. That is a very classical symptom of sinusitis, beta. Yes. So do remember the diagnosis in this patient is nothing else but sinusitis, also called as rhinosinusitis. Why? Reason? We know initially the patient may develop rhinitis. Due to rhinitis, what happens is the meatuses are blocked, and as the meatus will be blocked, beta, the sinuses are not able to drain the secretion. As the sinuses cannot drain the secretions, these retained secretions in the sinuses will get infected, and that infection of the paranasal sinuses is known as sinusitis बच्चे. तो जब भी sinuses अपने आप को drain ना कर पाए, तब the patient will develop sinusitis, beta. We know it can be bacterial, it can be viral, it can be fungal, but the most common cause is going to be bacterial, beta. And which is the leading cause for a bacterial sinusitis? So we know the most common cause for a bacterial sinusitis is nothing else but Streptococcus pneumoniae, beta. The most common cause of bacterial sinusitis is strep pneumoniae or Streptococcus pneumoniae, also known as pneumococcus, beta. So Streptococcus pneumoniae is the leading cause for a sinusitis case. Anybody, let me know in the chat box which is the most common type of which is the most common cause of fungal sinusitis. If they say what is the most common cause of fungal sinusitis, answer will be, if they ask you the most common cause of fungal sinusitis, answer is going to be, bolo. Most common cause overall is strep pneumonia, also known as pneumococcus. But most common cause of fungal sinusitis, if they ask you, answer has to be Aspergillus fumigatus, beta. The commonest cause of a fungal sinusitis, if they ask you, beta, the answer has to be nothing else but Aspergillus fumigatus. Barabar. So do remember both the points. That has to be kept in mind. Okay? Answer is Aspergillus fumigatus. Clear? Next important, if I talk about now. Okay? Next important, if I talk about is what is going to be the first line investigation for a case of sinusitis. So if they ask you the first line investigation in a case of sinusitis, answer is always and always a X-ray PNS or a X-ray paranasal sinuses, beta. Okay? So do remember the first line investigation is going to be a X-ray PNS or X-ray paranasal sinuses. We know that X-ray PNS is taken in various views, beta. The first one that you are able to see is this one over here. क्या लग रहा है? It seems as if the person is looking upwards and drinking water, right? It seems like that now. So this is classically known as my occipitomental view, beta. And this occipitomental view which is there, it is classically also known as which view? Waters view, bache. This occipitomental view that you are able to see is also classically known as the Waters view, beta. Let me know in the chat box that this Waters view which is there, it is also called as, if it is an open mouth Waters view, it is also known as, let me know in the chat box. As you are able to see, this is an open mouth Waters view. It is also going to be called as, anybody? Very good. We know, beta, as it is an open mouth Waters view, it is also classically known as the Pierce view, beta. As it is an open mouth Waters view, it is also known as the Pierce view. That has to be kept in mind. Clear? Now here you can see all the sinuses, frontal sinus, maxillary sinus, ethmoid sinus. But if they ask you that Waters view or the Pierce view is the best view for which sinus, so we all are quite aware, Waters view or the Pierce view is the best view for the maxillary sinus, beta. Okay, it is always the best view considered for the maxillary sinus, has to be remembered. No issues with this. Another question, if I ask you, which sinus is never visible on the Waters view? Let me know in the chat box. Which sinus is going to be never visible on Waters view, beta? which sinus is never visible on the water's view? Let me know in the chat box. Whichever water's view you take, this sinus is never visible on the water's view. Let me know in the chat box. Anybody? No, it is not the sphenoid. The sinus which is never visible on water's view. Yes, very good, Swati. It is posterior ethmoid. Do you remember, beta, that the sinus which is never visible on the water's view is going to be your posterior ethmoidal sinus or the posterior ethmoidal air cells, beta. Clear about? So do remember the posterior ethmoidal sinus or the posterior ethmoidal air cells. They are never visible. They are never visible on the water's view. That is what is important. The posterior ethmoidal air cells are never visible on the water's view. This is important to remember. समझे बात? That is important. Next, this is the picture that you are able to see. This is nothing else but a picture of X-ray skull lateral view, beta. Here you are able to see. This is a classical picture of the X-ray skull lateral view. And do remember, X-ray skull lateral view is the one where all the sinuses are visible, beta. Okay? So do remember, X-ray skull lateral view which is there, it is the only view of X-ray PNS, beta, where all the sinuses are visible. If you see properly, this is the sphenoid sinus, this is the posterior and the anterior ethmoidal air cells, this is the frontal sinus, and this is the maxillary sinus. So all sinuses which are there, beta, those are going to be clearly and properly visible on an X-ray skull lateral view. But yes, we know that X-ray skull lateral view is the best view for the sphenoid sinus. X-ray skull lateral view is the best view for sphenoid sinus, but all the sinuses are visible only and only on the X-ray skull lateral view, beta. समझे यहाँ तक? Next, this is the one where it seems as if the patient is looking in front, called as the occipitofrontal view, beta. And this occipitofrontal view that you are able to see is also called as my Caldwell's view. The occipitofrontal view that you are able to see is also known as your Caldwell's view, beta. That has to be remembered. And we know Caldwell's view is the best view for the frontal sinus and the ethmoid sinus, beta. The best view for the frontal and the ethmoidal sinus, answer has to be the Caldwell's view, also called as the occipitofrontal view. Clear? Now, if they ask you basically, what is the best radiological investigation for a case of, what is the best radiological investigation, beta, for a case of sinusitis? So, yaad rakhna, the best radiological investigation for a case of sinusitis is nothing else but a NCCT PNS or a non-contrast CT scan of paranasal sinuses. So NCCT PNS or a non-contrast CT scan of paranasal sinuses is the best radiological investigation overall. And when I do a NCCT PNS or HRCT PNS, you can go for. So on the X-ray PNS or the CT PNS, beta, you are able to see the classical picture. If you compare both these maxillary sinuses, क्या difference दिख रहा है? In one sinus, there is a complete blackish appearance. That means it only contains air. But in second sinus, if you see, beta, some area appears black and some areas appears white or gray, beta. Reason, this area which appears black, it contains air. That is the normal finding. But this area which appears whitish or grayish, it contains fluid, that is nothing else but pus. So if the X-ray PNS or if the NCCT PNS shows you the air fluid levels, beta, that is what is diagnostic of sinusitis, बच्चे. तो कैसे पहचानना है whether the patient is having sinusitis or not? If air fluid levels are visible on the X-ray PNS or the NCCT PNS, that is how you diagnose a case of sinusitis, बच्चे. ठीक है? The air fluid levels if seen, it is a case of sinusitis, has to be remembered. Now, if they ask you what is the gold standard or the best investigation for sinusitis overall, the gold standard or the best investigation for a case of sinusitis overall is nothing else but pus culture, beta. Obviously, you will perform a diagnostic nasal endoscopy. By that endoscopy, you will take the pus and send it for culture. Reason, you will get to know exactly which organism is causing the infection and which antibiotics the organism is sensitive to, beta. बराबर है बात? So definitely gold standard or the best investigation overall can be a pus culture, and this pus culture is obtained by which investigation? The pus is obtained by a diagnostic nasal endoscopy, beta. The pus for culture is basically taken by the diagnostic nasal endoscopy. Hopefully cleared all of you now. Chalo. The pus culture which is obtained by diagnostic nasal endoscopy, should be the best or the gold standard investigation, which will tell you about the exact organism causing the infection. बराबर है? Treatment. We know majority cases of sinusitis are bacterial in nature. So obviously the treatment has to be nothing else but antibiotics, beta. But topical antibiotics or nasal drops, they are not going to work. We have to give systemic antibiotics or oral antibiotics, beta. So the treatment in cases of sinusitis has to be oral antibiotics, and they should be given for a span of 3 weeks, beta. We have to give oral antibiotics and they should be given for a minimum duration of 3 weeks. Okay, and when we give oral antibiotics, beta, for a duration of 3 weeks, along with that you also give nasal decongestants. Okay, oral antibiotics along with nasal decongestants, and majority cases are going to resolve. बहुत सारे cases ठीक हो जाते हैं. But in case if the condition does not resolve even after 3 weeks of oral antibiotic therapy, beta, in those conditions we have to go for nothing else but a FESS. We have to go for nothing else but FESS, beta, called as a functional endoscopic sinus surgery, beta. ठीक है? In case the 3 weeks of oral antibiotic therapy fails, we have to go for nothing else but called as FESS, that is a functional endoscopic sinus surgery, where we enter inside the sinuses and we scrape out all the infected mucosa, beta, so that the infection gets completely and thoroughly resolved. Clear है बात? So FESS has to be done. Now in case during a FESS surgery, beta, whenever we scrape out the infected mucosa, we know that new mucosa will regrow or the new mucosa will regenerate. Please let me know in the chat box. When the new mucosa will regrow, we know a lot of adhesions or a lot of syncytiae are going to develop. So what is the drug that you apply to prevent the syncytiae or to prevent the adhesion, beta? So we know after the FESS surgery, there can be a problem of syncytiae formation. So if you want to prevent that syncytiae or that adhesions basically from forming, what is the drug that you should apply? This was a PYQ again. Whether it is the vocal cord or it is the sinuses, in them, if there is going to be syncytiae or adhesions, to prevent them, very good. The drug that we apply is known as mitomycin C, which has an anti-fibroblastic action, beta. We apply a drug basically called as mitomycin C, which is going to have an anti-fibroblastic action. That is what is important. Clear, shabash. To prevent syncytiae, apply mitomycin C. Now, let's talk about the next topic, and that is nothing else but a maxillary sinus carcinoma, beta. Now, if I talk about benign tumors, do remember, benign tumors or osteoma, it is more common in frontal sinus. The benign tumor or an osteoma is more common in the frontal sinus, beta, but the malignancy or the cancer is more common in the maxillary sinus. The malignancy or the cancers are more common in the maxillary sinus. If I talk about maxillary sinus carcinoma, it can be of both the types. Either it can be a squamous cell carcinoma or an adenocarcinoma, beta. Yaad rakhna, if it happens due to a nickel exposure, it is commonly going to be a squamous cell carcinoma. Nickel exposure causes a squamous cell carcinoma in the maxillary sinus. Whereas if it happens due to a hardwood dust or a furniture dust exposure, it is going to be an adenocarcinoma, bache. Yaad rakhna, in the maxillary sinus, if the malignancy happens due to nickel exposure, it is a squamous cell carcinoma. Due to a hardwood dust exposure, it is an adenocarcinoma. That is the basic thing that you have to remember. Now, whenever a patient will have maxillary sinus carcinoma, patient will come to you with complaints like cheek swelling is there, anesthesia over cheek is there. Okay? Patient may have invasion of the orbit. Multiple of these features can be present. If they say what is the investigation of choice, we know taking a biopsy from the maxillary sinus cancer is extremely difficult. Therefore, the investigation of choice is not a biopsy over here. The investigation of choice is CECT scan. Right? The investigation of choice is a CECT scan. Now, when I do a CECT, do remember, you will find the whole maxillary sinus appears whitish or grayish in color. But how to differentiate it from mucocele? Reason, mucocele, when a lot of mucus is filled in the sinuses, that will also appear completely white or completely gray. So the difference is, beta, always see the bone. If the bone is normal, it is a collection of mucus known as mucocele. But if the bone is eroded or if the bone is damaged, then it is a case of maxillary sinus carcinoma. क्लियर है बात? दिस इज हाउ यू डिफरेंशिएट, ठीक है? तो इन्वेस्टिगेशन ऑफ चॉइस इज अ सीसीटी स्कैन. Once the diagnosis is confirmed, and if you want to see the prognosis matlab outcome, whether the outcome of the patient will be good or bad after this case. So do remember beta that prognostic evaluation is done by this imaginary line. Let me know the name of this line beta. This was a PYQ. So here you can see a imaginary line from the medial canthus of eye till the angle of mandible. Now this line which is there beta, it will help us to decide the prognosis of the maxillary sinus carcinoma. How? If the cancer is above the line beta, it will have a poor prognosis or a bad prognosis. Why? Reason, if the cancer is yes. If the cancer is above the line, basically we know there will be an early orbital involvement, and due to the early orbital involvement it will have a poor prognosis or a bad prognosis. Samjhe baat? Yes. Very good all of you. This is classically known as the Ongren's line. So for the prognostic evaluation of the maxillary sinus carcinoma beta, the line that we basically use is classically known as the Ongren's line beta. That has to be remembered. And any cancer above the line is considered to be having a poor prognosis. Okay? Any cancer above the line will have a poor prognosis. Below the line there will be a good prognosis beta. समझे बात यहाँ तक? So that is important. Next, another recent question from 26 July FMG examination beta, the last one. Here you can see if a patient is having maxillary sinus carcinoma, I have to remove the whole maxilla or the whole maxillary bone itself. And for removal of the maxillary bone, this kind of marking has to be done. Barabar, where I can remove the whole maxilla and dotted line is representing plus minus. Matlab, if definitely beta the orbit is involved, I may also have to remove basically the orbit beta. Yes, majority of the topics are going to be same in NEET PG as well, bachche. Clear hai baat? So that is important. Some topics are in depth, but otherwise majority topics are same. 60-70% is same content. So do remember basically beta that plus minus definitely you may also have to remove the orbit or the orbital bones as well if they are involved. This is basically known as which approach? The Weber-Ferguson approach beta. This is what is known as the Weber-Ferguson approach, and that is used for which procedure? So that is used for removal of the maxilla. That is nothing else but total maxillectomy beta. Samjhe baat? That is what was the question in the recent FMG. So do remember total maxillectomy has to be done using the Weber-Ferguson approach. So they gave this picture of Weber-Ferguson approach in the exam and they asked you it is used for which surgical procedure. So do remember it is generally used for the total maxillectomy. Hopefully clear. So this was the question in the recent exam. They did not ask you the name of the approach. They asked you for which procedure it is useful. The answer was nothing else but for total maxillectomy it is useful, and it is done in a patient suffering from maxillary sinus carcinoma. Understood? Chalo. Next important if I talk about beta is another condition, and that is nothing else but allergic rhinitis beta. Now if I talk about a case of allergic rhinitis, we know rhinitis is inflammation or infection in the nose basically, and allergic rhinitis means after exposure to allergen, the patient definitely suffers from rhinitis symptoms like sneezing, excessive watery nasal discharge, these kind of symptoms beta. Samjhe baat? So this allergic rhinitis is going to be which type of hypersensitivity? Let me know in the chat box. We know all the allergic and the anaphylactic conditions, they are going to be which type of hypersensitivity? Let me know in the chat box beta. Okay. So allergic rhinitis is which type of hypersensitivity? Shabash. Do remember that allergic rhinitis is a type 1 hypersensitivity beta which is associated with IgE. So type 1 hypersensitivity or the IgE mediated hypersensitivity is allergic rhinitis. So it is an atopic condition. Atopy means familial allergy or a hereditary allergy which runs in the families beta. Barabar? As allergic rhinitis is an atopic condition, it is associated with other conditions also like bronchial asthma, hay fever and atopic dermatitis. Matlab, if a patient is suffering from allergic rhinitis, there is a very high chance or a very high probability that the patient may also be having bronchial asthma, hay fever or atopic dermatitis. Samjhe baat? That is what is important. Now do remember allergic rhinitis can be of two types. One is a seasonal allergic rhinitis beta and second is a perennial allergic rhinitis. Seasonal allergic rhinitis only happens during a specific season of a year beta. especially the spring or the summer season. And it happens due to exposure to pollen grains beta. So if a person is exposed to the pollen grains, definitely these pollen grains act as allergens, and that is the reason why the patient will have a seasonal allergic rhinitis. Okay? Whereas the second type is perennial. Perennial matlab 12 mahine. Perennial means throughout the year beta. So perennial allergic rhinitis, it happens due to the house dust mite. You might have heard a lot of people saying, I am having dust allergy. So those people are actually having a perennial allergic rhinitis beta. That means whenever they are exposed to the house dust mite, they immediately develop the symptoms of allergic rhinitis beta. समझे बात? That is what is important. So due to pollen grains, seasonal one; due to house dust mite, the perennial one. Now the patient starts having symptoms like there will be a watery nasal discharge beta. ठीक है, runny nose, continuously नाक बहती रहेगी, watery nasal discharge, and second is excessive sneezing. Once the patient is exposed to the allergen, continuously they keep on having sneezing beta for the next 10-15 minutes. Now, if I do a lab workup in a patient of allergic rhinitis, I'll be able to see two things. One, if I do a CBC, as we know it is an allergic condition, you will find excessive rise in the eosinophil levels beta or the eosinophil count called as eosinophilia. So when I do a complete blood count, on that I am able to see eosinophilia. Second, if I check the levels of serum IgE or immunoglobulin E, they are going to be grossly elevated beta. So serum IgE levels are going to be high. समझे बात? तो lab workup shows eosinophilia and the elevated IgE levels beta due to allergy. Treatment, हमें पता है the best treatment is ask the patient to identify the allergen. What is the cause for his symptoms? Ask the patient to identify that. Once the allergen has been identified, advise the patient to avoid the allergens as much as possible. ठीक है? Along with that, whenever the patient is having symptoms, obviously the patient should be given antihistaminics beta. Antihistaminics, the drugs like cetirizine, levocetirizine, these kind of drugs. Clear? The patient should be given definitely the drugs like cetirizine, levocetirizine, which are antihistaminics, which will help counter the patient's symptoms beta. Okay? Chalo. So that is important to be remembered. Now, another previous year question in the FMG examination was, in NEET PG also this was asked basically in the 2023 examination, and the question is, a patient who is a known case of bronchial asthma develops ethmoidal nasal polyps. We know beta, polyps are usually going to be of two types. One is the antrochoanal polyp, also known as Killian's polyp. These antrochoanal polyp or Killian's polyp, they are commonly seen in the maxillary sinus beta. Second one are the ethmoidal nasal polyps. Ethmoidal nasal polyps are commonly seen in the nose. Okay? The antrochoanal or the Killian's polyp are commonly associated with infections, whereas the ethmoidal nasal polyps are commonly associated with allergy. That's the reason beta, these ethmoidal nasal polyps are seen in an allergic condition like bronchial asthma. So patient is a known case of bronchial asthma having ethmoidal nasal polyps. Now they're asking you, this patient will be allergic to which group of drugs beta? Very good, all of you. Yes. So do remember, there's a classical triad over here, and that can be remembered by the mnemonic BAN or BAP, whatever you want to remember. B for bronchial asthma, A for allergy to NSAIDs beta, especially the non-steroidal anti-inflammatory drugs like aspirin. Most common drug is aspirin beta. Okay? So do remember definitely A for allergy to NSAIDs, especially the aspirin group, aspirin drug, and N for nasal polyps, the ethmoidal nasal polyps basically. समझे बात? So you can remember the BAN or BAP as the mnemonic basically. That is bronchial asthma, allergy to NSAIDs, and nasal polyps beta. And this is a classical feature of which triad? It is a classical feature, as you have rightly mentioned. Yes, it is a classical feature of nothing else but the Samter's triad. It is a classical feature of nothing else but Samter's triad. Samjhe baat? So these are the important findings that you need to remember. Understood? This is a classical feature of Samter's triad. Now, next question, a Sarkari and a classic favorite of your FMG and NEET PG examiners both, and that is, an immunocompromised patient presents to you with blackish spots on the palate along with loose teeth. Reason, the palate has undergone necrosis, due to which there are blackish spots, and due to that itself the teeth have become loose beta. The patient is having reddish swelling over the cheek, and later on there is a black scar which forms on the cheek. As you are able to see, this kind of a black scar is seen around the nose, on the palate, on the cheek, or on the orbits as well. Okay, and the patient is also having blurring of vision. Obviously, the condition is involving the eye or the orbit, and that causes blurring of vision. And the patient is having altered sensorium, which is a CNS symptom. So, due to brain involvement or due to CNS involvement, the patient is basically having altered sensorium. So, you can see there is involvement of the nose beta, there is going to be involvement of the orbit, and there is involvement of the brain. So, therefore, we call this classical condition as rhino-oculocerebral mucormycosis beta. Yes, shabash. So do remember, diagnosis in this condition is a case of mucormycosis, also referred to as the rhino-oculocerebral mucormycosis. Reason: the nose, orbits, and the brain is involved. Mucormycosis we know is a fungal infection. It is a life-threatening or it is a fulminant fungal infection beta. Most commonly caused by mucor, rhizopus, or abscedia. Let me know in the chat box. It is more commonly caused by mucor, rhizopus, or abscedia. What is the leading cause? Mucormycosis is a life-threatening infection or a severe infection which is usually seen only in immunocompromised patients, like the patients who are HIV positive, the patients who are elderly diabetics, or the patients who have been taking high doses of corticosteroids. Like in COVID-19 treatment, we used to give high doses of corticosteroids, which made the patient immunocompromised and increased the risk of mucormycosis in the patient. Very good. The leading cause, though the name is mucormycosis, the leading cause is not mucor, bache. The leading cause of mucormycosis is rhizopus followed by mucor. The most common cause is rhizopus followed by mucor. Do remember, this rhizopus or mucor which is there, it is an angioinvasive fungus. Matlab, it invades the blood vessel, due to which the blood supply is compromised. And as the blood supply is compromised, beta, there is ischemic necrosis. And that is the reason why everything appears black over here. There is ischemic necrosis in the areas, and therefore definitely everything appears black. Therefore we refer it to as the black fungus also. Samjhe baat? That is important. Investigation, if they ask you. Now, a previous year NEET PG question beta from 2023, I feel. And the question was basically 2022, sorry. And the question was, sorry, a patient of mucormycosis is presenting to you beta. A classical clinical case of mucor was given, and they asked you what should be your initial step in the management of this patient beta. One option was MRI head, another option was nasal swab for mucor. What should be preferred? The first step basically beta, it should be MRI head or the nasal swab for mucor. First step has to be MRI head or the nasal swab for mucor. Answer would be, so the first step is basically MRI head beta. Yes. Reason is definitely we have to do an MRI head to rule out the brain involvement or the CNS involvement beta. Barabar hai baat? That is what is important to be remembered. The first investigation that we go for is basically a MRI head basically beta, just to rule out the brain involvement or the CNS involvement. Understood? So brain involvement or CNS involvement has to be ruled out by doing a MRI head. That has to be remembered. Clear hai baat? Along with that, you can also send a nasal swab. Okay, nasal swab can be sent, but it is not the immediate priority, has to be remembered. Clear? And if they ask you what is the gold standard investigation or what is the best investigation beta for a case of mucormycosis, we all know the gold standard or the best investigation to confirm the diagnosis of mucormycosis is biopsy or the histopathological examination. You will take the tissue biopsy beta and send this biopsy for culture. Okay? So biopsy or histopathological examination with culture is going to be the gold standard or the best investigation itself. Okay? Which kind of hyphae will be seen? Acute angle or obtuse angle? Septate or aseptate? Let me know in the chat box. When you do a culture from this biopsy of mucormycosis, you are able to see which kind of hyphae. Acute angle or obtuse angle? Septate or aseptate? Integration with micro. Let me know in the chat box. So do remember beta, the hyphae which are there, those are going to be aseptate hyphae and they are going to be obtuse angle beta. They are going to be aseptate hyphae which are going to be obtuse angle. Septate acute angle hyphae is seen in aspergillus beta. Septate acute angled hyphae are a feature of aspergillus. समझे बात? That is what is the difference. If they ask you, definitely beta, in cases of mucormycosis, once the diagnosis has been confirmed, then what is the drug of choice? All of us are quite aware. All the severe fungal infections, beta. Okay, all the severe fungal infections, whichever they are, the drug of choice is nothing else but LAMB, that is liposomal amphotericin B. The conventional amphotericin B is highly nephrotoxic, beta. Therefore, we prefer the liposomal variant, that is nothing else but LAMB. So, IV LAMB or the liposomal amphotericin B is considered as the drug of choice in mucormycosis. So, yaad rakhna, all the severe fungal infections like mucormycosis or cryptococcal meningitis, in drug of choice is LAMB. Along with that, definitely you can give another drug that is known as 5-flucytosine beta. Okay, another drug that I can add is 5-flucytosine. Yes, in some cases of sorry, COVID-19, okay, we also use posaconazole as well. Okay, but the drug of choice has to be LAM or liposomal amphotericin B. Samjhe baat? That is important to be remembered, beta. Okay. Apart from that, if I ask you a previous year pharma question, it was, let me know in the chat box. What is the most common complication or most common side effect of LAM therapy? Liposomal amphotericin B ka most common side effect. Let me know in the chat box, beta. Treatment, I hope all of you are quite aware. There are a lot of dead necrotic tissue. I need to remove all that dead necrotic tissue, that is called as debridement beta. Removal of the dead necrotic tissue is going to be called as debridement. Plus minus, I may also have to remove the orbit. In case if the orbit is involved, I have to remove the orbit beta, that is the orbital bones with the extraocular muscles as well. Right? Shabash, very good Swati. It is infusion related reactions beta. Yes, infusion related reaction is the commonest side effect of the liposomal amphotericin B. Now let me know, removal of orbit should be called as enucleation, exenteration or evisceration beta. Debridement is the mainstay of management, but along with that, if the orbit is involved, I may also have to remove the orbit beta. And removal of the orbit is going to be called as enucleation, exenteration or evisceration beta. Very good. The answer has to be nothing else but exenteration. So if orbit is involved beta, you have to do the removal of orbit, and removal of orbit is known as nothing else but exenteration beta. Okay? So that is what is important. Shabash. Yes. So do remember, treatment of choice is nothing else but debridement plus minus exenteration. समझे बात यहाँ तक? Classical. Next one. A person comes to you with complaints of infertility. Which kind of infertility? Hypogonadotropic hypogonadism. Matlab, there is damage at the level of hypothalamus. Due to that, there is decreased production of GnRH and decreased production of FSH and LH. Decreased production of FSH and LH. And that's the reason there is a hypogonadotropic hypogonadism beta. Along with that, patient also gives a history or symptom of anosmia. Anosmia is complete loss of sense of smell. Okay? There is absence of sense of smell. Please tell me what is the diagnosis. If they say infertility plus anosmia together, we know this is a classical case of, very good, Kallman syndrome beta. Yes, it is a classical case of nothing else but Kallman syndrome. Can be asked from gynae as well. Okay? So Kallman syndrome is hypogonadotropic hypogonadism along with anosmia, and that happens due to damage at the level of hypothalamus. समझे बात? So this is what is important to be remembered. Understood till here? चलो. Next important is, let's say a patient had a fist fight or a patient had a trauma beta, and after the trauma to the nose or after the facial trauma, basically the patient comes to you with complaints of a bilateral fluctuant nasal swelling beta. Yes, after that trauma, definitely the patient comes to you with complaints of these bilateral fluctuant nasal swellings basically. So what is the likely diagnosis? After a trauma, when my patient comes to me with complaints of this bilateral fluctuant nasal swelling, what is going to be my likely diagnosis in the case? This was the PYQ once, only diagnosis was asked. Patient has bilateral fluctuant nasal swellings. Yes, this is a classical case of nothing else but a septal hematoma beta. Due to the trauma, basically you can see there is bleeding around the nasal septum, and due to that these bilateral fluctuant nasal swellings are seen beta. Shabash. It is a classical diagnosis of nothing else but a septal hematoma. And if the condition is septal hematoma beta, obviously the treatment is nothing else but aspiration of blood. Hematoma is collection of blood, right? So definitely treatment is nothing else but take a needle, attach an empty syringe, insert the needle in the swelling and aspirate all the blood which is collected beta. So septal hematoma mein the treatment is aspiration of blood beta. But after aspiration of blood, if you leave it as it is, then there will be reaccumulation of blood or recollection of blood at the site. So to prevent that reaccumulation or recollection of blood, make sure after the aspiration beta followed by aspiration, you have to do a proper nasal packing bache. With the help of gauge piece, you can do a proper nasal packing. Reason, this nasal pack which is there, it will apply direct pressure over that bleeding site, and if it applies direct pressure over the bleeding site, the recollection of blood is not going to happen. Samjhe baat? So if there is a case of septal hematoma, the treatment in this condition is nothing else but aspiration followed by nasal packing. The treatment is aspiration followed by nasal packing. Hopefully cleared all of you now. So chalo, that is what is important to be remembered. No issues with this. What? Okay, chalo. No, IND you don't do beta. IND is usually done for abscess. If there is definitely a septal abscess which is, then we have to go for incision and drainage. Until then, you can just go for an aspiration. Minimally invasive. Now, why to go for IND if aspiration can work? Barabar? Next is a case of septal perforation. How does it happen? Let's say there was a trauma beta. Due to trauma, definitely, initially the patient developed septal hematoma. You did not treat the septal hematoma. As we did not treat the septal hematoma, it got infected, and due to infection, there was formation of a septal abscess. And ultimately, due to septal abscess, there was a septal perforation beta which developed. Okay? So the leading cause of septal perforation is going to be trauma itself. Okay? So septal perforation which is there, it is going to be like this. You can see in the nasal septum, there's an opening between both the nasal cavities beta. This is known as septal perforation. The leading cause of septal perforation is going to be trauma. The leading cause of septal perforation has to be trauma. But apart from trauma, there are multiple other causes. Barabar? Yes, very good. One of the cause is nothing else but the white powder that usually these people inhale beta. Right? That is nothing else but called as cocaine. So we know bache that cocaine snorting if you do for a longer duration of time, it can also cause a septal perforation. Why? Reason, cocaine is a vasoconstrictor. As it is a vasoconstrictor, it will cause vasoconstriction of the septal vessels. So the nasal septum does not receive enough blood supply. It undergoes ischemic necrosis, leading to formation of a septal perforation. So chronic cocaine snorting can also cause a septal perforation. Apart from that, multiple granulomatous conditions like syphilis, TB, leprosy, lupus, vaginous, multiple granulomatous conditions can cause it. Please tell me, beta, please tell me, if there is a perforation in the bony part of nasal septum only, then it is caused by which granulomatous infection? If there is perforation only in the bony part of the nasal septum, it is mainly caused by which condition? Shabash. So if there is perforation only in the bony part beta, it is mainly caused by a bacterial infection known as syphilis, especially tertiary syphilis, which is caused by Treponema pallidum. बराबर bony part में perforation is caused by syphilis or tertiary syphilis caused by Treponema pallidum. Next, if there is perforation in both the parts beta, that is bony as well as cartilaginous. If there is perforation in both the parts, that is bony as well as cartilaginous, that is caused by which condition? Very good. Bony and cartilaginous, in both the parts if there is perforation, it is caused by a small vessel vasculitis known as vaginous granulomatosis, also known as granulomatosis with polyangiitis. बराबर है बात? So definitely perforation in both the parts is caused by a vaginous granulomatosis beta, also referred to as granulomatosis with polyangiitis. Which antibodies are seen in vaginous granulomatosis? Let me know in the chat box. TB, lupus and leprosy only cause perforation in the cartilaginous part. Okay, both parts में perforation is caused by vaginous granulomatosis. Which antibodies are seen in vaginous granulomatosis? Let me know in the chat box. Treatment. We know patient will come to us with a complaint of whistling sound every time he breathes. ठीक है, हर बार जब सांस लेता है there is a whistling sound which comes basically. That is this problem. ठीक है, so treatment is we have to close the perforation, and for the closure of perforation beta we can use either septal obturators or the septal buttons beta. Septal obturators or the septal buttons can be used for the closure of septal perforation. Clear? Anybody? Not Pianka, it is Cianca. Very good, Edwin. Yes, yes. Molin, very good. Yes, Arjun, Shabash. It is Cianca, not Pianka. It is Cianca antibody seen in vaginal granulomatosis beta. Now, a classical case. Let's say beta, a young beautiful lady comes into your OPD. But as soon as she enters in the OPD beta, there is extreme foul smell that you are able to get. What is the likely diagnosis? So a female presents to you beta with complaints of nasal stuffiness or a nasal blockage along with a merciful anosmia. Merciful anosmia means she is emitting a lot of foul smell beta, but she herself is having anosmia or she herself is not able to sense any smell. That is known as merciful anosmia. Along with nasal cavities which have been filled with crust. Crust is nothing else but this dried up mucus beta. Okay? Female having nasal stuffiness, merciful anosmia, nasal cavity filled with crust and excessive foul smell has to be a classical case of nothing else but atrophic rhinitis beta. Very good. Merciful anosmia and foul smell are the keywords beta for this question of atrophic rhinitis. हमें पता है atrophic rhinitis is also known as azena beta, right? This condition known as atrophic rhinitis is also referred to as azena. The reason behind that is we know that it is called as azena because it is caused by a bacterial infection known as Klebsiella azene. It is caused by a bacterial infection known as Klebsiella azene. That's the reason. Atrophic rhinitis can also be called as azena. Now let me know in the chat box beta, what should be the treatment of choice for atrophic rhinitis or this azena? चलो दो options दे रहा हूं. One is alkaline nasal douching or second is modified Young's operation. What should be the treatment of choice? It is alkaline nasal douching or modified Young's operation. So in this condition beta, yes, we should go for an alkaline nasal douching. Every morning, daily, she has to definitely beta make an alkaline solution with sodium chloride, that is NS, sodium biborate and sodium bicarbonate, soda. And this solution she has to inject into her nasal cavities. Every morning with this alkaline solution, she has to clean or she has to wash her nasal cavities beta. That is known as alkaline nasal douching. Don't directly jump onto surgery beta. Who directly takes up a patient for surgery? First try conservative management, na? Right? So it has to be alkaline nasal douching beta. Alkaline nasal douching on a daily basis will be done to clean the nasal cavities beta, so that the patient does not emit any foul smell, okay, and the condition gets the time to heal as well. Okay? So alkaline nasal douching has to be the treatment of choice. In case if you have tried alkaline nasal douching for a longer duration, still the patient does not respond, still the patient's condition continues, in those conditions we have to go for a surgery. If alkaline nasal douching fails beta, then we go for a surgery, and that surgery is known as the modified Young's operation beta. And the modified Young's operation is nothing else but a permanent partial closure of both the nostrils beta. दोनों nostrils को थोड़ा थोड़ा बंद करना है, right? So to decrease the space inside the nasal cavity, we do a partial closure of both the nasal cavities of both the nostrils beta, so that less crusting happens or less crust forms basically in the nasal cavities. Hopefully clear to all of you now. So that is what is important. Now if I talk about basically another condition, and that condition is nothing else but called as a rhinoscleroma, also known as woody nose. All of us are quite aware, scleroma or sclerosis literally means fibrosis. So whenever there is going to be fibrosis of the nose, or whenever there will be fibrotic nodules formed over the nose beta, that condition is nothing else but called as rhinoscleroma beta. Okay, and as fibrotic nodules are formed over the nose, the texture of the nose, it is going to become woody hard. Okay, that's the reason rhinoscleroma is also known as woody nose. So if you see the picture, these are the fibrotic nodules formed over the nose, making the texture woody hard beta. Rhinoscleroma or woody nose is a chronic bacterial granulomatous infection beta. Yes, it is a chronic bacterial granulomatous infection caused by an organism. Shabash. The name itself is evident. Caused by an organism known as Klebsiella rhinoscleromatis. Beta. Shabash. The most common cause of rhinoscleroma or woody nose is nothing else but an organism called as Klebsiella rhinoscleromatis. That has to be kept in mind. ठीक है, तो Klebsiella azine is known to cause atrophic rhinitis or azena, whereas Klebsiella rhinoscleromatis is known to cause rhinoscleroma or woody nose. Beta has to be remembered. Clear about? Yes, this Klebsiella rhinoscleromatis can also be referred to as the fresh bacillus. Beta. Now we know that rhinoscleroma is going to be more common in the northern parts of India, especially endemic to the states of UP and Rajasthan. Beta. Okay, it is more commonly seen in northern parts of India. If you see the stages, there are 3 stages in rhinoscleroma. First is the atrophic stage. And atrophic stage mein patient will have exactly same symptoms as atrophic rhinitis only. Okay? The first stage is similar to atrophic rhinitis. Second stage is a granulomatous stage. And in that granulomatous stage, beta, you are able to see these fibrotic nodules forming on the nose. Beta. Second is the granulomatous stage where nodules are formed. And third is the fibrotic stage where deformities are seen in the nose, like the Hebra nose or the tapir nose. These kind of deformities can be seen. Clear? Now, when you take a biopsy from these nodules, okay, from the nodules, if I take a biopsy, we are able to see 2 classical features on histopath. Beta. And these 2 classical histopathological features are, first, the macrophages known as the maculus cells. Beta. Barabar. The first classical feature is the macrophages called as the maculus cells. And second, the inclusion bodies called as the Russell bodies. Beta. Second is basically the inclusion bodies, classically referred to as the Russell bodies. Hopefully clear to all of you. So do remember one point, beta, that if you see the biopsy or the histopathological examination, you are able to see the classical maculus cells and the Russell bodies. Beta. That has to be kept in mind. No issues with this, anybody? Clear? Now if they ask you what is the treatment, we know rhinoscleroma or woody nose is a bacterial infection, so treatment has to be antibiotics. Beta. And the combination of antibiotics that we prefer for the treatment of rhinoscleroma, one is an aminoglycoside known as streptomycin, second is tetracycline. So streptomycin plus tetracycline combination is the treatment that we use in a case of rhinoscleroma or woody nose. Beta. That has to be remembered. Samjhe baat? So this was about the second infection. The third one, here you are able to see we are having a cattle breeder. Beta. Okay, cattle breeder basically means charvaha. Okay, so we are having a cattle breeder basically from Tamil Nadu or from southern parts of India, presents with a mulberry like nasal mass. As you are able to see in the picture, there's a mulberry or a strawberry like nasal mass, which is a vascular mass. And therefore the patient is having recurrent epistaxis or recurrent nosebleeds. Beta. What is the likely diagnosis of this case, they are asking you? Very good. So they will give you a history of a farmer or a cattle breeder who takes bath in the same dirty water which is also used by animals. Okay? So the patient will be taking bath in the same contaminated or the dirty water used by animals, and due to that he gets this infection. It is more common in southern India, especially endemic to the state of Tamil Nadu. And the classical features are, one is a mulberry-like nasal mass which is seen, and second important feature is the recurrent epistaxis because this mass is vascular in nature. So we know it is a classical case of rhinosporidiosis. Beta. Now we know that rhinosporidiosis is an infection caused by an aquatic protozoa. Yes, rhinosporidiosis is an infection caused by an aquatic protozoa known as Rhinosporidium seaberi. So once the person comes in contact with this Rhinosporidium seaberi or with that dirty water, patient gets this infection. Okay? So it is due to Rhinosporidium seaberi, which is usually found in dirty water. Beta. That has to be remembered. Okay? Important. If I take a biopsy, beta, usually biopsy is not recommended, but after removal of BAS, if I send a biopsy, what I am going to be able to see on the histopath or the biopsy. Beta. So on the histopathological examination or on the biopsy. Beta, I'll be able to see the classical sperules with endospores. Beta. So you will be able to find sperules with a lot of endospores inside them. Okay? So if the histopath shows you a lot of sperules with endospores inside them, that is the classical presentation of nothing else but rhinosporidiosis. Beta. Sperules with endospores. Clear? Now treatment, we know this is a mass that we have to remove at any cost, right? So definitely treatment is surgical excision of this mass beta with cauterization at the base, right? So to prevent the bleeding afterwards, you have to coagulate or cauterize the base. So you have to do a surgical excision of the mass, followed by that cauterize the base also, so that the bleeding does not happen. Clear? But after the surgical excision, which is the drug that we give to prevent the recurrence? This is not the drug to treat the condition. मैं पहले ही बता रहा हूँ. This is not the drug to treat the condition. Treatment is always surgical excision. But after the removal of the mass, yes, to prevent the recurrence, basically, beta, we have to give a drug known as dapsone. To prevent the recurrence, we give a drug known as dapsone beta that has to be kept in mind. Now, another question to all of you. Mulberry-like nasal mass is a feature of rhinosporidiosis. But please let me know, mulberry-like nasal mucosa is a feature of which condition? Mulberry-like nasal mucosa is seen in which condition? Let me know in the chat box. Bolo. Mulberry-like nasal mucosa is seen in which condition? So mulberry-like nasal mucosa is seen in DNS or a deviated nasal septum due to compensatory inferior turbinate hypertrophy. Okay? Due to the compensatory inferior turbinate hypertrophy in patients of DNS, you are able to see a mulberry-like nasal mucosa. Hopefully clear. Next condition from nose. That is nothing else but classically known as CSF rhinorrhea. We know rhinorrhea means leakage from the nose beta. So when the CSF or the cerebrospinal fluid will start leaking out from the nose, that condition is known as CSF rhinorrhea basically. Do remember, the most common cause of CSF rhinorrhea is nothing else but trauma. The most common cause of CSF rhinorrhea is known as trauma. Due to the trauma, there is fracture at the base of skull. And due to the base of skull fracture, the CSF starts leaking out from the nose beta. Anybody, what is the most common site of leakage, bache? Let me know in the chat box. If there is a trauma and a base of skull fracture, what is the most common site in the base of skull from where the leakage is going to happen? Let me know in the chat box. The most common site for trauma, the most common site of leakage in CSF rhinorrhea is going to be. Very good. So we know beta, in this ethmoid bone, we have a horizontal plate which forms a partition between the cranial cavity and the nasal cavity, known as cribriform plate, bache. And when that cribriform plate gets fractured, then the CSF will start leaking out via the nose, causing CSF rhinorrhea beta. Samjhe baat? So do remember, trauma when it happens and the base of skull fracture when it happens, there will be fracture at the cribriform plate, and due to the cribriform plate fracture, the patient will have a CSF rhinorrhea or a CSF leakage. Hopefully clear to all of you now. So that is what is important. Understood? Whenever a patient of CSF rhinorrhea comes to us, do remember basically beta, the first thing you will ask the patient to sniff back the discharge. मतलब पीछे खींचने के लिए वापस बोलोगे like this. If the patient is able to sniff it back, that means it is mucus. But even after sniffing back, if the discharge continues, then it is a case of CSF. Patient cannot sniff back CSF. ठीक है, वो CSF को पीछे नहीं खींच सकता. That is what is important. Second, you can do an handkerchief test beta. Do remember handkerchief test and not handkerchief sign. ठीक है, in a PYQ they confused you with handkerchief sign. There is no handkerchief sign seen. There is a handkerchief test that we do in CSF rhinorrhea. Now what is that? Here definitely you will take the CSF sample on the handkerchief beta, and then the handkerchief will be sticky or non-sticky. We know if it is mucus, it will be sticky. If it is CSF, CSF is watery, therefore it is going to be non-sticky beta. Second important, after you let the handkerchief dry, it will not turn stiff. Kadak nahi hoga wo. ठीक है? If it is mucus, it will turn stiff, but if it is CSF, it will not turn stiff beta. That is what is important. The handkerchief test when I do remember the handkerchief is actually going to be non-sticky and the handkerchief is going to be non-stiff. And that is a hint that it is a case of CSF and not a mucus beta. Hopefully clear? Sometimes what happens after a trauma, the patient comes to you with a case of CSF, bloody CSF rhinorrhea beta. Matlab, a lot of blood is coming out from the nose. Now you are not able to understand whether it is only blood or it is blood plus CSF coming out. For that condition beta, you will take the sample on a blotting paper or filter paper. And when I take the sample on blotting or filter paper, After some time, I'll find definitely these concentric rings which are seen beta. And these concentric rings which are going to develop is classically known as the target sign, also known as the double target sign. Okay, you can call it as the target sign, also referred to as the double target sign. In a PYQ, instead of target, they gave double target. So, एक ही चीज है, please remember that. ठीक है? Whereas this one that you are able to see, it is nothing else but the halo. The CSF gets separated and it forms a halo around the blood. That is known as the halo sign. समझे बात? So one is target or the double target sign seen. Second is the halo sign seen on the blotting or filter paper if it is a case of bloody CSF rhinuria. समझे बात? चलो. Next important if I talk about is what is the best radiological investigation to confirm the diagnosis to confirm the site of leakage beta. The best radiological investigation to find the site of leakage or to confirm the site of leakage if they ask you. So I hope all of you are quite aware. The best radiological investigation is nothing else but the HRCT skull base beta. The best radiological investigation to find the site of leakage is HRCT skull base. That is a high resolution CT scan of skull base. ठीक है? तो high resolution CT scan of skull base is the best radiological investigation to find the site of leak. But in case if they say HRCT skull base cannot find the site of leakage, if in case they say HRCT skull base cannot find the site of leakage, then even better is a CT cysternography beta. Even better is a CT cysternography. But do remember, as CT cysternography is invasive, it is not the first choice. Okay, it is only done when HRCT fails. Clear? So HRCT skull base can help you find the site of leakage beta. समझे बात यहाँ तक? Now, if they ask you what is the overall gold standard investigation or the best investigation to confirm the diagnosis of CSF rhinuria, मतलब जो fluid बाहर आ रहा है वो CSF ही है, ये confirm कैसे बोल सकते हो तुम लोग? So the best investigation or the gold standard investigation to confirm the diagnosis of CSF rhinuria is beta 2 transferrin estimation beta. It is nothing else but beta 2 transferrin estimation. If you are able to estimate beta 2 transferrin in that sample, you surely know it is nothing else but CSF only. ठीक है? तो beta 2 transferrin estimation is the best or the gold standard investigation to confirm the diagnosis of CSF rhinuria. Now beta 2 से remember three things बेटा. I am telling overall basically beta 2 से तीन चीजें एग्जाम के लिए याद रख लो. First, beta 2 transferrin is the gold standard investigation for CSF rhinuria. Second, beta 2 microglobulin is the best prognostic marker for multiple myeloma. Beta 2 microglobulin is the best prognostic marker for multiple myeloma. And third, anti-beta 2 glycoprotein antibody. Anti-beta 2 glycoprotein antibody is the most important antibody in APLA syndrome. Anti-beta 2 glycoprotein antibody is the most important antibody in APLA syndrome. समझे बात? ये तीन beta 2 याद होने चाहिए. Treatment. Let me know in the chat box. CSF rhinuria is mainly a conservative management or surgical management. CSF rhinuria, we go for a conservative management or surgical management. Let me know in the chat box. I'll write it in the corner and share the PDF. Don't worry. ठीक है? मैं लिख दूंगा. Don't worry about that. ठीक है? चलो. Yes, the treatment is nothing else but conservative management. Majority cases of CSF rhinuria will be only going for conservative management beta. Okay, reason it is a self-limiting condition. मतलब the leakage or the rhinuria is eventually going to stop within a span of 7 to 10 days beta. That's the reason conservative management should be done for the initial 7 to 10 days basically beta. Okay, and even after 7 to 10 days or even after 7 to 14 days, if the leakage continues or if the rhinuria continues, then you can go for surgical repair. So initial management is always conservative in nature, where you will try to decrease the ICP or decrease the intracranial pressure. Reason, if I decrease the ICP, the leakage is also going to decrease beta. For that I will advise bed rest. We can give mannitol or acetazolamide beta. समझे बात? That is important. So conservative management for 7 to 10 days. But if it fails, in case if the conservative management fails, then only we go for a surgical repair beta or a surgical correction. समझे बात? So that is what is important. Next is nothing else but what are we going to ligate beta? किसका ligation करोगे? ठीक है? चलो. Next important if I talk about basically is nothing else but Epistaxis. We know beta epistaxis is nothing else but nose bleeding. In literal terms or in simple terms, epistaxis means nose bleeding. We know nose bleeding or epistaxis can be either an anterior epistaxis or a posterior epistaxis beta. Anterior epistaxis is more common, and anterior epistaxis happens commonly in children. What is the reason for that anterior epistaxis in children? Nose picking or nose bleeding, right? So अगर पूछा जाए what is the most common cause of epistaxis, the most common cause of epistaxis is nose picking or nail trauma, right? The commonest cause for epistaxis is nose picking or nail trauma beta in children. That has to be remembered. If they ask you what is the commonest site, we know nose picking की वजह से this little's area is injured. Little's area is this antero-inferior part of nasal septum. ठीक है? So the most common site of epistaxis is this little's area or the antero-inferior part of nasal septum beta. Why little's area is the commonest site to bleed? The commonest site to bleed is little's area because it contains an arterial plexus or an arterial network. As you are able to see in the picture, in this little's area or in this antero-inferior septum beta, we have a arterial plexus or arterial network. Okay, this is known as the Kieselbach's plexus. And this Kieselbach's plexus gets injured, and that is the reason why the patient will have epistaxis or bleeding beta. So as the little's area contains the Kieselbach's plexus, that is the reason why the patient definitely develops anterior epistaxis. Now important is, let me know, Kieselbach's plexus is never formed by which artery? Which artery does not participate in the formation of Kieselbach's plexus? Let me know in the chat box. Which artery supplying the nose never participates in the formation of Kieselbach's plexus? Let me know in the chat box. PYQ. Anybody? Kieselbach's plexus is formed by the sphenopalatine artery, the greater palatine artery, the superior labial artery, and the anterior ethmoidal artery. But I hope all of you are quite aware, yes, the posterior ethmoidal artery never forms the Kieselbach's plexus. Posterior ethmoidal artery never participates in the formation of Kieselbach's plexus. That is what is important. And we know the most common vessel to bleed in epistaxis is the sphenopalatine artery. The most common vessel to bleed in epistaxis is the sphenopalatine artery. That's the reason why sphenopalatine artery is also known as artery of epistaxis beta. The sphenopalatine artery can also be called as the artery of epistaxis. Hopefully clear है यहाँ तक बात? That is important. Elderly patient, we know in elderly patient also there can be epistaxis. Elderly patient very commonly have posterior epistaxis also beta, and in elderly patient if there is a posterior epistaxis, that basically happens from a venous plexus, and the venous plexus which causes the posterior epistaxis is known as Woodruff's plexus beta. Okay, the posterior epistaxis is mainly from a venous plexus, classically known as your Woodruff's plexus. That has to be kept in mind. Hopefully clear to all of you. Yes, the reason for posterior epistaxis in elderly patient is an uncontrolled hypertension or very high BP beta that will rupture the vessels in Woodruff's plexus, causing a posterior epistaxis. Yes. Treatment now, if they ask you, first is, we know the best method to control bleeding or the best method to stop the bleeding is apply direct pressure. So the first step is always pinch the nostrils beta. You have to apply direct pressure or pinch the nostril for a minimum duration of 5 to 7 minutes. ठीक है? तो pinch the nostrils for 5 to 7 minutes, called as Trotter's method, also known as Hippocratic method beta. ठीक है? So definitely the first step is pinching the nostrils, called as the Trotter's method or the Hippocratic method, and that should be done for 5 to 7 minutes. During this, always ask the patient to sit bending forwards. Never ask the patient to lie down. I've seen a lot of people asking the person to lie down. No, always ask the patient to sit bending forwards and spit out any blood going in the throat. Reason is, if the patient lies down supine, the risk of aspiration of blood is going to increase beta. समझे बात? So you don't want aspiration of blood, therefore ask the patient to sit bending forwards. Hopefully clear? Chalo. So pinch the nostrils, but even after pinching the nostrils for 5 to 7 minutes does not help. If the bleeding continues, then go for chemical cauterization. I hope all of you are quite aware. Chemical cauterization mein you will use chemicals like silver nitrate or phenol, which will help coagulate the bleeding site beta. So you have to find the bleeding site. Wherever is the bleeding site, against that you have to apply these chemicals like silver nitrate or phenol. समझे बात? तो chemical cauterization can be done with chemicals like silver nitrate or phenol beta, which helps in coagulation of the bleeding site. But for this, yes, condition is you should know the bleeding site. If you don't know the bleeding site exactly, don't go for a chemical cauterization at all. ठीक है? Because you cannot pour the whole bottle of chemical in the nose. ठीक है? So it is necessary to know the bleeding site for chemical cauterization. Let's say if you have tried chemical cauterization but it fails, so in those conditions I should go for nasal packing beta. ठीक है? Previously we used to do the nasal packing with the help of gauge piece beta, right? We used to use the roller gauge or the tape gauge, okay, or we used to prepare packs. So with gauge pieces I used to pack the nasal cavity, because packing will apply direct pressure over the bleeding site and help in decreasing the bleed. ठीक है? Nowadays we also have PVA packs. Nowadays we also have catheters where we have balloons. As you inflate the balloon, it will apply direct pressure and the bleeding is going to stop. ठीक है? If you know the exact site, go for the specific packing. मतलब anterior epistaxis है तो anterior nasal packing to be done. Posterior epistaxis है तो posterior nasal packing to be done. But if you're not aware about the bleeding site, if you don't know exactly whether it is anterior or posterior, better go for both anterior plus posterior nasal packing. Clear? Let's say if you have tried nasal packing beta, but even after doing nasal packing, still the patient continues to bleed. In those conditions, you have to start ligating the artery. We know the artery of epistaxis, or the most common artery to bleed, is the sphenopalatine artery. So I'll start my ligation with the sphenopalatine artery. Go for SPAL. SPAL is nothing else but endoscopic sphenopalatine artery ligation beta. So endoscopic sphenopalatine artery ligation or SPAL has to be done. Okay? If the nasal packing fails. If sphenopalatine artery ligation does not work, like if even after ligating the sphenopalatine artery, patient continues to bleed, then catch the hold of the mother beta. Okay, catch the hold of parent artery. Then ligate the parent artery called as maxillary artery. So if sphenopalatine artery ligation does not work, go for maxillary artery ligation. And if maxillary artery ligation also does not help, then go for ligation of a parent artery, that is ECA. External carotid artery ligation has to be done. If maxillary artery ligation fails, go for external carotid artery ligation. If external carotid artery ligation fails, then please tell me, you would ligate which artery next? If external carotid artery ligation fails, the next or the last artery to be ligated will be? Let me know in the chat box. Very good. Shabash. Don't answer anyways ICA or CCA beta. ICA or CCA, if you ligate, the patient dies the 3rd minute, your license gets cancelled in the next 2 minutes itself. Clear hai baat? So definitely if ECA ligation fails, always mark beta it as anterior and posterior ethmoidal artery ligation. If ECA ligation fails, then ligate the anterior and the posterior ethmoidal arteries beta. That is what is important. Hopefully clear to all of you now. So that is what is important. Chal. The last arteries to be ligated are the anterior and posterior ethmoidal arteries, which are a rare cause of epistaxis, but the last option is that only. Okay? Chal. Next important now. This was all about your nose. Now let's talk about the last part of ENT, and that is nothing else but ear. The major part that we have. Now if I talk about ear, basically beta, okay, we know there are 3 parts to the ear. First is the external ear, second is the middle ear, and third is the inner ear beta. First of all, if I talk about external ear, we know beta, external ear is formed by 2 parts. One is the pinna, this visible structure over here known as pinna, and second is the EAC or the external auditory canal beta. For epistaxis, basically they will ask, like for example, definitely like we have tried pinching the nostrils, we have tried chemical cauterization, that doesn't work. What is the next step? The answer has to be nasal packing. So they will definitely ask in a sequential manner. That's the reason we have discussed the flowchart. Clear? Chalo. Ear, basically we know there are 3 parts: external, middle and inner ear. The external ear which is there beta, it is going to be made up of this pinna, which is the visible structure, and second this structure over here called as EAC or the external auditory canal. Once the external ear ends, we have a partition between the external ear and middle ear called as tympanic membrane or the myring beta. So tympanic membrane or myring forms a partition between the external ear and the middle ear. Then is the middle ear. Middle ear is a closed cavity. एक बंद कमरे जैसा होता है. Okay, middle ear is the closed cavity having only one exit, and that is your eustachian tube beta. Middle ear is a closed cavity having only one opening or one exit, known as your eustachian tube. Now, in this middle ear cavity or in this tympanum or the tympanic cavity beta, we have three bones known as three ear ossicles. And what are these three ear ossicles? The malleus, the incus, and the stapes. We know the malleus, incus, and the stapes, they are usually attached to each other, or these malleus, incus, and stapes are connected to each other beta. Reason is they are responsible for conduction of sound. So whatever vibrations are produced by the tympanic membrane, those are going to be transferred, or those are going to be conducted further by these three ear ossicles known as malleus, incus, and stapes. That's the reason when these ear ossicles will get dislocated. If the ear ossicles get dislocated from each other, then conduction of sound will not happen, causing a conductive hearing loss. So ossicular dislocation causes a conductive hearing loss beta. समझे बात? Now, apart from these three ear ossicles, we have two muscles in the middle ear. One muscle is known as tensor tympani muscle. The function of tensor tympani muscle is to stretch or to tense the tympanic membrane. The function of tensor tympani muscle is to stretch or tense the tympanic membrane. And second is the stapedius muscle. Stapedius muscle is responsible for a protective reflex called a stapedial reflex. Stapedius muscle is responsible for a protective reflex which protects the inner ear from loud sounds. Okay, inner ear को loud sound से बचाने वाला stapedial reflex. Clear? That is what is important. Now, after the middle ear beta, we know the sounds will be conducted into the inner ear. Inner ear, also known as labyrinth. The inner ear, which is also known as labyrinth beta, has three parts. First is the snail-like structure. We know this snail-like structure, which is responsible for hearing, is known as cochlea. The snail-like structure responsible for hearing is known as cochlea. Apart from that, we have the utricle and saccule. Let me know the function of utricle and saccule in the chat box. PYQ in the FMGE exam. What is the function of utricle and saccule? We know cochlea is responsible for hearing, but if they ask you about the utricle and saccule, their function is what? And third structure is the semicircular canals beta. There are three semicircular canals in the inner ear. These three semicircular canals are: first is the superior semicircular canal, second is the posterior semicircular canal, and third is the lateral semicircular canal. So superior, posterior, and lateral semicircular canal beta. Very good. Utricle and saccule are basically responsible for the linear balance or the linear acceleration of body. When you stand straight or when you walk straight, you do not fall, because the linear balance of your body is maintained by utricle and saccule beta. Clear? Whereas semicircular canals, they are responsible for the angular balance of the body. Matlab, when I turn, when I bend, when I twist, I do not fall again. Reason? The semicircular canals are responsible for the angular balance of body. Clear hai baat yahan tak? Chalo. Embryology now. Let's talk about this. First of all, definitely, if I talk about the embryology of the external ear beta, we know external ear has two parts. One is the spinna and second is nothing else but the external auditory canal. Now, हमें पता है pinna में this conical structure over here is known as tragus beta. This conical structure over here is known as tragus basically. बराबर? So do remember that tragus of pinna is formed by the first pharyngeal arc. The tragus of pinna is formed by the first pharyngeal arc. Whereas the rest of the pinna which is there beta, it is developed from the second pharyngeal arc. The rest of the pinna is developed from the second pharyngeal arc. Let me know in the chat box, this was a PYQ. Pinna usually forms by the 6 precursors. What is the name of those 6 precursors beta? Let me know in the chat box. Pinna development happens from the 6 precursors of pinna. What is the name of those 6 precursors of pinna beta? There are 6 precursors of pinna which fuse together to form the pinna basically. These 6 precursors of pinna which are there, yes, they are classically known as hillocks of FESS. These 6 precursors of pinna which are there beta, they are classically referred to as the hillocks of FESS. They fuse together for the development of pinna. Second important thing, pinna development usually completes by 20 weeks of intrauterine life beta. The pinna development which is there, it completes by 20 weeks of intrauterine life itself. Okay, it completes in the fetal life or the intrauterine life itself. समझे? चलो. Next part of the external ear is your EAC or the external auditory canal. The EAC or the external auditory canal, mainly it forms by the first cleft or the first pharyngeal cleft beta. Okay, the main contribution in the EAC or the external auditory canal is the first cleft or the first pharyngeal cleft. But apart from that, even first arc also helps in formation of the EAC or the external auditory canal. Okay, even the first arc or the first cleft is also going to help beta basically in the formation of the external auditory canal basically. ठीक है? ठीक है? Not exactly Norset beta, but it is similar. A lot of topics are going to be common. Norset is somewhat superficial in some parts. ठीक है? But yes, okay, a lot of topics will be covered. Almost all the topics will be covered. So याद रखना, EAC or external auditory canal is formed by the first cleft or the first arc beta. Next important is tympanic membrane. We know tympanic membrane is the only structure in the ear beta which is formed by all the three germ layers बच्चे. All the three germ layers का मतलब endoderm, mesoderm and ectoderm beta. ठीक है? So tympanic membrane or the myring is formed from all the three germ layers, that is endoderm, mesoderm and ectoderm as well. ठीक है? So do remember this. Next important is middle ear cleft. What do I mean by middle ear cleft? We know beta, middle ear cleft means, let's say basically this is your middle ear. Basically we know this middle ear is going to have only one exit, and that one exit of the middle ear which is there beta, it is nothing else but the one exit of the middle ear is nothing else but your eustachian tube which connects the middle ear to the nasopharynx beta. And behind the middle ear definitely we have the mastoid bone, and we know your middle ear is connected to the largest and the most constant mastoid hair cell called as the mastoid antrum. Your middle ear is connected to the largest and the most constant mastoid hair cell known as the mastoid antrum beta. So याद रखना, the middle ear, the eustachian tube and the mastoid hair cells together, this is known as your middle ear cleft. The middle ear, eustachian tube and the mastoid hair cells together we call it as the middle ear cleft. So याद रखना, this middle ear cleft is going to be developed from what? So middle ear cleft usually develops from the first endodermal pouch or the first pharyngeal pouch. The middle ear cleft develops from the first endodermal pouch or the first pharyngeal pouch. That has to be remembered. समझे यहाँ तक? Next, inner ear or labyrinth if I talk about. Do you remember beta? The inner ear or the labyrinth if I talk about. The whole inner ear or labyrinth usually develops from the neuroectoderm. The whole inner ear or the labyrinth develops from the neuroectoderm, or you can call it as otic placode beta. ठीक है? The whole inner ear or the labyrinth develops from neuroectoderm or the otic placode, what we call it as. समझे बात? Now, in the middle ear, basically we know the whole middle ear develops from the first pharyngeal pouch or the first endodermal pouch. In the middle ear, we have three ear ossicles. The first one that you are able to see is known as malleus, which is a hammer-like ear ossicle. हथौड़े जैसा दिखता है. ठीक है? Second one that you are able to see basically beta, it is going to be क्या हुआ? So please remember, second one is nothing else but incus basically beta, and the third one is nothing else but stapes. So the three ear ossicles are, first one is nothing else but malleus, second one is nothing else but the incus, and the third one is nothing else but the stapes beta. इसमें से do remember that malleus and incus which are there, both of these are derivatives of the first pharyngeal arc. Okay, malleus and incus, both of them are the derivatives of the first pharyngeal arc beta. Whereas the stapes which is there, it is a derivative of second pharyngeal arc. Anybody let me know in the chat box beta. We know the whole stapes is derived from the second pharyngeal arc except the foot plate. Foot plate of stapes is derived from which structure? Let me know in the chat box. हमें पता है the whole stapes is a derivative of second pharyngeal arc basically beta. That is important. So usually this was a previous year image based question in NEET PG examination in 2023, and they asked you to differentiate between malleus and incus. A lot of people, the picture was of incus and a lot of people marked it as malleus. याद रखना, malleus basically has a head, it has a neck, it has a lateral process beta, it is going to have a handle, and there is a tip of the handle known as umbo. There is a tip of handle known as umbo. Whereas incus जो होता है, incus usually has a very broad surface known as the body. The broad surface of incus known as body. There is a short process, there is a long process, and there is this lenticular process beta. Sanjay baat, that is important. Always see the parts. If you see the parts, you will get the answer. Okay? And stapes is very easy. This is the suprastructure of stapes that you are able to see beta, the upper one, and this is the footplate of stapes that I have marked. Very good. We know beta, the footplate of stapes is not derived from the second pharyngeal arc. The footplate of stapes is usually derived from the neuroectoderm. Along with inner ear, the footplate of stapes is derived from neuroectoderm, and this is the reason why you might have seen na, in CSOM or chronic suppurative otitis media, all the ear ossicles get eroded or all the ear ossicles get damaged. Malleus, incus, even the suprastructure of stapes. But the part which is never damaged in the CSOM is footplate of stapes beta. Reason is the footplate of stapes has a separate blood supply because it is derived from the neuroectoderm. That is the basic idea. समझे बात अभी क्यों नहीं damage होता in CSOM, the footplate of stapes? This is the reason for it. Clear? चलो. So do remember, these are the points that you need to remember beta. ठीक है? Now please tell me, what is the joint present between the incus and malleus? The incudo-malleolar joint is going to be which type of joint? Anatomy se integration I'm doing. If they ask you that the incudo-malleolar joint is going to be which variety of joint, let me know in the chat box. The incudo-malleolar joint which is there basically, it is going to be which variety of joint, basically let me know in the chat box. We know both the joints between the ear ossicles are synovial joints. The incudo-malleolar joint which is there, it is going to be which variety of joint? Very good, shabash. The incudo-malleolar joint is going to be the classical saddle or the salar variety of joint beta. Yes, it is going to be the saddle or the salar variety of joint, that has to be remembered. Second, the incudo-stapedial joint, the joint between the incus and stapes. Let me know in the chat box. The incudo-stapedial joint, that is the joint between the incus and the stapes. It is going to be which variety of joint beta? The incudo-stapedial joint between the incus and stapes, that is going to be which variety of joint? The incudo-stapedial joint. Very good. Yes, the incudo-stapedial joint which is there beta, it is nothing else but the ball and socket joint. The incudo-stapedial joint is a variety of ball and socket joint. That is what is important to remember. Understood? So these are the points basically that you need to remember about the joints between the ear ossicles beta. Samjhe baat? Chalo. Next important if I talk about now. Done with this? Understood? Chalo. The next important if I talk about now is basically the condition or the congenital anomaly that you are able to see. This is the congenital anomaly. Now, in the pinna beta, you might have seen, we have this outer curvature, and this outer curvature is known as your helix beta. And inside that we have this inner curvature. This inner curvature basically is known as your antihelix. Okay? So there is a outer one known as nothing else but helix, and the inner one classically known as the antihelix. Which one is absent in this given picture beta? In a case known as bat ear, okay, in a case called as bat ear beta, which is absent? The helix or the antihelix? Which one is absent over here? Very good. You can see the outer curvature known as helix is present, but the inner curvature known as antihelix is absent beta. So do remember, bat ear which is there, it is a condition where there is an absent antihelix beta. Bat ear is a condition where there is an absent antihelix, has to be remembered. Treatment. We know if there is a congenital anomaly or if there is a congenital defect, we have to go for a repair beta, and that repair is known as auriculoplasty. Auricle means pinna, plasty means repair. So we have to do a plastic reconstruction of pinna, and that plastic reconstruction of pinna is known as auriculoplasty. That should be done after what age? This is a PYQ, let me know in the chat box. The auriculoplasty in cases of bat ear should be done after what age beta? Let me know in the chat box. The auriculoplasty in cases of bat ear should be done after what age? Auriculoplasty or the plastic reconstruction of pinna should be done after the age of 6 to 7 years beta. Shabash. It should be done after age of 6 to 7 years. That has to be remembered. It should only be done after 6 to 7 years of age. Reason, the pinna growth happens up to the 6 to 7 years of age, and even the coastal cartilages that we may need, they will be fully grown. Okay? So 6 to 7 years of age beta After that itself, you should go for a plastic reconstruction or auriculoplasty. That has to be remembered. समझे यहाँ तक बात? चलो. Next important, if I talk about now, is this question over here. That is, a patient complains of heaviness in the ear, beta. Along with heaviness in the ear, patient is also having CHL or conductive hearing loss. Do remember one point I'm clarifying right now, and that is, any problem in the external ear or middle ear will cause a conductive hearing loss. Why? External and middle ear are responsible for conduction of sound. So any problem in the external and middle ear causes a conductive hearing loss, beta. Whereas any problem in the inner ear or the eighth nerve, any problem in the inner ear or the eighth nerve causes a SNHL or sensory neural hearing loss. Any problem in the inner ear or the eighth nerve causes SNHL or a sensory neural hearing loss. Clear है यहाँ तक? So here there is some problem in the external or middle ear maybe. So patient complains of heaviness in the ear along with conductive hearing loss. And excess ear wax was seen inside the external auditory canal. We know, beta, in the external auditory canal, we have some specialized glands called as the ceruminous glands. And these ceruminous glands are known to secrete earwax. But if there is excess earwax impacted inside the ear external auditory canal, beta, that causes a problem. Okay? If there is excessive earwax impacted inside the external auditory canal, that causes heaviness or that causes hearing loss, beta. Treatment क्या करोगे? You have to clean that earwax, and cleaning of earwax can be done with the help of water or saline, beta. You have to take warm water or warm saline, and you have to inject this warm water or warm saline, beta, in the patient's external auditory canal in a posterior direction. क्यों posterior? Reason is, if you push or if you irrigate the ear in posterior direction, the fluid or the water goes behind the earwax and pulls the earwax outwards, beta. If you do it in antero-inferior direction, one problem may be the earwax may get pushed backwards. ठीक है? तो always do the ear syringing बच्चे in the posterior direction only. ठीक है? So the treatment of excessive earwax has to be ear syringing, and this ear syringing that you are able to see. Two things that you have to follow whenever you do ear syringing for cleaning the earwax, beta. One, always use a warm water or warm saline, beta. For cleaning the earwax, always use a warm water or warm saline itself. That has to be kept in mind. Okay? When you use cold water, what will happen? We'll talk about that. So always use warm water or warm saline. And second, the direction of ear syringing should always be posterior, beta. The direction of ear syringing which is there, it should always be posterior. Hopefully clear about. So these are the 2 points to be remembered. One is use always a warm water or warm saline, and second is the direction of ear syringing should be posterior. Let's say in case if you have not followed this, let's say if you have not followed this, beta, then what is going to happen? Let's talk about that. Okay? If you have not followed this, what is going to be happen basically, beta? Let's talk about that. Okay? Thank you so much. ठीक है, तो if I talk about basically the cold water, beta, let's say in case instead of warm water बच्चे you are going to use cold water, तो क्या हो जाएगा? As cold water goes in the external auditory canal, suddenly the temperature of EAC changes, beta, and as suddenly the temperature of EAC changes, the lateral semicircular canal in inner ear, the lateral semicircular canal in inner ear is stimulated, and as soon as the lateral semicircular canal is stimulated, beta, immediately the patient starts experiencing vertigo, because if lateral semicircular canal is stimulated, that causes disturbance in angular balance of the body, and if angular balance gets disturbed, patient को चक्कर आएंगे बेटा, patient experiences vertigo. So do remember, instead of warm, if you use cold water for ear syringing, the patient tends to experience vertigo, beta. That has to be remembered. ठीक है? Next important, if I talk about, if they say that the direction of ear syringing is going to be antero-inferior. If the direction of ear syringing is going to be antero-inferior, beta, then what will happen? We know, as you push the water in antero-inferior direction, the floor of the external auditory canal is going to be irritated. Do remember, the floor of the EAC is supplied by, or it is innervated by, the Arnold's nerve. And what is Arnold's nerve? Arnold's nerve basically, beta, is going to be an auricular branch of vagus nerve. Arnold's is a auricular branch of vagus nerve. So if you do ear syringing in antero-inferior direction, you are irritating the floor, matlab you are irritating Arnold's nerve. and if Arnold's nerve is irritated, the whole vagus nerve gets irritated beta. ठीक है, समझे ये बात यहाँ तक? So whenever you do ear syringing in antero-inferior direction, that causes irritation of Arnold's nerve, also known as Eiderman's nerve, and that causes the irritation of the whole vagus nerve. And as there will be a vagal stimulation or as there will be a vagal irritation beta, that will lead to two problems. क्या क्या problems होंगे? First, we know vagus nerve also supplies the larynx and pharynx by the SLN and RLN. बराबर, branches of the vagus nerve will also supply the larynx and pharynx by the SLN and RLN. Therefore, patient immediately gets a cuff reflex beta. ठीक है, तो one, definitely patient immediately gets a cuff reflex. During ear syringing, if the patient is getting cuff reflex, that means your direction of ear syringing is wrong. You're doing the syringing in antero-inferior direction. बराबर. Second, we know vagus is a sympathetic or parasympathetic nerve. Let me know in the chat box. Vagus is a sympathetic or parasympathetic nerve. Let me know in the chat box, बच्चे. Sorry. Vagus is a sympathetic or parasympathetic nerve, beta. I hope all of you are quite aware basically that vagus is nothing else but a parasympathetic nerve. If you irritate or if you stimulate the vagus nerve, there will be a parasympathetic activity. That means suddenly the patient's heart rate and the BP will drop. And if the patients, I am not asking motor or sensory that you are answering mixed. I am saying basically it is sympathetic or parasympathetic. So it is mainly a parasympathetic nerve beta, and that will cause vasodilatation or sudden decrease in the heart rate and BP. And if there is sudden drop in the BP beta, the brain does not receive enough blood supply. And as the brain does not receive enough blood supply, the patient falls down unconscious. Patient बेहोश होके नीचे गिर जाता है बेटा, and that is classically known as nothing else but vasovagal syncope or a syncopal attack beta. Clear? So another problem that happens due to the vagal stimulation is a vagovagal syncope or syncopal attack. The brain does not receive enough blood supply due to sudden drop in BP. समझे बात? Known as the vasovagal syncope. So if they ask you that during ear syringing, patient experiences vertigo, causes use of cold water. If they ask you during ear syringing, patient experiences cuff reflex or patient suffers from a vasovagal syncope, causes irritation of Arnold's nerve or vagal stimulation due to antero-inferior direction of ear syringing beta. समझे बात यहाँ तक? चलो. Next, let's say a patient who is a boxer beta, a boxing professional comes to us with the complaints of trauma to the ear or trauma to the pinna. And due to the trauma to the pinna or due to trauma to the ear, the patient is having this collection of blood in the pinna. And this is classically known as nothing else but pinna hematoma beta. Barabar, this condition is classically referred to as a pinna hematoma. So as I've told you, what is the most common cause of pinna hematoma? The leading cause of pinna hematoma is nothing else but trauma, which is commonly seen in boxers or wrestlers beta. Okay? What is the treatment of pinna hematoma? Let me know in the chat box. As you are able to see, this is a case of pinna hematoma beta. What is the treatment of pinna hematoma? Let me know in the chat box. What is the treatment of pinna hematoma? We know, as it is collection of blood or hematoma, what we have to do, we have to take a needle, an empty syringe, and insert the needle in the swelling and aspirate all the blood collected in the hematoma beta. Shabash. So treatment is nothing else but aspiration. But if we do an aspiration and leave it as it is, there will be reaccumulation of blood or recollection of blood basically beta. That's the reason after aspiration, followed by aspiration, apply pressure bandage with it. Reason, after aspiration, when you apply pressure bandage, obviously the recollection of blood or the reaccumulation of blood is not going to happen. बराबर, वापस collection नहीं होगा. So treatment has to be nothing else but aspiration followed by a pressure bandaging. Let's say, if in case I do not treat pinna hematoma, let's say if we are not going to treat the pinna hematoma, patient develops a deformity beta. And what is that deformity called as? If the pinna hematoma is not treated timely, the patient will develop a deformity where the pinna will appear very irregular beta. And that complication or that deformity is known as which one? Shabash. Yes, that deformity can be called as the cauliflower ear or boxer's ear beta. Yes, that is known as the cauliflower ear or boxer's ear. To do remember, in case if you do not treat the pinna hematoma properly, patient develops a deformity called as cauliflower ear also known as the boxer's ear. Okay, chalo. Done with this. Now let's talk about the next part, beta. Then next is this one over here. Here we are having an elderly diabetic patient, beta, and this elderly diabetic patient comes to us with complaints of severe earache, beta, that is pain or otalgia, along with a purulent blood-stained ear discharge. The purulent blood-stained ear discharge. Purulent means pus containing. Okay? Along with features of facial nerve palsy or the seventh cranial nerve palsy. On examination, granulations are seen in the external auditory canal. If you examine the external auditory canal, you will find granulation, and this is the purulent ear discharge, beta. What is the likely diagnosis? What is the likely diagnosis? So first of all, patient is elderly diabetic, that is patient is immunocompromised, beta. In immunocompromised, there is an infection which is happening, and it is mainly an infection of the external ear, okay, also known as otitis externa. But as it is a very severe infection, yes, we refer it to as, or we call it as a case of malignant otitis externa. Malignant does not mean any cancer. Malignant only means it is very severe condition. Okay? So diagnosis of this case is nothing else but malignant otitis externa. And why this malignant otitis externa is so severe? Reason, in this condition, the infection is not limited to the external ear, or the infection is not only limited to the external auditory canal. The infection may spread to the skull base, and as the infection spreads to the skull base, beta, patient will have multiple cranial nerve palsy. Why? From the skull base, you know, multiple cranial nerves are going to exit the cranial cavity. So as the infection goes up to the skull base, patient develops multiple cranial nerve palsy. Okay, so that is what is important to be remembered. So these are the important points. Now, why I was so sure that it is the case of otitis externa and not otitis media? The main reason being, beta, a purulent ear discharge. Purulent, that is pus containing ear discharge. I'll tell you two important things. Yaad rakhna. First, if they say a purulent ear discharge, beta, that is only a pus containing ear discharge. And second, if they say the patient is having a tracheal tenderness or a tracheal sign. What do I mean by that? If you press the tragus of pinna, the patient has a lot of pain. Okay, that is known as the tracheal tenderness or the tracheal sign. If these two features are there, it has to be a case of external ear infection, also known as otitis externa, beta. It is a case of external ear infection, also known as otitis externa. Now, it can be a localized otitis externa, like furunculosis. It can be diffuse otitis externa, which we call as swimmer's ear, or it can be a malignant otitis externa, which we are talking about right now. Samjhe baat? Purulent ear discharge and tracheal sign or tracheal tenderness is the feature of otitis externa. Then what is the feature of otitis media? It is a mucopurulent ear discharge. Reason, whenever there is a middle ear infection, it is not only the, it is not only basically, beta, the pus, it is also the mucus which is coming out. So mucopurulent ear discharge, and tracheal sign or tracheal tenderness is negative, beta. The tracheal sign or the tracheal tenderness is negative. No pain on pressing the tragus. Okay? If these are the features that are seen, beta, then it is a classical case of nothing else but the middle ear infection, also called as otitis media. So can you see, just by symptoms, things will be much easier for you. Okay? So purulent ear discharge with tracheal sign or tracheal tenderness is otitis externa. Mucopurulent ear discharge without a tracheal sign or tracheal tenderness is otitis media. समझे बात यहाँ तक? That is important. Clear? चलो. Now, coming back to the malignant otitis externa, we know it is a severe external ear infection which is commonly seen in immunocompromised patients like elderly diabetics. Okay, and in this condition, patient will have multiple cranial nerve palsies like facial palsy as well, and therefore it is life-threatening. Now, most common cause, we know severe conditions or severe infections will not happen due to Staph aureus. They usually happen due to a deadly organism like Pseudomonas, beta. Yes, so Pseudomonas is the leading cause of malignant otitis externa. Chalo, I'll integrate it with micro. Please tell me, what is the culture media for Pseudomonas? Let me know in the chat box. What is the culture media used for Pseudomonas? The most common cause of malignant otitis externa is Pseudomonas aeruginosa. And as it is a bacterial infection, treatment has to be IV antibiotics, beta. It is a very severe infection, so you have to go for IV antibiotics. Do remember, Pseudomonas needs broad spectrum antibiotics, beta. Broad spectrum antibiotics like third or fourth generation cephalosporin, especially something like ceftriaxone beta. Third or fourth generation cephalosporin like ceftriaxone. And later on, when you have to shift to oral antibiotics, you can give ciprofloxacin beta. Later on, you can shift to ciprofloxacin beta. Clear है बात? यहाँ पे meropenem is usually not needed. In case if the patient is not responding to ceftriaxone, then you can shift on to peptaz or meropenem like drugs. समझे बात? चलो. Next, another is a case beta known as otomycosis. Now, I hope all of you are quite aware. Mycosis is usually a fungal infection. याद रखना, mycosis is usually a fungal infection except in two conditions. One, botryomycosis, which is a bacterial infection caused by Staph aureus, and second, mycosis fungoides, which is a cutaneous T-cell lymphoma. Otherwise, everywhere, mycosis is always a fungal infection. So, otomycosis, which is there beta, do remember, is a fungal infection of the external auditory canal, and the most common cause for it is nothing else but Aspergillus. Which kind of Aspergillus? Aspergillus niger beta. And we know Aspergillus niger. Niger literally means everything black. Barabar? The leading cause is nothing else but Aspergillus niger, and Aspergillus niger literally means everything black. Therefore, if you see the otoscopy, on otoscopy you are able to see a classical appearance. Some whitish, some blackish and moist areas beta, giving you a classical appearance called as the wet newspaper appearance. Shabash. Yes. The otoscopy in a case of otomycosis gives us the classical wet newspaper appearance that has to be kept in mind. Okay, the wet newspaper appearance is going to be classically seen in the patient beta. Understood? We know as it is a fungal infection, the main complaint of the patient is not earache or otalgia. The main complaint of the patient has to be itching beta. A lot of itching or pruritus will be there in the ear. And treatment, you have to clean the ear beta. And cleaning the ear is known as oral toilet along with antifungal ear drops. The oral toileting should be done, or cleaning of the ear should be done along with antifungal ear drops beta. Yeah. I asked you basically the culture media. The culture media for Pseudomonas is cetrimide agar beta. Cetrimide agar pe green color colonies are seen. Do you remember that? Okay. Next is this case, August 2020 FMG, and repeated after that also. The question states beta, a patient was cleaning the ear with hairpin. Okay, the patient was cleaning the ear with hairpin, and accidentally the patient has injured the tympanic membrane, leading to a traumatic tympanic membrane perforation. As you are able to see the otoscopic picture, here you can see there is a traumatic tympanic membrane perforation beta. So what should be the treatment in this regards? Let me know in the chat box. So either due to hairpin injury, or due to slap, or due to a sudden exposure to loud sound like a DJ. Okay? In these conditions beta, the patient may have a traumatic tympanic membrane perforation. And due to the traumatic tympanic membrane perforation, what should be the treatment for this? I hope all of you are quite aware. Shabash. The treatment has to be nothing. That is reassurance beta. The treatment has to be nothing. That is reassurance. Okay? Just reassurance to the patient has to be done basically beta. That has to be kept in mind. Barabar, only reassurance to the patient has to be done. Reason is, please remember, traumatic tympanic membrane perforation is a self-limiting or a self-resolving condition. You don't need to treat it at all beta. It is going to heal within a span of 3 to 6 months. Okay? Yes, do nothing, observation, no treatment, reassurance. That is what is important to be remembered. So up to a span of 3 to 6 months beta, it is going to resolve on its own. It resolves spontaneously beta. Okay? In case if the condition does not resolve even after 6 months, in case if the condition does not resolve even after 6 months, then I go for a repair, or then we go for a surgery called as myringoplasty. Okay? Even after 6 months, when it does not resolve, then we go for a treatment or a surgery called as nothing else but myringoplasty. So 6 महीने बाद भी, in case if it does not resolve, then you have to cover the tympanic membrane perforation beta with the help of a graft known as myringoplasty. And the graft that we commonly use is the temporalis fascia beta. The graft that we commonly use is the temporalis fascia. Clear about that is what is important. Yes. Now another condition if I talk about is nothing else but ASOM beta. What is ASOM? Acute suppurative otitis media. We know otitis media means middle ear infection beta. Suppurative means pus collection is there, right? So acute suppurative otitis media is a middle ear infection forming a lot of pus, and due to that pus, the patient will have heaviness in the ear, the patient will have earache or otalgia, and the patient will have conductive hearing loss. बेटा समझे बात? तो ASOM का most common cause if they ask you, do remember the leading cause of ASOM is the streptococcus. Either it can be streptococcus pneumoniae or it can be the streptococcus pyogenes. The leading cause of ASOM or acute suppurative otitis media is going to be the organisms like streptococcus pneumoniae or streptococcus pyogenes. Beta, that has to be remembered. Clear about? So do remember. Yes, it is secondary to URTI. Beta. Reason: if a patient is having pharyngitis or if a patient is having upper respiratory tract infection, क्या होगा? The bacteria or the organism from the nasopharynx goes up to the middle ear via the eustachian tube, and that is how the middle ear infection or otitis media develops. समझे बात? Complaints, the patient complains of what? As I've told you, the patient complains of a severe earache. Beta, along with earache, the patient will also have conductive hearing loss due to collection of pus. And if you do a examination, on otoscopic examination, you can find due to inflammation, the capillaries on the tympanic membrane appear dilated. And as these capillaries on tympanic membrane appear dilated, they will give us a very classical appearance called as the cartwheel appearance, which is that gives us the very classical appearance known as the cartwheel appearance. These dilated capillaries on tympanic membrane looks like the cartwheel. That has to be remembered. And if the patient is having ASOM only with the cartwheel appearance, beta, my treatment is nothing else but just go for oral antibiotics. Beta, just go for systemic antibiotics or the oral antibiotics in the patient, and that will help resolve the condition. Clear? But let's say if this is the case, beta, what is this case? It is a patient of ASOM only. Here also there is a case of ASOM only. If you see the otoscopy, you are able to see the cartwheel appearance also. But apart from cartwheel appearance, you are able to see a full or bulging out tympanic membrane. Barabar, there is a full tympanic membrane or a bulging out tympanic membrane. Why? Because behind the tympanic membrane in the middle ear, there is excessive pus collection. And due to the excessive pus collection, the tympanic membrane is full or it is bulging out. What should be the treatment in this regard? Let me know in the chat box. If they say there is a ASOM with a full or a bulging out tympanic membrane, beta, in this condition, your treatment, will it be only antibiotics? Your treatment, will it be only antibiotics, beta, now? Let me know in the chat box. Very good. So we know, beta, basically that if there is a full or a bulging out tympanic membrane, if you only give oral antibiotics, beta, ultimately the tympanic membrane is going to rupture or it is going to perforate. So better is go for an early myringotomy, that is make an incision over the tympanic membrane and drain all the pus which is collected in the middle ear cavity, beta, and that procedure is known as myringotomy. So you have to do a myringotomy. Yes, very good all of you. Myringotomy for pus drainage is usually done in the postero-inferior quadrant. Myringotomy for pus drainage is done in the postero-inferior quadrant, has to be remembered. Okay? So you have to do a proper myringotomy in the patient. Along with that, give oral antibiotics as well. Okay, along with oral myringotomy, also give oral antibiotics, but mainstay of management has to be a myringotomy if there is a full or a bulging out tympanic membrane. Chalo. Hopefully clear to all of you now. So these are the points, beta. So one word can change your answer over here. Do remember this point, that full tympanic membrane can change your answer from only antibiotics to myringotomy with antibiotics. Next one. Here you are able to see a case, beta, and what is seen in this? A child complains of heaviness in the ear, beta, along with a bilateral CHL or a bilateral conductive hearing loss. Child is also having poor school performance. Obviously, due to the hearing loss, the child may be having a poor school performance. So when a school going child comes to you with complaints of only heaviness in the ear, mind it, the patient is not having any pain or any earache. There is only heaviness, beta. Okay, along with a bilateral CHR or a bilateral conductive hearing loss. Very good all of you. Yes, it is more probably a case of nothing else but a glue ear, also known as serous otitis media. हमें पता है, let's say this is your nasopharynx, beta. On the lateral wall of nasopharynx, on both the sides we have the eustachian tube opening, and this eustachian tube or the auditory tube connects the nasopharynx to the middle ear beta. It connects the nasopharynx to the middle ear basically. Clear hai baat? Now let's say a school going child has a recurrent upper respiratory tract infection. Due to that recurrent upper respiratory tract infection, the child develops adenoid hypertrophy. And due to the adenoid hypertrophy, you can see both the eustachian tube openings are blocked. As both the eustachian tube openings will be blocked beta, this middle ear will not be able to drain the secretion. And if middle ear cannot drain the secretion, all these secretions will collect in the middle ear. And when this thick glue-like secretions collect in the middle ear beta, that condition is known as glue ear, also called as serous otitis media, also known as otitis media with effusion. Samjhe baat? Do remember, as there is no infection over here, it is a sterile condition and therefore it is painless. The child does not have any earache. The child only has heaviness in the ear beta. Samjhe baat yahan tak? Chalo. So do remember, the diagnosis is nothing else but a case of glue ear, also called as the serous otitis media, but nowadays they have started using the term known as otitis media with effusion. Effusion is nothing else but fluid collection itself. Samjhe baat? Chalo. So that is what is important. Now if I talk about glue ear or the otitis media with effusion beta, the leading cause or the most common cause for it, as I've told you, is known as adenoid hypertrophy. Okay? It is nothing else but adenoid hypertrophy. There are multiple other causes. Any cause which can cause blockage of the eustachian tube, any condition which can lead to the blockage of the eustachian tube beta will cause a glue ear. But most common cause is usually adenoid hypertrophy seen in school going children beta, which leads to a bilateral glue ear or a bilateral otitis media. Let me know in the chat box, if a patient more than 50 years of age comes to you with a unilateral glue ear, what is the differential that should come to your mind? Very good. A patient more than 50 years of age comes to you with a complaint of unilateral glue ear, what should be the differential that should come to your mind? I hope all of you are quite aware. Very good. Yes. Then the differential has to be NPC or the nasopharyngeal carcinoma beta. Shabash. Great. Next important, if I talk about in a case of glue ear beta, the patient will only have heaviness along with the conductive hearing loss. If you do an examination, this is the classical picture seen. Behind an intact tympanic membrane or behind a normal tympanic membrane, you are able to see fluid collection. And in that fluid, there are some bubbles which are seen beta. Okay? So this has been a previous year image based NEET PG question. Do remember that. So there is a fluid behind an intact or a normal tympanic membrane beta. That is a classical picture of glue ear. If they ask you basically, tympanometry will show you which kind of a curve beta in a case of glue ear. Let me know in the chat box. Tympanometry or the impedance audiometry is the investigation which checks the freedom of movement of the tympanic membrane and the ear ossicle. Okay? We know as there is a lot of fluid in the middle ear, the ear ossicles will not be able to freely move. And as the ear ossicles cannot freely move beta, then definitely a flat curve is seen on tympanometry. Shabash, all of you. And the flat curve seen on tympanometry is classically known as the type B curve beta. So if it is a case of glue ear, do remember tympanometry shows you the classical type B curve. This has been a repeat FMGE question. Do remember this. Samjhe yahan tak baat? Now, if they ask you what is the treatment, do remember, for a glue ear, you have to drain all the fluid collected in the middle ear cavity. For that, what I do is, we make an incision over the tympanic membrane. After making an incision in the tympanic membrane, that is myringotomy, I will drain all the fluid collected beta. Do remember, the myringotomy that we do for drainage or grommet insertion is done in the antero-inferior quadrant basically. Okay? So we do a myringotomy for the fluid drainage, and after that, we insert a middle ear ventilation tube called as grommet. As you are able to see in this picture also, this is your middle ear ventilation tube called as grommet, okay, which will be inserted at the end of the procedure. So the treatment for glue ear is nothing else but myringotomy plus grommet insertion. In case, okay, in case if they say the cause is adenoid hypertrophy, if they say the cause is adenoid hypertrophy, then we plan for adenoidectomy beta. If they say the cause is adenoid hypertrophy, then we may also plan for a adenoidectomy. Samjhe baat? So myringotomy and grommet insertion is just done for glue ear, but For the underlying cause, you have to find the underlying cause by nasopharyngeal endoscopy. And once you have found the cause, what is the cause? You have to treat that cause also. Plus minus adenoidectomy will be done. समझे बात यहाँ तक? चलो. Another classical case that you are able to see is we are having a 25-year-old young female beta. This young female comes to us with complaints of gradually progressive bilateral conductive hearing loss. There's a gradually progressive bilateral conductive hearing loss, but she mentions there is worsening of symptoms beta since she has been pregnant. That is, pregnancy is the aggravating factor, or pregnancy is a worsening factor beta. Pregnancy की वजह से और hearing खराब हुई है. So please tell me what is the provisional diagnosis that should come to your mind. Very classical. Young female coming to us with complaints of bilateral conductive hearing loss, which worsens basically during pregnancy beta. A classical case of which condition? A classical case of nothing else but otosclerosis beta. Very good. A condition known as otosclerosis, also known as otospongiosis bache. Now we know sclerosis literally means fibrosis beta. Barabar? Sclerosis literally means fibrosis. So what happens in this case? In this case, let's say this is the stapes beta. So around the footplate of stapes, there is going to be fibrosis. And if there is fibrosis around the footplate of stapes, the stapes footplate will get fixed, or the stapes will not be able to move. Or मुझे बता, if the stapes cannot move only, will there be proper conduction of sound? No. As the stapes has got fixed due to fibrosis, there is no movement of stapes, and no movement of stapes means no conduction of sound, and therefore the patient suffers from a conductive hearing loss. समझे बात? So that is important. Otosclerosis, which is there here, the patient is going to have fixation of stapes due to fibrosis, and due to fixation of stapes beta, the patient suffers from the conductive hearing loss. Understood? Another feature, we know in cases of otosclerosis, there is a classical phenomena. And what is that phenomena? Patient hears better in noisy areas beta. So as the patient goes to noisy areas beta, patient is able to hear better. What is this phenomena known as? Let me know in the chat box. Patient hears better in noisy areas. What is this classical phenomena called as? Let me know in the chat box. We know the patient hears better in noisy areas is classically called as paraacusis villi beta. This phenomena is classically known as nothing else but paraacusis villi. It is a very classical finding seen in patients of otosclerosis basically. Clear about? It is known as paraacusis villi. Okay? Now, any patient who comes to us with complaints regarding the ear or with complaints of hearing loss, the first two investigations that I do, one is an otoscopy. Otoscopy is done for the examination of external auditory canal and the tympanic membrane. And second, a pure tone audiometry. That pure tone audiometry or PTA is done for hearing. Clear? So if I do an otoscopy beta, I'll be able to see this classical picture. On otoscopy, you are able to see this classical flamingo pink appearance, also known as the Schwartz sign beta. Please tell me one point, and that is flamingo pink appearance or Schwartz sign on otoscopy is seen in the early stages or late stages of otosclerosis. It is seen in the early stages or the late stages of otosclerosis. Let me know. The flamingo pink appearance or the Schwartz sign that you are able to see, it is a feature of early or late stage of otosclerosis. The classical flamingo pink appearance, also known as the Schwartz sign. It is only seen in early stages of otosclerosis. Shabash. So as it is seen in the early stages of otosclerosis beta, what should be the treatment? If the patient comes to you in the early stages of otosclerosis with a Schwartz sign positive, the treatment is not surgery beta. Reason, as the patient is in the early stages or the Schwartz sign is positive, I don't go for a surgery immediately. I go for a conservative management where we will give a drug that is known to stabilize the disease. Matlab, this drug will not let the fibrosis proceed further. और ज़्यादा fibrosis नहीं होने देता. What is that drug basically? That was a PYQ. Shabash. Very good. So in the early stages of otosclerosis beta, we basically give a drug to stabilize the disease, and that drug is basically known as oral sodium fluoride. That drug is known as the oral sodium fluoride basically. That has to be remembered. No issues with this? Sure. So these are the points that you need to remember in this condition, beta. Very good. Next important if I talk about is nothing else but the PTA. PTA is nothing else but pure tone audiometry. That is, whenever patient is not able to hear properly, we do a pure tone audiometry, which will tell us whether the patient has a normal hearing or he is suffering from hearing loss. Second, it will also tell us whether it is a conductive hearing loss or a sensory neural hearing loss. And third and most important, it will tell us basically beta that how much severe is the hearing loss in the patient. Clear? तो यहाँ पे देख सकते हो. First of all, there are two things that we will check. One is the air conduction basically, and second is the bone conduction beta. ठीक है? So the brackets are going to represent bone conduction. The circles are going to represent air conduction basically. You can see if both the lines are less than 25 decibel. This is the landmark of 25 decibel. Both the lines, if they are less than 25 decibel, we say there is normal hearing beta. If both the lines are less than 25 decibel, we say normal hearing. But here what we are able to see, bone conduction is less than 25 decibel. So you can say bone conduction is normal. As bone conduction is less than 25 decibel, you can say bone conduction is normal. But air conduction is more than 25 decibel or air conduction is beyond 25 decibel. As air conduction is beyond 25 decibel, do remember that means air conduction is poor. Do remember that whenever they say bone conduction is normal and air conduction is poor, it is a case of conductive hearing loss or sensory neural hearing loss beta. Bone conduction, when you check, the sound directly goes to the inner ear. Therefore, the bone conduction is normal, matlab inner ear is normal. But when you check for air conduction, the sound travels from external ear, then the middle ear, and then the inner ear. But if air conduction is poor, that means there is some problem in the external or middle ear. And any problem in external or middle ear is classically suggestive of CHL. That is nothing else but conductive hearing loss beta. Samjhe baat abhi? So that is how you identify. On a pure tone audiometry, do remember if the bone conduction is normal, less than 25 decibel, and ठीक है, we will come back again basically. Don't worry about that. Pure tone audiometry और एक बार आएगा. So bone conduction is normal and air conduction is poor. That is classically a case of nothing else but CHL or conductive hearing loss. Has to be remembered. Here you are able to see. You can also see a dip in bone conduction at 2000 hertz beta. Okay, this dip in bone conduction at 2000 hertz is classically called as your Carhart's notch, right? Yes. So do remember the dip in bone conduction at 2000 hertz is classically known as Carhart's notch. And do remember, Carhart's notch is a classical feature of otosclerosis. Carhart's notch is a very special feature or a specific feature of otosclerosis. Carhart's notch is not seen in other conditions or other cases of conductive hearing loss beta. समझ आई यहाँ तक बात? That is what is important. Now, if the patient comes to us in the late stages or in the advanced stages of otosclerosis, we have to go for a surgery beta. And the surgery that we do is nothing else but beta. Two options are there. One, if the stapes is not damaged beta, we will try to save the stapes. And if you try to save the stapes, that surgery is known as stapedotomy. What we do in stapedotomy, we just remove all the fibrosis around the footplate of stapes and make the stapes free. ठीक है, जो fibrosis है उसको हटाओगे basically बेटा. That is what is important. बेटा, I will come to the graph or the pure tone audiometry again. Just wait. Audiology में I have included graphs of CHL and SNHL again. Don't worry about that. समझे बात अभी? That is what is important. So one is, if the stapes can be saved basically, I will just remove all the fibrotic material around the stapes beta. And then definitely we will make the stapes free. And that procedure is known as stapedotomy. But let's say if the stapes is damaged. अगर stapes खुद खराब हो चुका है, I have to remove the stapes. And removal of stapes is known as stapedectomy beta. The removal of stapes is known as stapedectomy. And once you remove the stapes, you may have to place a prosthesis in place of that. ठीक है, अगर हम stapes निकाल देंगे, we have to place a prosthesis in place of that stapes beta. That is what is important. So either stapedotomy or a stapedectomy will be the surgery that can be done depending on the status of stapes beta. समझे बात यहाँ तक? Yes. Next important is this one. That is nothing else but a case of CSOM, also called as chronic suppurative otitis media beta. ठीक है? I hope all of you are quite aware that CSOM or chronic suppurative otitis media is a middle ear infection basically, which is again going to cause a lot of pus formation, but it will have a long history. The patient will have this problem since months together, beta. Therefore, we call it as CSOM or chronic suppurative otitis media. समझे बात? There are two types of CSOM that we have. One is called as the safe CSOM, also known as tubotympanic CSOM, beta. And the second is known as unsafe CSOM, also known as atticoantral CSOM. What is the basic difference? Understand this once. समझ लो. If I say the middle ear infection is only limited to the middle ear cavity, matlab it is not damaging the walls, it is not spreading outside the middle ear, then we call it a safe CSOM. अगर वो infection बस middle ear के अंदर ही रहेगा, उसके बाहर नहीं फैल रहा है, that is what is known as safe CSOM. Unsafe CSOM means when the infection damages the walls of middle ear. Once the infection damages the walls of middle ear and starts spreading outside, that is known as unsafe CSOM. अनसेफ का मतलब जब मिडल ईयर की वॉल्स डैमेज हो जाती है और इन्फेक्शन बाहर फैलना शुरू करता है, दैट इज व्हाट इज नोन एज अनसेफ सीएसओम. बच्चे क्लियर है यहां तक? चलो, तो सेफ सीएसओम इज नोन एज tubotympanic CSOM. रीजन, द इन्फेक्शन स्प्रेड्स फ्रॉम द eustachian ट्यूब and it is only limited to the middle ear or the tympanum. Therefore, we call it as tubotympanic. Unsafe CSOM matlab it is also known as atticoantral CSOM. Attic is epitympanum or the upper part of middle ear, and antrum is the largest and the most constant mastoid air cell, beta. Here the infection is not only limited to the middle ear or the tympanum, it is also spreading to the antrum or the mastoid air cells. Therefore, we call it as unsafe CSOM. समझे बात यहाँ तक? That is the basic idea. Now, do remember, beta, in both the conditions, which type of tympanic membrane perforation you see. In ASOM, we know there is no tympanic membrane perforation. But in CSOM, ultimately the patient develops a tympanic membrane perforation. If there is a central perforation in the tympanic membrane, patient develops a safe CSOM or a tubotympanic CSOM. But if there is a marginal perforation in the tympanic membrane, patient develops an unsafe or an atticoantral CSOM. Why? Understand. Let's say, beta, this is your tympanic membrane, and in the tympanic membrane there is a marginal perforation like this. अब क्या होगा? The skin from the the skin of the external auditory canal will grow inside the middle ear cavity. Why? As the margins are absent, beta, right? As the margins are absent, the skin of this external auditory canal grows inside the middle ear cavity. And when this ectopic skin grows in the middle ear cavity, that looks like this pearly white mass. Let me know what is this known as. So along the absent margins, when the skin of the EAC grows in the middle ear, beta, that is classically going to form this pearly white mass. And this pearly white mass is known as nothing else but cholesteatoma. सुना होगा ना? तो we know basically, beta, that cholesteatoma which is there, it is nothing else but, beta, a pearly white mass which is going to be seen. Okay, and that cholesteatoma is nothing else but ectopic skin in the middle ear, beta, and that is what is going to cause unsafe CSM. Why? Reason, this cholesteatoma is basically known to cause bone erosion. This cholesteatoma releases bone eroding enzymes, and as it causes bone erosion, beta, the infection now is not only limited to the middle ear, the infection will start also spreading outside the middle ear, therefore called as unsafe CSM. ठीक है? तो cholesteatoma की वजह से, if the bone erosion happens and the walls of middle ear are damaged, the infection spreads outside the middle ear basically, and that is the reason why we call it as unsafe CSM. समझे बात यहाँ तक? That is important. Do remember, in both the conditions of safe as well as unsafe CSM, the complaints are going to be similar. One, the patient is going to have earache or otalgia because it is an infection. Second, patient will have CHL or a conductive hearing loss. Third, the patient will have a mucopurulent ear discharge, beta. Third, the patient will have a mucopurulent ear discharge. Why mucopurulent? It is a otitis media or middle ear infection. If it was otitis externa, then only purulent ear discharge would have been seen. ठीक है? Please tell me, beta, if I'd say conductive hearing loss, हमें पता है conductive hearing loss in CSOM mainly happens due to ossicular erosion or ossicular damage. Due to this chronic infection, beta, the ear ossicles will get damaged. Let me know in the chat box which is the most common ear ossicle eroded. What do you think? In a case of CSOM beta, if they ask you which is the most common ear ossicle eroded, answer will be the most common ear ossicle that is eroded in a case of CSOM. Very good. It is incus beta. This is important to be remembered. Reason is incus has no muscle attachment. As incus has no muscle attachment, it has the least blood supply. And as it is going to have the least blood supply, it is more prone for erosion or more prone for damage beta. So incus is the most common ear ossicle eroded. And if the ear ossicles will get eroded, conduction of sound cannot happen properly, leading to a CHL or a conductive hearing loss. समझे बात यहाँ तक? चलो. Treatment की अगर हम बात करें, once you have done a X-ray and a CT mastoid properly beta, once you have seen the status of ear ossicles, once you have seen the status of the middle ear walls beta, then we'll go for the treatment. If it is a case of safe CSOM, you will find the infection of the ear is limited to the middle ear only. It is not spreading outside the middle ear. Okay, and the ear ossicles would have been eroded. Whereas unsafe CSOM, you will find that the walls have been eroded and the infection has gone outside the middle ear cavity. ठीक है? Safe CSOM में the treatment is basically called as nothing else but tympanoplasty. Tympanum is another name for middle ear. Plasty literally means repair. So whenever you go for a surgery which will help in the repair and cleaning of the middle ear beta, that treatment is known as tympanoplasty. There are total 5 types of tympanoplasty beta. That is what is important. ठीक है? Incus is not safe. Incus is the most common one to get damaged. Incus not safe. Incus is the commonest one to get damaged. Clear? So do remember, treatment of safe CSOM or tubotympanic CSOM is tympanoplasty beta. That has to be done. That is nothing else but repair of the middle ear cavity. Okay, understood. That depends. There are total 5 types of tympanoplasty beta. Which type of tympanoplasty to be done? That completely depends on the status of ear ossicle. कौन सा ear ossicle damaged है, कौन सा ear ossicle बचा हुआ है. Depending on the status of ear ossicles, you decide the type of tympanoplasty. I tell you the main ones. Like if you say all the ear ossicles are intact, मतलब malleus, incus and stapes, all of them are absolutely normal. M plus, I plus, S plus situation. In this condition, you prefer going for a type 1 tympanoplasty beta. Type 1 tympanoplasty में क्या करना है? You just have to repair the tympanic membrane perforation. And for the repair of tympanic membrane perforation, we go for a procedure known as myringoplasty. For the repair of tympanic membrane perforation, I go for a procedure known as myringoplasty. So if all the ear ossicles are absolutely normal, or if all the ear ossicles are absolutely intact, just repair the tympanic membrane perforation. That is known as type 1 tympanoplasty, also known as myringoplasty beta. Clear hai baat? That is what is important. Next, if I talk about basically is the M minus, I minus, S plus situation. इसका मतलब क्या? The malleus and the incus have been eroded. The malleus and the incus have been damaged beta. Do remember. And due to this, definitely now, which type of tympanoplasty or which type of surgery is done? We go for a type 3 tympanoplasty. If malleus and incus have been eroded, or if malleus and incus have been damaged, we go for a procedure known as nothing else but a type 3 tympanoplasty. ठीक है? Type 3 tympanoplasty is also called as a columella tympanoplasty beta. Columella is another name for stapes. ठीक है? So याद रखना, type 3 tympanoplasty is also known as a columella tympanoplasty, और we can also call it as myringostapediopexy. क्यों? यहाँ पे हम क्या करेंगे, जो खराब हुआ malleus और incus है उसको निकाल के फेंक देंगे, और जो tympanic membrane का graft है वो डायरेक्टली स्टेपीज के ऊपर फिक्स कर देंगे. इसीलिए वी कॉल इट एज myringostapediopexy. Do remember, in type 3 tympanoplasty, what we do is we remove the damaged malleus and incus and we directly fix the tympanic membrane graft over the normal stapes. As you directly fix the tympanic membrane graft over the normal stapes, you call this procedure as myringostapediopexy, also known as type 3 tympanoplasty. Hopefully clear to all of you now. So these are the two conditions that you can remember, where we go for a type 1 and a type 3 tympanoplasty respectively if the patient is suffering from safe CSOM, also known as tubotympanic CSOM. Unsafe CSOM or atticoantral CSOM में we go for a procedure known as MRM, or a modified radical mastectomy. Radical why? Reason, here we will not clean or here we will not only repair the middle ear beta, but along with middle ear, we will also repair all the other structures which have been involved. Unsafe CSOM, as the infection has gone outside the middle ear also, so we will repair not only the middle ear, but the other structures involved as well. And therefore we call it as the radical mastodectomy or a modified radical mastodectomy surgery beta. Hopefully clear to all of you now. So that is what is important to be remembered. समझे बात? Not only unsafe CSOM or atticoantral CSOM, but majority complications of unsafe CSOM or atticoantral CSOM will be treated by the same procedure called as MRM or the modified radical mastodectomy itself. Clear है बात? That is what is important to be remembered. ठीक है? चलो. Just we will take a 5 to 10 minutes break, and after the 10 minutes of break, definitely we'll start the last session. ठीक है? चलो. Just a 5 to 10 minutes. A short break will be this one. Don't take a very long break, and we'll immediately start and finish off the session after this. ठीक है? चलो बच्चे. Then hopefully the audio visuals are clear again. Shall we start? Correct, start. So I've already discussed safe CSOM or tubotympanic CSOM. The treatment are tympanoplasties. There are total 5 types of tympanoplasty. But if all the ear ossicles are normal, go for a type 1 tympanoplasty called as myringoplasty. And if malleus and incus is eroded, then go for a type 3 tympanoplasty called as myringostepidiopexy or a columella tympanoplasty. And unsafe or atticoantral CSOM, the treatment is MRM, known as modified radical mastectomy. Clear? Chalo. Now, if they ask you what are the complications of this unsafe CSOM, हमें पता है in unsafe CSOM beta, as the walls of the middle ear will be eroded or as the walls of the middle ear will be damaged, the infection will spread outside the middle ear beta. And once the infection starts spreading outside the middle ear, multiple complications may happen, right? Now, the most common complication of unsafe CSOM overall is, we know, the infection can easily spread to the mastoid hair cells beta. And when the infection easily spreads to the mastoid hair cells, the patient develops acute mastoiditis basically. Barabar? So, the most common complication if they ask you for a case of unsafe CSOM, answer is nothing else but acute mastoiditis beta. Acute mastoiditis is the commonest complication of unsafe CSOM. Apart from acute mastoiditis, there are other complications like the infection may spread to the other sides where there will be pus collection or abscess formation. Third, the patient may develop a labyrinthine fistula. Fourth, the patient may develop meningitis. Fifth, the patient may develop a brain abscess. Sixth, the patient may develop a subdural empyema. Seventh, the patient may develop sigmoid sinus thrombosis. So multiple such complications can be seen beta, that has to be remembered. Clear about most common complication which is there basically, okay, it is going to be nothing else but acute mastoiditis. Most common intracranial complication if they ask you, because acute mastoiditis is an extracranial complication. Most common intracranial complication if they ask you beta, answer is meningitis. Most common intracranial complication, answer is nothing else but meningitis beta, has to be remembered. Clear about? Do you remember this? Recorded the surgery sessions basically for NEET PG and INR-CT I'll be recording very soon, and we'll share the details as well beta. Okay, once they are recorded. Okay. Sure. Thank you so much. The most common complication which is there basically, it is acute mastoiditis beta, and most common intracranial complication if they ask you, if the infection spreads to the cranial cavity, it is going to be meningitis beta, has to be remembered. Clear about? Now here there's a question which states a person had a history of CSOM or chronic suppurative otitis media, and now the patient has been brought to the casualty or the emergency beta with complaints of altered sensorium, seizures and confusion. The MRI has been given below, which shows you this kind of a picture. What is the likely diagnosis? Let me know in the chat box beta. What is the likely diagnosis? MRI pe we are able to see a classical ring enhancing lesion, right? On the MRI you are able to see a cavity, okay, around that you are able to see a sclerotic ring basically. This is known as the ring enhancing lesion beta. So I hope all of you are quite aware that if the patient is having unsafe CSOM ka history, after that the patient is basically having all these symptoms and a ring enhancing lesion on MRI beta, it is a classical diagnosis of nothing else but a autogenic brain abscess. Yes, so due to a ear infection, when the patient develops a brain abscess, it is known as a autogenic brain abscess. Okay, the infection has spread to the cranial cavity or to the brain, and then inside the brain there is a cavity filled with pus called as the autogenic brain abscess. Do remember, if they would have said after a history of unsafe CSOM, patient comes to you with the complaints of fever along with headache along with nuchal rigidity, then your diagnosis would have been, let me know in the chat box, history of unsafe CSOM followed by fever, headache and nuchal rigidity or neck stiffness, then your diagnosis would have been, let me know in the chat box. So here you are able to see a case of autogenic brain abscess beta where there is a ring enhancing lesion seen on the MRI head basically. Okay? Very good. Meningitis would have been your diagnosis beta if fever, headache and nuchal rigidity would have been mentioned. Clear? Chalo, shabash. So यहाँ पे the diagnosis is autogenic brain abscess, and the most common site that is involved is the temporal lobe of brain. अनसेफ CSOM की वजह से whenever there is an autogenic brain abscess, the most common site where this brain abscess is going to be seen, beta, is the temporal lobe of the brain. It is going to be the temporal lobe of the brain. Hopefully clear to all of you now. That has to be remembered. Now, here there is a case, beta. Do remember, treatment of autogenic brain abscess is usually done by neurosurgery. Okay? We know majority complications of unsafe CSOM are usually treated by MRM or modified radical mastectomy. But subdural empyema and brain abscess, these are the two complications, beta, which needs a neurosurgery, which have to be treated by neurosurgery only. Clear? Chalo. Now here there's a question which states, a patient is a known case of unsafe CSOM and now presents to you with complaints of retroauricular pain, that is behind the pinna, beta, there is pain, or over the mastoid basically there is pain. Along with that, patient is having a mucopurulent ear discharge and mastoid tenderness, that is as you press basically, beta, the patient has a lot of pain over here. Okay? So unsafe CSOM के बाद, if the patient is having retroauricular pain, mastoid tenderness, mucopurulent ear discharge, this is a classical diagnosis of nothing else but, no, it is not Bezold's abscess. Bezold's abscess is pus collection along the sternocleidomastoid muscle. It is not a Bezold's abscess. What is this complication called as? Acute otitis media will happen before CSOM, na? Here to the patient is already having unsafe CSOM. Yes, unsafe CSOM की वजह से the infection has spread to the mastoid air cells, and as the mastoid air cells have got infected, beta, it is a condition known as acute mastoiditis. So the diagnosis in this case is nothing else but acute mastoiditis, beta. The diagnosis in this case is nothing else but acute mastoiditis, has to be remembered. Okay? And due to that mastoid air cell infection or due to that acute mastoiditis, the patient is having symptoms like retroauricular pain, mastoid tenderness, mucopurulent discharge. That has to be remembered. The earliest sign in acute mastoiditis is this. If a patient develops acute mastoiditis, this is the earliest sign that is going to be seen. What is this? You are able to see inflammatory signs over the mastoid surface. And this inflammatory signs over the mastoid surface is classically referred to as the ironing of mastoid, beta. This inflammatory signs over the mastoid surface is classically referred to as the ironing of mastoid. Has to be remembered. Clear? So earliest sign in cases of acute mastoiditis is going to be this classical ironing of mastoid surface. Do remember, it is not a battle sign. Battle sign is bruising over the mastoid surface, not ironing of mastoid surface. समझे बात? Ironing of mastoid surface is a feature of acute mastoiditis. Apart from that, patient will have other signs like reservoir sign. What is reservoir sign? As there is so much of pus, beta, as soon as you clean the pus from the external auditory canal, more pus comes inside the ear, beta. ठीक है, जैसे ही तुम पस साफ करते हो और पस भर जाता है. ठीक है, that is classically known as reservoir sign because it seems as if the patient is having a reservoir of pus. जैसे तालाब हो पस का, इतना पस है बेटा. As soon as you clean, immediately the new pus fills in. That is reservoir sign. And second is the classical lighthouse sign, where the light reflex moves with the pus column, beta. Okay? Treatment. Once you have done an X-ray mastoid and a CT mastoid to confirm the diagnosis, to see the status of ear ossicles, to see the status of the walls of middle ear, and to see the status of mastoid air cells. Once you confirm the diagnosis, then you have to go for treatment. The treatment is nothing else but cortical mastoidectomy, beta. That is the cleaning which is there. It is done from the middle ear as well as the mastoid air cells, beta. That treatment is classically known as cortical mastoidectomy. And for cortical mastoidectomy is also known as the Schwartz operation, beta. Okay, Schwartz sign is the flamingo pink appearance seen in otosclerosis, but Schwartz operation is another name for cortical mastoidectomy required in a case of acute mastoiditis. Now in cortical mastoidectomy or Schwartz operation, the first step is finding the largest and the most constant mastoid air cell, beta. To find the largest and the most constant mastoid air cell, basically, we need a surgical landmark. Let me know in the chat box, what is the surgical landmark for the mastoid antrum? To find the mastoid antrum, what is the surgical landmark we use? That was a PYQ. The surgical landmark. Shabash. So do remember, the surgical landmark beta that we need for the mastodantrum is classically known as the Mac-Evans triangle beta. So the Mac-Evans triangle which is there definitely is a surgical landmark to find the mastodantrum. Okay? It is a suprameatal triangle which is seen. Chalo. Great. Another complication of unsafe CSOM is this. Here you are able to see a case of unsafe CSOM. Okay, and due to that, the patient develops a condition known as sigmoid sinus thrombosis. Sigmoid sinus thrombosis is also known as a lateral sinus thrombophlebitis as well, beta. Do you remember that? Okay. Sigmoid sinus is the main vein of the posterior cranial fossa. As the sigmoid sinus is thrombosed, or as the sigmoid sinus gets blocked, obviously the blood from the posterior cranial fossa cannot drain, and as the blood from the posterior cranial fossa cannot drain, the patient develops a raised ICP or a raised intracranial pressure beta. बराबर, अगर ये sigmoid sinus ब्लॉक हो जाती है तो ड्रेनेज नहीं हो पाता, जिसकी वजह से ICP बढ़ जाता है. ठीक है, so sigmoid sinus thrombosis leads to a raised ICP or a raised intracranial pressure, and due to that raised ICP or a raised intracranial pressure beta, the patient develops symptoms like, first, patient will have a headache beta. Due to the raised ICP, patient will have headache. Second, patient will have a spiky fever, and that spiky fever is known as picket fence fever. Let me know in the chat box, a spiky fever known as Pal-Epstein fever is seen in which condition? A spiky fever known as the Pal-Epstein fever is a feature of which condition? Picket fence fever is going to be seen. Along with that, patient will develop edema over the mastoid beta. Okay, due to sigmoid sinus thrombosis, there will be swelling or there will be edema over the mastoid. And the swelling or edema over mastoid is classically known as which sign? So we know this is classically known as the Grisanger sign. The swelling or the edema over the mastoid in sigmoid sinus thrombosis is classically known as the Grisanger sign. Has to be remembered. ठीक है, तो picket fence fever is a feature of sigmoid sinus thrombosis, but Pal-Epstein fever is a feature of Hodgkin's lymphoma. Do remember that Pal-Epstein fever is seen in Hodgkin's lymphoma. Investigation of choice, we know it is a problem related to the vein or it is problem related to the sigmoid sinus. That's the reason investigation of choice, if they ask you, has to be a CECT head, that is a contrast enhanced CT scan of head. The investigation of choice is a CECT head or a contrast enhanced CT scan of head. And when you will do a CECT head, on that this classical picture is seen. This area which is not taking up the contrast beta, it looks like a triangle, and triangle in Greek alphabets is nothing else but delta. Barabar? So do remember beta, CECT head will classically show you the delta sign, also called as the empty delta sign. तो इसका टारगेट और डबल टारगेट जैसे मत कर देना इन एग्जाम प्लीज. ठीक है, whether they mention delta sign or the empty delta sign, it is same. It is a feature of nothing else but sigmoid sinus thrombosis itself. Understood about? So that is important. Treatment. Do remember beta, treatment is nothing else but, I have told you, except brain abscess and except subdural empyema, all other complications of unsafe CSOM are treated by the same surgery called as MRM or a modified radical mastoidectomy. Along with MRM, you have to clear the thrombus or you have to remove the blockage from the sigmoid sinus as well. Clear? Chalo. So these are the important things. Another complication of unsafe CSOM is classically known as nothing else but the Grady-Negro syndrome beta. Another complication of unsafe CSOM is known as the Grady-Negro syndrome, and this Grady-Negro syndrome is also known as petrositis. We know when the infection spreads posteriorly to the mastoid hair cells, we call it as mastoiditis. Where see, when the infection spreads to the petrous apex hair cells, we should call it as petrositis beta. Very close to the petrous apex, we have the 5th and the 6th cranial nerve beta. Close to the petrous apex, we have the 5th and 6th cranial nerve. Due to that, a classical triad is going to be seen. What is the triad? First, the triad can be remembered by the mnemonic red, bache. The triad can be remembered by the mnemonic red basically. When I talk about R basically stands for retroorbital pain. The patient has a severe retroorbital pain beta, and that happens due to the 5th cranial nerve involvement. Second, E stands for ear discharge. Yes, there will be a mucopurulent ear discharge due to unsafe CSOM beta. And third, D for diplopia. diplopia or double vision that usually happens due to the involvement of sixth cranial nerve or the abducens nerve. So trigeminal and abducens nerve involvement or fifth and sixth cranial nerve involvement will be seen in this condition, leading to retroorbital pain and diplopia respectively beta. समझे बात? That is important. Treatment अगर पूछा जाए, do remember the treatment in a case of Gradinigo syndrome or Petrositis is nothing else but MRM, that is modified radical mastectomy. But this time when I do a modified radical mastectomy, the cleaning will not only be limited to the middle ear and the mastoid cells, the cleaning will also be done in the petrous apex air cells also. Okay, so that is what is the treatment. Understood? Chalo. Let's talk about inner ear now. I hope all of you are quite aware inner ear is nothing else but also known as the labyrinth beta. Barabar? The inner ear which is there basically, it is also known as the labyrinth and it has three parts to it. The inner ear or the labyrinth which is there, it has basically three parts to it beta. One is the cochlea. We know the cochlea or the snail-like structure. It is basically responsible for hearing. The cochlea is basically responsible for hearing. And the sensory end organ of cochlea, I hope all of you are quite aware, is known as organ of Corti beta. The sensory end organ of cochlea is classically known as organ of Corti. Second, as I've told you, we have vestibular organs like utricle and saccule. Second structure which is present beta is known as the vestibular organs like utricle and saccule. And do remember, these utricle and saccule are responsible for the linear balance or the linear acceleration of the body. They are responsible for linear balance or linear acceleration of body, and the sensory end organ of utricle and saccule is macula. The sensory end organ of utricle and saccule is macula beta. That has to be remembered. Next, the third structure which is there, it is your semicircular canal. The third structure is going to be semicircular canal. It is responsible for angular balance or the angular acceleration of the body. It is responsible for the angular acceleration or the angular balance of the body, and the sensory end organ of semicircular canal is known as crista. The sensory end organ of semicircular canal is classically known as crista beta. Hopefully clear to all of you now. So do remember these points. This have been the PYQ. What is the function of utricle and saccule? Answer was linear balance of the body. Clear? Chalo. Now let's talk about basically, we know in the inner ear beta there is a bony covering, and inside that bony covering beta we have the membranous inner ear. Barabar? In the inner ear there is a bony cover, and inside that bony cover basically beta we are going to have your membranous inner ear. We know the fluid that is present inside the membranous inner ear beta. The fluid that is going to be present inside the membranous inner ear is known as your endolymph. Barabar? That fluid is known as your endolymph. Whereas the fluid that is present around the membranous inner ear, the fluid that is present around the membranous inner ear or inside the bony cover is known as perilymph. The fluid that is present surrounding the membranous inner ear or inside the bony cover is known as your perilymph beta. समझे यहाँ तक बात? Now if they ask you that this endolymph which is there, it is going to be secreted by what? So in the membranous inner ear beta, we have a layer of vessel, and that layer of vessel is known as stria vascularis beta. So do remember the endolymph is basically secreted by that vascular layer known as stria vascularis. The endolymph is secreted by a vascular layer known as stria vascularis. And it is absorbed by whom? It is absorbed by a structure known as endolymphatic sac beta. The endolymph is basically absorbed by a structure known as an endolymphatic sac. The endolymph is secreted by the stria vascularis and it is absorbed by the endolymphatic sac. Now let me know the condition beta. In case if I say the endolymphatic sac cannot properly absorb the endolymph, if the endolymphatic sac cannot absorb the endolymph properly, the amount of endolymph will increase, causing a increased endolymphatic pressure. And due to that increased endolymphatic pressure, the cochlea gradually gets damaged beta. And this gradual damage of cochlea will lead to a sensory neural hearing loss. What is this condition known as? So when endolymphatic sac cannot absorb the endolymph properly, leading to rise in the endolymphatic pressure and a gradual damage of cochlea, leading to SNHL or sensory neural hearing loss. This condition is known as. Very good. This condition is classically known as the Meniere's disease beta. right? This condition is classically known as Meniere's disease. समझे बात? Next, here there is a question which states a patient complains of vertigo which suddenly starts beta whenever the patient gets up from the bed or whenever the patient turns his head. So whenever the patient changes position, whenever the patient changes the head position, patient immediately experiences vertigo या उसको चक्कर आता है. What is this diagnosis classically? The patient's hearing is absolutely normal beta over here. If you see the hearing of the patient, it is absolutely normal. The diagnosis of this case is classically known as, very good, yes, it is BPPV. What is BPPV? Benign paroxysmal positional vertigo beta. ठीक है, तो whenever the patient experiences vertigo on turning the head or on changing the head position, it is a classical diagnosis of BPPV or benign paroxysmal positional vertigo. Okay, paroxysmal means which starts all of a sudden and on changing head position it happens. Do remember, in cases of BPPV, the hearing is absolutely normal. Reason why I'm telling you this or I'm stressing on this is, if they say patient is having vertigo along with a sensory neural hearing loss, then the diagnosis will be Meniere's disease beta. But if they say the patient is only having vertigo with a normal hearing, then the diagnosis will be BPPV or benign paroxysmal positional vertigo. समझे बात? That is important. Diagnosis के लिए we know, if I want to diagnose a case of BPPV, we are going to use this two-step diagnostic maneuver. And this two-step diagnostic maneuver में what we do? We suddenly bring back the patient. And as a suddenly bring back the patient beta, we turn the patient's head towards one side. As you turn the patient's head towards the one side, the patient will start experiencing vertigo and there will be a nystagmus which is observed. Okay? As you suddenly turn the patient's head to one side, patient experiences vertigo and there is a nystagmus observed in the eyes. That confirms the diagnosis of BPPV in the patient. Yes, very good. This two-step diagnostic maneuver for confirmation of BPPV is classically called as the Dix-Hallpike maneuver beta. This two-step diagnostic maneuver for the confirmation of BPPV is classically known as your Dix-Hallpike maneuver. That has to be remembered. Okay, it is classically referred to as the Dix-Hallpike maneuver. If they ask you beta, what is done for treatment? So do remember, for treatment, we usually go for this cyclical maneuver beta, which is a 5-step maneuver. And treatment के लिए this cyclical 5-step maneuver that we do is nothing else but called as the Epley's maneuver beta. The treatment maneuver that we do, which is a cyclical maneuver, is known as the Epley's maneuver. Hopefully clear to all of you now. So do remember the points. याद रखना, Dix-Hallpike is only a 2-step maneuver beta and a doctor or an examiner will always be present. Reason? It is done for diagnosis, so a doctor or examiner is always necessary. समझे बात? Whereas Epley's maneuver is a 5-step maneuver beta, which is a cyclical maneuver, and a doctor or an examiner will be absent because they have given images in the previous year exams to identify. So if doctor is absent and a cyclical 5-step maneuver is seen, that is the treatment maneuver called as the Epley's maneuver. समझे बात? That is important. So we know BPPV happens whenever the otoconia or the otolith from utricle and saccule enters into the semicircular canal. And as this otoconia enters into the semicircular canal, the angular balance of the body is disturbed, causing a vertigo in the patient beta. Clear? So whenever you change head position, the otoconia enters into semicircular canal, causes disturbance in angular balance, leading to vertigo. So therefore, to get the otoconia back into the to get the otoconia back into the utricle and saccule, we perform this cyclical maneuver known as the Epley's maneuver beta. समझे बात? चलो. Next important, if I talk about now, is nothing else but this picture over here basically beta, and that is of audiograms. So these are the audiogram pictures basically. First of all, whenever a patient comes to us with a complaints of hearing loss, the first audiometric investigation that we do is known as a PTA, also called as a pure tone audiometry. When I do a pure tone audiometry, we are going to check for two things beta. First of all, you will make the patient hear sound with the help of earphones beta. That means you are checking for air conduction. Second, you will make the patient hear sounds or vibrations with the help of an electrode over the mastoid bone. That means you are checking for bone conduction. एक बार अगर यहाँ से आवाज सुना रहे हो मतलब एयर कंडक्शन चेक कर रहे हो, और बोन पे इलेक्ट्रोड लगा के सुना रहे हो मतलब बोन कंडक्शन चेक कर रहे हो. समझे बात? दैट इज द बेसिक आइडिया. नाउ air conduction is a complete test of hearing. Why do I call it as complete test? Because in air conduction, the sound will travel from external ear, then to the middle ear, and then it will go to the inner ear beta. So air conduction will check for the function of all the three parts of ear beta. So it is a complete test of hearing. But bone conduction mein, the sound or the vibration directly reaches to the inner ear of the cochlea. Bone conduction mein, the sound or vibrations directly reaches the inner ear. So it is a partial test of hearing because it only checks the function of inner ear or the eighth nerve beta. It cannot tell you any problem in the external or middle ear. समझे बात यहाँ तक? So that is what is important. Do remember that air conduction which is there, it is considered as complete test of hearing basically. But bone conduction, if I talk about, it is going to be a partial test of hearing. That is the basic idea. Do remember, air conduction is represented by a continuous line or definitely these kind of symbols beta. But bone conduction is represented by a dotted line or these kind of brackets beta. That is what is the difference. Red lines are always going to represent the audiogram of right ear, and blue lines will always represent the audiogram of left ear beta. Red for right, blue for left. Clear है बात यहाँ तक? चलो. Pure tone audiometry में you will make the patient hear some sound and then you will ask the patient whether he was able to hear the sound or not. तुम पेशेंट को आवाज सुनाओगे और उसके बाद पेशेंट को पूछोगे कि आवाज सुनाई दी या फिर नहीं दी. That means the patient's participation is necessary in this test. So it is a subjective test. Do remember, whether you do a pure tone audiometry or you do a tuning fork test, in both the condition, patient's participation is necessary. So both of these are subjective test beta that has to be remembered. Whereas the other two, that is otoacoustic emission or BERA, we'll talk about them. In those tests, the patient's participation is not necessary. So those are objective tests. समझे बात? यहाँ पे patient's participation is necessary, so it is a subjective test. You will make the patient hear sounds between 250 Hz till 8000 Hz. Yes, you will make the patient hear sounds from minimum 250 Hz to maximum 8000 Hz beta. Understood? Now, first picture you can see, this is an audiogram beta after a pure tone audiometry which has been obtained. Blue lines are seen, that means it is an audiogram of left ear. That is what is important. Clear? Now, if I talk about basically, in this audiogram you can see the dotted line or the brackets, they are basically bone conduction, and the continuous line or the cross, it is air conduction. This is the landmark, that is 25 decibel. Here you can see both the bone conduction as well as air conduction. It is less than 25 decibel. And we know whenever a line is less than 25 decibel beta, that means it is absolutely normal. Barabar? So here the bone conduction as well as air conduction, if both of them are less than 25 decibel beta, that literally means patient has a absolutely normal hearing. If both the lines are less than 25 decibel, that literally means patient has a normal hearing. So this is a picture of a normal audiogram beta. This is a picture of a normal left ear audiogram. समझे यहाँ तक? अब second picture that you are able to see, you can see this is an audiogram with red lines. That means it is an audiogram of right ear beta. Now this is the landmark of 25 decibel, let's say. ठीक है? Let's see the lines. First of all, this is the brackets bone conduction. This is the triangle air conduction. Do remember, bone conduction is always the upper line. If you get confused, remember ऊपर वाली line हमेशा bone conduction होगी. ठीक है? Here you can see bone conduction is less than 25 decibel, and we know any line which is less than 25 decibel is normal. So in this picture you can see the bone conduction of the patient is absolutely normal. Clear? Second, air conduction is beyond 25 decibel or air conduction is more than 25 decibel. Whenever air conduction is more than 25 decibel, it is poor beta. That means air conduction is poor basically. बराबर है बात? And if you see the gap, do remember between the bone conduction and air conduction, the gap should not be too much. It should be less than 15 decibels. 15 decibels से कम gap चाहिए होता है. Here if you see the gap between both the lines, it is more than 15 decibels beta. And if there is a gap of more than 15 decibel, we call it as a AB gap बच्चे. If that gap is more than 15 decibel, that is a AB gap which is present over here. If bone conduction is normal, air conduction is poor, and an AB gap of more than 15 decibels is present, that is a classical audiogram of CHL or a conductive hearing loss. And all of us are quite aware, CHL or conductive hearing loss means there is some problem in the external ear or middle ear. Conditions like beta, patient may be having ear wax, patient is having otitis externa, patient is having otitis media, patient is having otosclerosis, or patient is having blue ear. These kind of conditions which cause a conductive hearing loss, they will have this kind of audiogram where bone conduction if you check, so it will be absolutely normal. Reason, इनर ईयर चेक करता है ना बोन कंडक्शन, तो यहाँ पे तो कोई इनर ईयर में दिक्कत ही नहीं है, राइट. सो बोन कंडक्शन इफ यू चेक इट विल बी एब्सोल्युटली नॉर्मल. एयर कंडक्शन इफ यू चेक, proper conduction cannot happen, therefore the patient will have poor air conduction and there will be a significant AB gap. समझे बात यहाँ तक? Do remember this points. Next, this is the picture on the next one. I'll come back to the other audiogram. This is the picture. Again, it is a blue lines that you are able to see on the audiogram. Matlab it is an audiogram of left ear. If you see this audiogram, this is the landmark of 25 decibel beta. This brackets represent the bone conduction, the crosses represent air conduction. If you see beta, both the lines which are there, they are beyond 25 decibel or they are more than 25 decibel. We know whenever a line is more than 25 decibel or beyond 25 decibel, that is what is suggestive of nothing else but a poor conduction beta. So bone conduction as it is more than 25 decibel, it is poor. Air conduction, if it is more than 25 decibel, it is poor beta. Both of them are poor. Bone conduction is also poor and air conduction is also poor. And this is a classical feature of which condition, anybody? This is a classical audiogram of SNHL, that is a sensory neural hearing loss. And sensory neural hearing loss means the patient is having damage to the inner ear or the 8th cranial nerve beta. The patient is having any damage to the inner ear or the 8th cranial nerve. Conditions like Meniere's disease or acoustic neuroma. These are the conditions basically beta. Now, when you check for air conduction, obviously the sound is properly traveling via external ear. The sound is properly traveling via middle ear. But as inner ear is damaged, the sound cannot process only na. So air conduction will not be heard, it will be poor. Same with bone conduction. Bone conduction says the sound will normally reach up to the inner ear. But as inner ear has been damaged, the sound is not processed. So therefore bone conduction is also poor. Samjhe baat? When both bone conduction as well as air conduction will be poor, it is a classical audiogram of a SNHL or a sensory neural hearing loss. Hopefully clear abhi yahan par koi dikkat? Hopefully I have made myself very clear on this. ठीक है, ये चीजें देखनी होती है बच्चे तुम्हें, बस एक बार देखना सीख जाओ, easy it is. Now coming back to this audiogram over here, you can see both the lines are seen, blue as well as red, matlab it is a left as well as right ear audiogram. On that you can see beta, normally hearing is seen normal, but at a point you can see there is a dip in both bone conduction as well as air conduction, and it is seen at 4000 Hz. What is this dip classically known as, or what is this notch classically called as? Let me know in the chat box. So if I say beta, there is dip in both bone conduction and air conduction. There is dip in both bone conduction and air conduction at 4000 Hz beta. That is classically known as which dip or which notch, anybody? So dip in bone conduction as well as air conduction at 4000 Hz is classically known as a acoustic dip, also known as the boiler's notch beta. Yes, it is classically known as acoustic dip, also known as the boiler's notch. Do remember, only a dip in bone conduction at 2000 Hz is known as Carhart's notch, seen in otosclerosis. But a dip in both bone conduction as well as air conduction beta at 4000 Hz is a feature of acoustic dip or a boiler's notch. An acoustic dip and boiler's notch is usually seen, very good, in the early stages of noise-induced hearing loss. So it is an occupational disorder which can be seen in factory workers who are exposed to loud noise or loud sound on a daily basis. So in noise-induced hearing loss, you can see an acoustic dip or a boiler's notch on the audiogram. That is what is important to be remembered beta. That has to be kept in mind. Hopefully clear to all of you now. And treatment for noise-induced hearing loss is usually a hearing aid beta. Obviously, you will ask the patient to stop exposure to loud sound, and second, you can give a hearing aid in the patient. Stop exposure to loud sound and prescribe a hearing aid in the patient. That has to be kept in mind. Clear? Another audiogram. Identify this audiogram over here that you are able to see. You can see again red lines and blue lines both are seen. So it is an audiogram of the right as well as the left ear both. And you can see the patient is having normal hearing beta at lower frequencies. So when you checked for lower frequencies, the hearing was absolutely normal. But as soon as you started checking for higher frequencies, the patient was not able to hear the high frequency sounds beta. So patient is basically having hearing loss at higher frequencies. And as there is hearing loss at higher frequencies, you get a very classical sloping audiogram beta. Shabash. As there is hearing loss only at higher frequencies beta, you classically get a sloping audiogram. And very good. All of you are right. Sloping audiogram which is there, it is a classical feature of presbyacusis. And what do I literally mean by presbyacusis? Presbyacusis is nothing else but a age induced hearing loss beta. Okay? Sloping audiogram which is there, it is a classical feature of presbyacusis beta, and that presbyacusis which is there, it is classically known as nothing else but a age induced hearing loss. Hopefully clear. It is classically known as the age induced hearing loss. That has to be kept in mind. Samjhe baat? So these are the points that you need to remember. So sloping audiogram is a classical feature of presbyacusis or age induced hearing loss. Treatment in presbyacusis or age induced hearing loss is again a hearing aid beta. Obviously at this point of time or at this age, you will not prefer a surgery. You will usually prescribe only a hearing aid in this patient. Now, another question that I can integrate is, please tell me beta, in age-induced hearing loss, early stages mein, patient is having only a high-frequency hearing loss. If there is a high-frequency hearing loss, which part of the cochlea is damaged beta? Whether it is the apex of the cochlea or it is the basal tone of cochlea. If the patient is having high-frequency hearing loss, which part of the cochlea is damaged? It is the apex of the cochlea or it is the basal tone of cochlea? This was a PYQ. Very good. If the patient is having a high frequency hearing loss beta, that literally means the patient is having damage at the level of basal tone of cochlea. Because if basal tone of cochlea is damaged, the high frequency sounds are not processed, causing a high frequency hearing loss. Whereas if apex of the cochlea is damaged, the patient will have a low frequency hearing loss. Because if apex of the cochlea is damaged, the patient does not process the low frequency sounds, leading to a low frequency hearing loss beta. Samjhe baat? Do remember apex damage, apex damage, low frequency hearing loss. Basal tone damaged, high frequency hearing loss. These are the points that you need to remember. Samjhe yahan tak baat? Chalo. So these are the points. Okay? Another question basically from this case. They asked you in a PYQ beta that routine screening of hearing in neonates is done by which investigation beta? Let me know. Routine screening of hearing means what? We know whenever each and every child is going to be born beta, you have to check whether the child is having a normal hearing or the child is having deafness since birth beta. तो हर बच्चा जब पैदा होता है तो उसकी hearing check करते हो ना कि normal है या deaf है बच्चा. तो उसके लिए बेटा what is the routine investigation that we use? Very good. The routine screening of hearing in neonates is usually done by an investigation called as OAE. And what is OAE? That autoacoustic emission beta. So autoacoustic emissions which is there, it is the investigation basically, okay, which we are going to use beta for the routine screening of hearing. So this is the autoacoustic emission. क्या करते हैं इसमें? We give sounds to the ear of the patient. And after giving sounds to the ear of the patient, we record the echoes coming from outer hair cells of cochlea beta. Yes, the autoacoustic emission mein we record basically the echoes coming from the outer hair cells of cochlea basically beta. That is what is done. So here, is the patient's participation needed? No, we know autoacoustic emission mein patient's participation is not needed. As patient's participation is not needed, it is an objective test beta. Okay, unlike audiometry, Otoacoustic emission is an objective test, so can be done in neonates commonly. Okay, so that is what is important. This was the recent question. Do remember this. समझे यहाँ तक? Now if I talk about basically the another investigation called as BERA. Now what is BERA? BERA is brainstem evoked response audiometry beta. BERA is a brainstem evoked response audiometry. What we do in this procedure is, in BERA you give sounds to the ear of the patient, but after giving the sounds to the ear of patient, you don't record echoes. You record electrical activity from the auditory pathway, or you record the electrical activity in the brainstem area. Matlab, if a person is having normal hearing, after giving the sound, electrical activity is seen in the auditory pathway or electrical impulses are seen in the brainstem area. So if you can record the electrical activity, matlab the patient's hearing is normal. Barabar? So here also patient's participation is not needed beta. This is also an objective test. Clear? So do remember, if they ask you BERA, BERA is also an objective test. No patient's participation is needed in this test. That is important. And when we record the electrical activity from the auditory pathway, okay, when I record the electrical activity from the auditory pathway, do remember there are going to be 7 waves seen on that graph beta. And out of these 7 waves on the graph of BERA, the largest or the most important wave is which wave? So the largest and the most important wave in BERA is the wave number 5 beta. Please tell me in the chat box, this was a PYQ. The largest and the most important wave, known as wave number 5, is generated from which part of the auditory pathway? The most important wave of BERA, we know beta, it is basically the 5th wave. Let me know in the chat box, the 5th wave is going to be generated from which part of the auditory pathway? We know there is a mnemonic to remember the auditory pathway known as E. coli ma beta. E. coli ma matlab E for the 8th cranial nerve or the vestibulocochlear nerve. C for cochlear nucleus. O for olivary complex, that is superior olivary complex. L for lateral lemniscus. I for inferior colliculus. M for medial geniculate body, and A for auditory cortex. Clear? Do remember, yes, the 5th wave, the most important wave, is actually generated from the lateral lemniscus beta. Okay? The most important wave of BERA is usually generated from the lateral lemniscus of the auditory pathway. Samjhe yahan tak? Hopefully clear to all of you now. So do remember this. Now, please tell me, BERA, can it also be used for screening in neonates? Yes, BERA can be used for screening of hearing in neonates beta. But which kind of neonates? Let me know. Because commonly for screening of hearing in neonates, we use the otoacoustic emission. Reason? It is more portable, it is more cheaper. That's the reason we prefer using otoacoustic emissions commonly. Okay? But yes, if there are high risk neonates beta, okay? So high risk neonate agar honge, in high risk neonates, then we prefer using BERA beta. Screening of hearing in high risk neonates, we prefer BERA basically. High risk neonates matlab those neonates who are admitted in the NICU, those neonates who are suffering from meningitis. In these kind of neonates beta, we definitely prefer using BERA over otoacoustic emission. Hopefully clear to all of you now. So these are the points to be remembered. Done with this? Chal. So do remember that routine screening of hearing is done by otoacoustic emission, but screening in high risk neonates is basically done by BERA. Chal. Next is tympanometry beta. We know that tympanometry is also known as impedance audiometry beta. And what is done in tympanometry? We check the freedom of movement, matlab how freely the tympanic membrane or the ear ossicles can move beta. That is what you tend to check with the help of tympanometry or an impedance audiometry which is clear. So on the impedance audiometry, these are the various types of curve that you can see. First of all, if I highlight the green one that you are able to see over here, it is a normal curve beta called as the type A curve. So type A curve is an absolutely normal curve. Why? You can see there is not more movement or less movement. There is an adequate movement of the ear ossicle. If adequate movement of ear ossicle is seen, that is known as the type A curve, also known as the normal curve beta. Clear? Next important if I talk about is this one. The small one that you are able to see is the type AS curve beta that I am highlighting in red. You can see beta, here the movement of ear ossicle is less. As the movement of ear ossicle will be less, therefore a shorter curve is formed. And this shorter curve is classically known as the type AS curve. S literally stands for sclerosis or fibrosis beta. We know due to otosclerosis, there is fixation of stapes. And as the stapes will be fixed, the movement will be less beta, leading to a type AS curve, which is a shorter curve. So AS curve is usually seen in patients of otosclerosis. That has to be remembered. Understood? So that is important. Next important is this, the blue one that I'm highlighting right now. If you see the blue one, there is excessive movement beta, right? The blue one is a taller curve. And why this curve is much taller? Reason, there is more movement of ear ossicle. And when there will be more movement of ear ossicle, that is going to form a taller curve known as the type AD curve. D literally stands for dislocation, bache. So when the ear ossicles will get dislocated from each other, we know they can move very freely beta. As the ear ossicles are dislocated from each other, they move very freely, and that is going to form a taller curve called as the type AD curve. So type AD curve which is there, it is usually seen due to ossicular dislocation. That type AD curve is basically seen due to the ossicular dislocation. That has to be remembered. Okay? Chalo. Next important, if you see beta, is the pink curve. Definitely this pink curve that I'm highlighting right now is classically known as nothing else but the type B curve. The pink curve that you can see over here is nothing else but a type B curve. If you see the type B curve, it is a flat curve beta, and we have already discussed one condition where this type B or a flat curve is seen, called as the glue ear, also known as serous otitis media beta. Okay, because of fluid, the ear ossicles are not able to move properly, and therefore a flat curve or a type B curve is seen. Second condition where a type B or a flat curve is seen is a tympanic membrane perforation. So even in tympanic membrane perforation beta, you can see a flat curve or a type B curve. The commonest one that has been asked in the FMG exam. Okay? So type B or flat curve is seen in glue ear and tympanic membrane perforation beta. Next important, if I talk about now, is going to be the last one, that is nothing else but the type C curve beta that I'm highlighting in black itself. Do remember, this black curve that you're able to see is the type C curve. If you see the type C curve beta, you can see it is towards the negative side of the graph. So the type C curve is towards the negative side of the graph. Why? Reason, the tympanic membrane gets pulled inside, or the tympanic membrane gets retracted inside in this. Why? Reason is, whenever we know there will be a negative pressure, or whenever there will be a vacuum inside the middle ear, that will cause retraction of the tympanic membrane, or the tympanic membrane gets pulled inside. When there is negative pressure or vacuum in the middle ear, due to the Eustachian tube blockage. Barabar, Eustachian tube is known to ventilate the middle ear. But if there is a Eustachian tube dysfunction, or there is a Eustachian tube blockage beta, obviously the middle ear will have negative pressure or vacuum generated inside it, causing a retraction or a negative graph beta, classically known as type C curve. So type C curve happens due to Eustachian tube blockage or Eustachian tube dysfunction. Clear hai yahan tak? Chalo. Now answer this question to me basically in the chat box beta. Here the question states, you performed a bithermal caloric test. What is a bithermal caloric test? I am going to irrigate the external auditory canal with water at two temperatures beta. Once I will use the cold water, which is going to be at 30 degrees Celsius beta. Once I am going to use the cold water, which is going to be at the temperature of 30 degrees Celsius. And second time I will use a warm water, and that warm water will be at a temperature of 44 degrees Celsius. So as you are irrigating the external auditory canal with water at two temperatures, we call it as the bithermal caloric test. And this test is basically done beta to check the function of the lateral semicircular canal, or to check the vestibulo-ocular reflex. Okay? That means whenever the lateral semicircular canal is stimulated, patient will have a nystagmus in the eyes. That is the vestibulo-ocular reflex. Clear? So you performed a bithermal caloric test on a person when you irrigated his left ear beta with warm water. You noticed rapid movements of eye. Which among the following corresponds to the correct interpretation of the nystagmus observed in this test or in this patient? So हमें पता है one thing, that whenever I am going to use cold water beta, do remember the nystagmus is going to be towards the same side or opposite side. Let me know in the chat box. If I say I'm going to use cold water for irrigation, the nystagmus will be towards the same side or the opposite side. Let me know in the chat box. It will be towards the opposite side beta. That means if I'm irrigating the patient's right ear with cold water, the nystagmus will be towards the opposite side, that is the left side beta. समझे बात? So that is important. So whenever I'm going to irrigate the ear with cold water, the nystagmus is towards the opposite side. Now in a nystagmus you might have seen there is a fast component and a slow component beta. Wherever there's a fast and a slow component. Do remember the fast component is the one which decides the direction of nystagmus. The fast component is the one which decides the direction of nystagmus beta. ठीक है? So when I say I irrigate the patient's right ear with cold water, the nystagmus will be towards the opposite side. That means towards the left side. That means the fast component will be towards the left side beta. That has to be remembered. समझे बात यहाँ तक? Next, if I'm going to use warm water beta, let's say if I'm using warm water basically, then the nystagmus is towards the same side. That means if I'm irrigating the patient's right ear with warm water, the nystagmus will also be towards the same side, that is the right side itself beta. And do remember, nystagmus towards the same side means the fast component is towards the same side. As I'm irrigating the right ear with the warm water, the nystagmus is towards the same side, that is the right side. Matlab the fast component is towards the right side beta. Understood? So you might have heard about a mnemonic that is nothing else but cows. All of us are quite aware about this. That is, whenever I use cold water, the nystagmus is going to be towards the opposite side, has to be remembered. And whenever we use warm water, the nystagmus is going to be towards the same side. And when I say opposite side or same side, it is about the fast component of the nystagmus beta. Hopefully clear to all of you. Chalo. Now applying the same logic, we will solve the question. The question says, definitely you are irrigating the patient's left ear with warm water. Now we know whenever I am irrigating the ear with warm water beta, warm water causes a same-sided nystagmus. Matlab, as I am irrigating the patient's left ear with warm water, that means the nystagmus will be towards the left side itself. Barabar? The nystagmus will be towards the same side itself or the left side itself. And nystagmus towards the same side means fast component will be towards the same side. So as you're irrigating the left ear with warm water, there is a left-sided nystagmus. And if I talk about a left-sided nystagmus, that means the fast component is towards the left side. Answer has to be option A for this question. Fast component towards the left side. Let me know in the chat box now. If I would have said, I am irrigating the patient's left ear with cold water, then which option would have been correct? If I would have said that I am irrigating the patient's left ear with cold water, then which option would have been correct? Beta, let me know in the chat box. Very good. Yes, then the option C would have been correct. We know with cold water, the patient would have opposite sided nystagmus. So as I'm irrigating the patient's left ear with cold water, there will be a right sided nystagmus, and right sided nystagmus means fast component towards the right side. Now some people will say, sir, whether you say fast component towards left side or slow component towards right side will be same. No, it is not same beta. Do remember basically, it is not the slow component which decides the direction. It is the fast component which decides the direction. So option A will be the true statement in this condition. Samjhe baat yahan tak? So that is important. Remember the mnemonic cows. That is nothing else but cold water opposite sided nystagmus and warm water same sided nystagmus. Samjhe? Chalo. And answer the next question over here. The question states, a patient presented to the emergency beta with a sudden onset right sided facial weakness along with tingling sensation in the face and drooping of mouth on the right side beta. Okay, there is drooping of mouth like this. There is drooping of mouth on the right side along with headache. The patient was advised oral steroids basically like dexamethasone along with acyclovir beta. But after a span of 3 weeks or after a duration of 3 weeks, patient returns to us with no improvement at all in his symptoms. What shall be the next best step in the management of this patient? Now, please tell me what is your provisional diagnosis. Looking at this case, what is the diagnosis that should come to your mind, beta? What is the provisional diagnosis in this condition? Very good. We know, beta, it is a classical case of nothing else but Bell's palsy. And what is Bell's palsy, Vijay? Bell's palsy is nothing else but a idiopathic lower motor neuron facial palsy, beta. Okay, idiopathic lower motor neuron facial palsy is known as Bell's palsy. Though some cases of Bell's palsy can be due to the HSV or the herpes simplex viral infection, but majority cases till date are idiopathic only. So it is a lower motor neuron facial palsy, that is, facial nerve is damaged but outside the brain. If the facial nerve is damaged at the level of brain, we call it as upper motor neuron. Clear? So it is a lower motor neuron facial palsy, that is known as your Bell's palsy, beta. Now, whenever there is a Bell's palsy, the patient will have features like, first of all, there is drooping of angle of mouth on the affected side. Yes, drooping of mouth on the affected side is going to be seen, whereas deviation of angle of mouth is seen on the normal side. So drooping of mouth is on the affected side and deviation of angle of mouth is seen on the normal side, beta. Samjhe? Second, there is loss of nasolabial fold. No nasolabial fold will be seen. Third, you can see there is going to be loss of wrinkling. Please tell me, loss of wrinkling is only a feature of lower motor neuron facial palsy or upper motor neuron facial palsy? Let me know in the chat box. This is known as loss of wrinkling on forehead. And loss of wrinkling on forehead is a feature of only a lower motor neuron or upper motor neuron facial palsy. So do remember, if loss of wrinkling is there, that is only and only a feature of nothing else but, beta, a lower motor neuron facial palsy. It is never seen in upper motor neuron facial palsy. Upper motor neuron palsy mein the tone of the muscles is increased or there is a spastic paralysis. So wrinkles are present. Wrinkles agar hai, matlab it is a upper motor neuron palsy. Wrinkles absent hai, so it is a lower motor neuron palsy, beta. Hopefully cleared all of you now. Chalo. So these are the features which will be seen: drooping of mouth on affected side, deviation of mouth on normal side, drooling of saliva at times, loss of wrinkling, and a very common feature. On the affected side, patient cannot completely close the eye. And when the patient cannot completely close the eye, it is known as lag of thalamus, beta. Okay, incomplete closure of the eye is lag of thalamus. It happens due to the palsy of orbicularis oculi muscle. And due to this lag of thalamus, patient may be at a risk of exposure keratitis. Any kachra or debris can go in the patient's eyes, causing damage to the cornea, leading to exposure keratitis. Understood? Now we know that the main reason for Bell's palsy or a facial palsy is inflammation or edema around the facial nerve. And this edema around facial nerve compresses the facial nerve, beta. And therefore, the drug of choice for facial palsy is always oral steroids. The drug of choice for facial palsy or the drug of choice for Bell's palsy is oral steroids, beta. We know some cases are due to HSV infection, so you may give acyclovir. But acyclovir is only effective if given within 3 days. Otherwise, acyclovir is not effective. Samjhe baat yahan tak? That is what is important to remember. Now, here the patient was given a acyclovir therapy patient was given an oral steroid therapy for a span of 3 weeks. But even after 3 weeks, the patient comes to us with no improvement, beta. So what should be the next best step if they ask you? So we all know the next best step has to be very good. Option C, electrophysiological nerve testing. By electrophysiological nerve testing or nerve conduction studies, you will see, beta, whether the facial nerve is normal or the facial nerve has been damaged. If the facial nerve is damaged, then after that, you can go for a surgical decompression of the nerve. Once you find, okay, the facial nerve fibers have been damaged, then you may go for next step as the surgical decompression. I've seen a lot of people marking surgical decompression as the answer directly. No. If patient has no improvement after 3 weeks, first do a electrophysiological nerve testing, and if the fibers are damaged, then only go for surgical decompression of nerve. Samjhe baat yahan tak? That is what is important. MRI head will be done, but not the immediate next step. ठीक है? Surgical decompression only after electrophysiological nerve testing has confirmed the fibers are damaged, and continuous steroid therapy is not going to be useful. Clear? Chalo, the last two slides. Now first is, here there is a question which states a patient presents to you with complaints of unilateral, gradually progressive sensory neural hearing loss. Along with that, the patient also has imbalance and vertigo beta. Gadolinium enhanced MRI is given below. Gadolinium is the contrast. So the gadolinium enhanced MRI is given below. What is the likely diagnosis? So do remember beta, patient coming to you with a unilateral, gradually progressive sensory neural hearing loss along with problems like imbalance and vertigo also. Okay? And this is the gadolinium enhanced MRI which shows you a very classical appearance. What is this appearance called as beta? So you can see in the brain or at the cerebellopontine angle beta. This is the cerebellum and this is the pons. So at the cerebellopontine angle, you are able to see a tumor which is giving you a very classical appearance called as ice cream cone appearance beta. Barabar? I am able to see a tumor basically giving me a very classical ice cream cone like appearance. And we know a tumor at the cerebellopontine angle giving me a classical ice cream cone appearance which is there beta is going to be considered as nothing else but acoustic neuroma beta. बराबर, it is classically known as nothing else but acoustic neuroma. अपने को पता है acoustic neuroma is a benign tumor arising from the 8th cranial nerve beta. Acoustic neuroma is basically a benign tumor arising from the 8th cranial nerve. That has to be remembered. ठीक है? And majority cases में acoustic neuroma is unilateral. Most of the cases acoustic neuroma is unilateral except in one condition, which is the only condition where acoustic neuroma or vestibular schwannoma is bilateral beta. The only condition where acoustic neuroma or vestibular schwannoma is bilateral, let me know in the chat box. We know in acoustic neuroma, as the 8th nerve is damaged, patient has a sensory neural hearing loss. As it is a slow growing benign tumor, the sensory neural hearing loss is gradually progressive, which develops over a span of years together. As the 8th nerve is damaged, there is not only hearing loss, but patient will also have other symptoms like imbalance or vertigo, because 8th nerve is not only responsible for hearing but even for the balance of the body. Clear about that is important. Very good. Shabash. The only condition bache where the acoustic neuroma is a bilateral condition is neurofibromatosis type 2. So neurofibromatosis type 2 mein the patient is going to have a bilateral acoustic neuroma or a bilateral vestibular schwannoma. That is what is important to be remembered. Other all cases mein it is always unilateral. Hopefully clear to all of you now. Chalo. Now in acoustic neuroma, patient has a classical finding known as rollover phenomena. What is rollover phenomena? On increasing intensity of speech, the understanding falls further. मतलब अगर तुम और जोर से बोलोगे पेशेंट के साथ, उसको जितना समझ में आ रहा था वो भी नहीं आएगा. ठीक है? The intensity of speech, if you increase, the understanding of speech decreases. Next is Hitzelberger sign. Hitzelberger sign means in the external auditory canal, in the posterior-superior area, there is loss of sensation. Why? Because this tumor involves the sensory division of facial nerve or it involves the nerve of Würzburg. And as this nerve of Würzburg will be damaged, the patient will have loss of sensation in the posterior-superior part of external auditory canal known as the Hitzelberger sign beta. Clear? That is important. Investigation of choice, so we all know it is the gadolinium enhanced MRI, which confirms the diagnosis by this ice cream cone appearance. And treatment, we know treatment for a case of acoustic neuroma or a vestibular schwannoma is a surgical excision. Once I do a surgical excision of an acoustic neuroma or a vestibular schwannoma, I am able to see a very classical picture beta. If I do a biopsy after the surgical excision or the surgical removal, I am able to see a very classical histopath. What is this histopath called as? I am able to see some hypercellular areas, some hypocellular areas, and some areas beta where there is almost no cells at all. Okay? These hypercellular and the hypocellular areas are basically known as the antennae A and the antennae B areas beta. The hyper and the hypocellular areas are known as the antennae A and antennae B areas, but these areas without anything, they are classically known as which bodies? Verrucate bodies. Shabash. These areas without any proliferation are classically referred to as the Verrucate bodies beta, has to be remembered. So after surgical removal of the acoustic neuroma, the histopath shows you a very classical finding known as Verrucate bodies beta, has to be remembered. समझे बात अभी? चलो. Now if I talk about basically this next question which states a young male complains of episodes of tinnitus along with vertigo and hearing loss. Classical triad of symptoms. One is tinnitus, second is tinnitus is ringing sensation in the ear. Second is vertigo along with nausea and vomiting at times, and third is hearing loss. And these classical triad is seen in episodes. Matlab, like we have episodes of migraine, we are having episodes of these symptoms beta. And each episode is usually lasting for a span of around 24 hours. So one day episodes are going to be seen. The pure tone audiometry has been given below. What is the likely diagnosis? Very good, all of you. Pure tone audiometry shows what? Here you can see this is the 25 decibels ka landmark. You can see at lower frequencies when we check, the patient is having poor hearing or hearing loss. But at higher frequencies when you check, patient has a normal hearing beta. Matlab in this condition, patient is low frequency hearing loss. Means which part of the cochlea is damaged? Apex or basal turn? Let me know in the chat box. As I say, patient is having a low frequency hearing loss. Which part of the cochlea is damaged? Apex or basal turn? Let me know in the chat box. And due to the low frequency hearing loss beta in the early stages, you are able to get a very classical rising audiogram, bache, right? We are able to get a very classical rising audiogram. We know sloping audiogram due to high frequency hearing loss was a feature of presbyacusis or age induced hearing loss. But rising audiogram on PTA due to low frequency hearing loss is a classical feature of Meniere's disease beta. Yes, all of you are right. Very good. Low frequency hearing loss is due to damage to the apex of the cochlea. So diagnosis in this case is known as Meniere's disease, which is also known as endolymphatic hydrops or the glaucoma of ear. As the endolymph is not properly absorbed, that is the reason why patient develops increased endolymphatic pressure, and due to that increased endolymphatic pressure, there is gradual damage to cochlea causing these symptoms beta. That is known as Meniere's disease, also known as glaucoma of ear. We know Meniere's disease mein the patient has various symptoms like Tumarkin's crisis. What is Tumarkin's crisis? During an episode, there is such a severe vertigo that the patient falls down without turning unconscious. Patient is not unconscious, but due to that severe vertigo, he has fallen down. ठीक है, इतना चक्कर आता है बेटा कि पेशेंट चक्कर के मारे नीचे गिर जाता है, बेहोश नहीं हुआ है. ठीक है, that is Tumarkin's crisis. Next is recruitment phenomena. Recruitment phenomena is nothing else but loud sound appears more loud beta. ठीक है, the loud sound is going to appear more loud to the patient in Meniere's. That is known as recruitment phenomena. Third is Tullio's phenomena. Tullio's phenomena is nothing else but the patient experiences vertigo on hearing loud sound. So whenever the patient will hear loud sound, that causes vertigo. तो ज्यादा जोर की आवाज सुनने पे पेशेंट को चक्कर आने लगता है. That is what is Tullio's phenomena. And last is diplacusis. What is diplacusis? The patient will hear the same sound in two different frequencies beta. A same sound can be heard in two different frequencies. That is known as diplacusis. That has to be remembered. Understood? So these are the points that you need to remember. Investigation of choice. See, pure tone audiometry will be my first line investigation which shows me rising audiogram. But what is the investigation of choice in Meniere's? Let me know in the chat box. The investigation of choice to confirm the diagnosis of Meniere's will be. Let me know in the chat box beta. Investigation of choice. Very good. The investigation of choice for Meniere's disease is known as the investigation called as ECG or electrocochleography beta. Along with electrocochleography, you can do a glycerol test also, but the single best investigation will be an electrocochleography. So if the cochlea has been damaged, obviously the electrical impulses are not generated in cochlea beta. So to check that, the investigation of choice in cases of Meniere's disease is electrocochleography. Okay? Now, treatment. We know whenever the patient of Meniere's disease comes to us, the main complaint of the patient is vertigo during the episode. The most disturbing symptom is vertigo. So during the episode, give anti-vertigo drugs beta. Anti-vertigo drugs like cinnarizine, prochlorperazine, promethazine, Vertane Stemitil like drugs. Next, in between the episode, give acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor, and that is given in between the episode to decrease the endolymphatic pressure. So acetazolamide decreases the endolymphatic pressure beta and stops the damage of cochlea. Glycerol test is an adjuvant test, not the investigation of choice. It is done alongside. Single best investigation I will mark as ECG. समझे बात? Now, the definitive treatment, if they ask you, definitive treatment depends, beta, whether the patient's inner ear is sorry, partially or completely damaged. If residual hearing is present, okay, if residual hearing is present, that means the inner ear is not completely damaged. And if inner ear is not completely damaged, I will try to save the inner ear, beta. And to save the inner ear, we go for a surgery known as a endolymphatic sac decompression surgery. We go for a surgery called as the endolymphatic sac decompression surgery, where we decompress the endolymphatic sac so proper absorption of the endolymph is going to happen. So endolymphatic sac decompression surgery is going to be done. Anybody, what is the surgical landmark for the endolymphatic sac? Let me know in the chat box. What is the surgical landmarks for endolymphatic sac? Let me know in the chat box. So if residual hearing is present, means the cochlea is not completely damaged. Try to save the cochlea by doing an endolymphatic sac decompression surgery, and the surgical landmark for this endolymphatic sac is known as your Donaldson line, beta. Very good. The surgical landmark for endolymphatic sac is your Donaldson line. Samjhe baat? Whereas if the residual hearing is absent, beta, in those conditions, we will completely kill the inner ear. Any which ways the hearing is absent, that means the inner ear is damaged. So better is to completely kill that inner ear, beta. And completely killing the inner ear is known as chemical ablation of inner ear. Do remember this chemical ablation of inner ear which is there. It is done by an ototoxic drug like gentamicin. The chemical ablation of inner ear is done by an ototoxic drug known as gentamicin, beta. So chemical ablation of inner ear with gentamicin has to be done. That is important to be remembered. Hopefully clear. And lastly, if I talk about basically, beta, about the refractory case. Refractory case means what? If the patient is not responding to any treatment, whatever treatment are possible, you have always tried, or you have tried all the treatment. So if it is a case of refractory Meniere's disease, it's better to remove the inner ear, and removal of inner ear is known as labyrinthectomy, beta. Refractory cases of inner ear will be treated by nothing else but labyrinthectomy. Clear? Sure. The last disease basically that we have is this one. A female presents to you, beta, with complaints of pulsatile tinnitus. Okay, pulsatile tinnitus is ringing sensation in ear. But if the patient definitely hears that pulsations in the ear, beta, that is called as pulsatile tinnitus. Along with that, patient is having CHL or conductive hearing loss, and a red bleeding mass is observed. What is the likely diagnosis? I hope all of you are quite aware. If a female comes to you with pulsatile tinnitus, conductive hearing loss, and red bleeding mass, yes, the diagnosis is classically a case of glomus jugulare, which is also referred to as glomus tympanicum, beta. Right? It is a classical case known as glomus jugulare or glomus tympanicum. What is the basic difference? The basic difference is, beta, if the tumor starts from the jugular bulb, we call it as glomus jugulare. But if the tumor starts in the middle ear, that is from the promontory, we call it as tympanicum, beta. समझे बात? अगर जुगुलर बल्ब से अराइज होता है, that is glomus jugulare. अगर मिडल ईयर में promontory से स्टार्ट होता है, तो glomus tympanicum we call it as. समझे? तो glomus jugulare or glomus tympanicum is a highly vascular tumor, beta, that you have to remember. ठीक है? As it is a vascular tumor, when it grows in the middle ear, that causes conductive hearing loss, and as it is vascular tumor, you are able to hear the pulsations, beta, causing a pulsatile tinnitus. Okay, and as this vascular tumor grows in the lower part of middle ear, or as this vascular tumor grows in the hypotympanum, it basically looks like a rising sun, beta. So otoscopy, when I do in patients of glomus jugulare or glomus tympanicum, it is classically known as the rising sun sign. Otoscopy classically shows us the rising sun sign, beta. That has to be remembered. Okay? Investigation of choice. Very good. So investigation of choice is nothing else but CECT, beta. Why CECT and why not a biopsy? Reason is, we know, beta, that glomus jugulare which is there, it is going to be a vascular tumor like angiofibroma. As it is a highly vascular tumor like angiofibroma, biopsy will be absolutely contraindicated, beta. Therefore, investigation of choice is nothing else but CCT scan. And if I do a CCT scan, on that you are able to see this classical picture. क्या दिख रहा है? Due to this tumor beta, though glomus jugulare or glomus tympanicum is a benign tumor, but it is still locally invasive like angiofibroma. Matlab it can cause a local invasion or a local damage, and therefore it damages this bony septum between the carotid canal and jugular foramen. And this bony septum between carotid canal and jugular foramen, if it is damaged, it is classically known as the Phelps sign beta. So CECT scan which is there, it classically shows you the Phelps sign. ठीक है, तो CECT scan classically shows you the Phelps sign, has to be remembered. Treatment, we know it is nothing else but surgical excision beta. Yes, though it is a vascular tumor and biopsy is contraindicated, still we go for a surgery or a surgical excision. Why? Because pre-operatively we have to go for an embolization. Just like angiofibroma, here also go for a pre-operative embolization and block the main artery of the tumor. If you block the main artery of tumor, the tumor does not receive any blood supply, and therefore there will be minimal bleeding during the surgical removal beta. That has to be remembered. So surgical excision is the main treatment, but pre-operative embolization is mandatory. Clear? Now, यहाँ पे if they show you a tumor like this, यहाँ पे जो दिख रहा है, it is a picture of glomus jugulare or glomus tympanicum. Let me know in the chat box. Here, if both the options are there in the case, glomus jugulare or glomus tympanicum, and this CCT is given, what is going to be your answer? Glomus jugulare or glomus tympanicum? Let me know in the chat box. Bolo. What should be your answer? Anybody? So do remember, any tumor that is medial to this bony septum or any tumor which is inside beta, that is known as glomus jugulare bache. That is known as glomus jugulare. It is arising from the jugular bulb beta. Whereas any tumor which is lateral to the septum bache or which is arising from the middle ear, that is known as glomus tympanicum. Any tumor that is lateral to the bony septum or which is arising from the middle ear beta, that is known as glomus tympanicum. समझे बात? So that is what is important. Medial है, अंदर की तरफ है तो जुगुलर होगा, lateral है, बाहर की तरफ है ईयर में तो tympanicum होगा. This one is basically a glomus jugulare because it is medial to the septum. Hopefully clear. Don't get confused. This was a PYQ in NEET, so I've told you that as well. Now let's talk about lastly hearing aid beta. We know what is the most common type of hearing aid that is used. This is the one which we commonly see, right? What is this hearing aid known as? The commonest type of hearing aid that we use beta, it is which one? The most common type of hearing aid that we use is, you can see the hearing aid is going behind the ear beta. So this is the most common type of hearing aid called as behind the ear hearing aid beta. Okay? So do remember, this is the most common type of hearing aid that is used till date, known as the BTE or the behind the ear hearing aid. Anybody, this hearing aids which are there, they are not going to correct a condition. They are just going to amplify the sound. Because they amplify the sound, that helps in hearing somewhat better. Clear? So behind the ear hearing aid is the most common type of hearing aid which is just known to amplify the sound. If hearing aids are known to amplify the sound only beta, it is going to be which level of prevention? From PSM if I ask you, hearing aids are which level of prevention? Primordial, primary, secondary, tertiary. Let me know in the chat box. Hearing aids are going to be which level of prevention? Primordial, primary, secondary or tertiary? Let me know. It is tertiary level of prevention beta. Yes, I've just now told you they do not treat the hearing loss beta. They do not treat any kind of hearing loss. They just help you in hearing. They just limit your disability or they just help you in rehabilitation. So it is a tertiary level of prevention, not secondary. Secondary is for treatment. Meniere's disease थोड़ी ठीक हो जाएगा hearing aid से. Clear? So it is just for the disability limitation. It is tertiary level of hearing loss. Hopefully clear है अभी बात. चलो. Next important if I talk about, we know hearing aid is never useful beta for a profound hearing loss. Profound means when there is more than 90 decibels of hearing loss. So whenever there is more than 90 decibels of profound hearing loss, you go for this implant or this surgery beta. What is this known as? Let me know in the chat box. So whenever a patient is having a bilateral profound sensory neural hearing loss, That means the inner ear or the nerve has been very severely damaged. That is going to cause a bilateral profound sensory neural hearing loss of more than 90 decibel. So please tell me, beta, in this condition, what is the hearing implant of choice? Very good. So bilateral profound sensory neural hearing loss में cochlear implant is the hearing aid of choice, beta. In this condition, cochlear implant surgery has to be done. Now, what is the prerequisite or what is the condition of cochlear implant surgery, beta? Let me know in the chat box. What is the condition or what is the prerequisite which should be fulfilled if you have to go for a cochlear implant surgery? क्या condition होती है cochlear implant की? Which structure should be absolutely normal or which structure should be absolutely intact? Very good. We know, beta, if I want to use a cochlear implant surgery, the condition is the 8th cranial nerve or the vestibulocochlear nerve should be absolutely normal or should be absolutely intact, beta. Reason, by cochlear implant, we stimulate the cochlear nerve endings, beta. And let's say you have stimulated the cochlear nerve endings, but the 8th nerve is damaged only. Will it help? Obviously not. So 8th nerve should be absolutely normal, बच्चे. ठीक है? Whenever you have to use a cochlear implant, that is important to be remembered. Now, in which condition, therefore, cochlear implant surgery is not useful? Let me know in the chat box in which condition the cochlear implant surgery is not useful, where both the 8 nerves have been damaged. Which is that condition where both the 8 nerves are damaged and cochlear implant surgery is not useful? Very good. Whenever there is a bilateral acoustic neuroma or a bilateral vestibular schwannoma, we know in bilateral acoustic neuroma, both the 8 nerves have been damaged, seen in neurofibromatosis type 2. And in those conditions, beta, cochlear implant surgery will never be useful. समझे बात यहाँ तक? Now, this is the electrode of the cochlear implant surgery, beta. This electrode of cochlear implant surgery which is there, it is placed in which part of the cochlea? Scala vestibuli, scala media or scala tympani? In which part of cochlea you place the electrode of cochlear implant surgery? Scala vestibuli, scala media or scala tympani? Let me know in the chat box. The electrode in a case of cochlear implant surgery, very good. It has to be placed in the scala tympani of cochlea via the round window. It has to be placed in the scala tympani of cochlea via the round window. That is what is important. PYQ itself. It is. Hopefully clear? Chalo. Next, as I told you, let's say if the patient is suffering from a bilateral profound sensory neural hearing loss, but due to what reason? Due to a bilateral acoustic neuroma or due to the neurofibromatosis type 2. So in that condition, if the patient is having a bilateral profound sensory neural hearing loss, cochlear implant is not going to be useful because 8th nerve has been damaged. And therefore, we have to go for this implant over here. Can you see? This is nothing else but called as an auditory brainstem implant, beta. So here what we do, the electrode directly goes in the brainstem area and it directly stimulates the auditory pathway. Okay? Here the implant or the electrode directly goes in the auditory pathway or the brainstem area and stimulates the cochlear nucleus. Okay? The cochlear nucleus of the auditory pathway is directly stimulated. So even if 8th nerve is damaged, we don't need 8th nerve only. We directly stimulate the cochlear nucleus in the auditory pathway, beta. Okay? So that is known as auditory brainstem implant. समझे बात? चलो. And do remember, the electrode in cases of auditory brainstem implant is usually placed in the lateral recess of fourth ventricle. The electrode in cases of auditory brainstem implant, beta, is placed in the lateral recess of the fourth ventricle, which is located in the brainstem area. Lateral recess of the fourth ventricle in the brainstem area, which will stimulate the auditory pathway or the which will stimulate the auditory pathway or the cochlear nucleus, beta. समझे यहाँ तक बात? चलो. Last important if I talk about, beta, is this. What is this hearing aid? Let me know in the chat box, बच्चे. What is this hearing aid that you are able to see in the chat box? This hearing aid that we are able to see in the chat box basically is nothing else but BAHA, beta. Yes, very good. It is nothing else but called as BAHA, that is bone anchored hearing aid. What I do is we directly fix a titanium screw to the skull bone, and to that titanium screw we directly fix this hearing aid, beta. Okay, that is known as BAHA or the bone anchored hearing aid. We know BAHA or bone anchored hearing aid, it usually works via the principle of bone conduction. Yes, it will stimulate the inner ear or it will stimulate the cochlea beta by the process of bone conduction. Okay, not by air conduction. And yes, it is useful in all those conditions beta wherever the pinna is absent or pinna is small. Reason, in all other hearing aids we need the pinna beta, but let's say if the pinna is absent, a condition known as anosia, or if the pinna is small and underdeveloped, that is microtia, in this condition the hearing aid of choice should be BAHA beta. Another condition, if there is problems related to the external auditory canal, let's say the external auditory canal is not well developed, that is external auditory canal atresia, or it is very narrow, external auditory canal stenosis, again we prefer BAHA. And last, chronic ear discharge. If they say from 2 years the patient is having a ear discharge beta, what is the hearing aid of choice? For chronic ear discharge also the hearing aid of choice is nothing else but BAHA or the bone anchored hearing aid. And that was all about your ENT. These are all the important topics that I've tried to cover and tried to touch. Yes, there would be some minor topics which I would have left, and that is because those were not repeated and those have been asked somewhere or the other in the FMG examination prior. Okay, so definitely this would be helping you for the last minute revisions, second or third revisions basically. So this will cover all the important parts of ENT बच्चे, ठीक है? चलो. So tomorrow and day after tomorrow we'll be doing surgery as well. Okay? So be ready for the session. Tell your friends also. If you like, please like the session. Okay? And thank you for attending the session and being patient throughout the session. Okay? Thank you so much. Take care. Good night.